banquet dinner, I suppose. Yeah? Don't be under tension. These judges should be, the performance of all of you would increase with the level of your ground reality. Usha. I take the privilege of calling upon the stage as a chairperson, Madam Dr. Risha Madhuri, Madam. Let's start with the first session, and I request the chairpersons to take these proceedings forward. One bill.
Good morning. This looks like a very interesting session, and I think there'll be a lot of new things in this session.
Be cool and composed as far as the PGs are concerned. I know the consultants have been doing various talks already, so they know how to go on to the stage. That I think your performance as well increases. This appears to postgraduates while your exams as well. There's a slight delay. We are going to check on with a confidential judges match that would be distributed. No one would be knowing about it. So this is as transparent as it could have been with respect to your judging your paper. So don't think that any partiality or anything like that would be done. This is going to be an absolutely transparent process. The performance of these paper, whoever are there, whether the consultant or the postgraduates, would determine the outcome.
Kalakshethram, end plate curettage with indirect decompression and local graft from PSIS and placed sentinel graft before inserting the cage, followed by pedicle screw stabilization using mouse Miami. These are the cases of open. The post-op pictures. However, in open, we had to delay the time to mobilization, considering wide dissection, and they were made to walk only after 15 days. Whereas in endoscopic, again, it was performed by percutaneous fixation under CM guidance after end plate curettage and underscopy visualization of end plate. And local G bone was applied, and wherever possible, the endoplate curettage adequate was done, and post-operative patients were mobilized early at post-op only, and had a significant leg pain relief in the post-operative period. These were made to mobilize on the second day itself, considering the low pain. Compared to the female preponderance was more, and in the both the groups, and L4 L5 was the predominant level with a common distribution of less than 60 years. Grade 2 and grade 1 were considered, and in the grade 1 were predominant, and operative time was comparatively more in endoscopic procedures, whereas blood loss was very minimal in endoscopic procedures. The VAS course again, in the early post-operative period, VAS course was significantly better in endoscopic group, whereas the pain continued until a few months in open group. However, the final follow-up were almost to similar ratio. Fusion was assessed using post-operative X-rays, where the tubercular connections between two bodies after fusion was considered. However, in open, we had 100% fusion because that was subsequently added with a far lateral fusion also, because since we had adequate graft because of removal of posterior spinous process. And far lateral fusion, I think would have still added on to the fusion in case of open groups, whereas in endoscopic, we had one case where a suspected fusion non-union was suspected. Comparing to the complications, in the open case, we had one dural tear, but was packed with Duragen, and however, it healed up with a conservative, no specific intervention was needed. One had a superficial infection in a diabetic patient. However, endoscopic, one patient continued to have transient paresthesia of the root, maybe due to insertion of the cage and its compression. So both open and endoscopic have significant improvement in pain relief, functional status, and radiological fusion in patients with degenerative spondylolisthesis. Endoscopic demonstrated significant advantages in terms of reduced intraoperative loss, blood loss, shorter hospital stay, faster early post-operative recovery, but were associated with a longer operative period. Whereas a long-term functional, again, ODI and VAS course and fusion rates and complication rates were comparable between two groups, even at 1 year follow-up. Endoscopic TLIF is a safe and effective, minimally invasive alternative to open TLIF, which is more morbid in appropriately selected patients, provided adequate surgical expertise available. Now research data also in a long term, both retrospective and prospective, suggests that long term results with respect to fusion are equal in both. However, in the early post op, the pain and mobilization was early, and duration of hospital stay was less. It was assessed with the VAS scores, ODI scores. The key takeaway points would be endoscopic TLIF provide equivalent fusion rates, long-term clinical outcomes compared with traditional open TLIF, while offering significantly reduced blood loss, less post-operative pain, earlier mobilization, shorter hospital stay, and faster return to daily activities. However, it requires a specialized equipment and a greater fluoroscopic exposure, and has its own steep learning curve. These are my references. Video is not playing. Video. Forward. The endoscopic procedure, just I wanted to show the procedure. Sorry that it's not moving forward. Here in endoscopy, we actually under vision, direct vision, the endoplate curettage was done effectively, followed by fixation and achievement of lordosis. And these were mobilized early with a good ODI scores in the post-operative period. Thank you.
Presentation, Shravan. Now may I call upon Dr. Prajwal Ganesh Senthilnathan is going to present a talk on presentation on corocoglenoscapular line, a simple tool to assess significant glenoid bone defect. Dr. Prajwal Ganesh.
Good morning, one and all. In this cozy morning, I'm here to talk about a wonder tool that is helpful in assessing critical glenoid bone loss. I'm Dr. Prajwal Ganesh, representing Tamil Nadu Arthroscopy Society. We all know that the shoulder joint is the most mobile joint of the body, and the stability is conferred by both bony as well as soft tissue components, out of which the bony component is a major part. And we all know that the glenoid surface area, the humeral head forms 4 times that of a glenoid surface area. So each and every part of the glenoid is extremely important for concurring shoulder stability. The critical questions that we should answer while assessing critical glenoid bone loss are: what is the critical bone loss that needs a bony procedure, and how do we calculate the bone loss. As of now, the literary review says there is a decreasing in trend of the threshold for critical glenoid bone loss, and we currently have a critical threshold of around 20% to do a bony procedure. It is moving by itself. First slide, Paul. Back, Paul. Back. Back. Yeah, stop. Can I use this? Sir? Yeah. We have two methods to assess glenoid bone loss, and one is the glenoid index method and the surface area method by Pico, out of which both of them do not consider the antero-inferior part of the glenoid, which is most commonly involved in dislocation. So, and also they underestimate or overestimate the amount of loss. We are here introducing to you a special tool which is simple and advanced, does not require any additional software, and that dictates the treatment. Introducing to you the coracoglenoScapular line. This is a line that joins on a glenoid end face view of a CT. There are 2 points. First point is the antero-inferior base of the coracoid process, and the other point is the anterior border of the scapula where it meets the glenoid. A line joining these two is called the coracoglenoScapular line. We have our own study which we have published in ISACOS in 2024, where we did a study on the normal shoulders, for which we were able to come to a conclusion that the mean area in front of this line is around 22%. So having this, we can hypothesize that the defects that cross the CGS line represent a glenoid bone loss of more than 20%. We took 50 pathological shoulders with a prospective observational study to validate the CGS line as a diagnostic tool for assessing critical glenoid bone loss. We selected patients with recurrent shoulder dislocation and those who have a glenoid bone loss of more than 10% without any prior surgery. And the sample size was assessed to be 50, and we have taken a sample size, and we did CT for all the shoulders with instability and got a glenoid end face view from the radiologist. We drew the Pico method, the best fit circle method, as well as the CGS line, and then found the area in between in front of the CGS line. In this particular example, where you can see that the area in front of the CGS line is calculated by Pico method was 18.9%, and the CGS line, the bone loss is not crossed. So in our study, we had a mean age of 32.26 years, and we calculated by Pico method for all the 50 shoulders, and 24 shoulders had a glenoid defect of more than 20%. And the mean percentage of bone loss was calculated to be 22.1%. After which we compared it with our CGS line and found that out of the 24 shoulders which had a glenoid bone loss of more than 20%, 23 had crossed the CGS line, and in less than 20% of the defect, 25 did not cross the CGS line. So we confer that our CGS line is 95% sensitive and 96% specific. We also did an inter-observer relationship criteria, and we found out that the reliability was strong level of agreement. So these are case examples where we have drawn a line for a first case where the CGS line is the defect has not crossed the CGS line, and by PICO method it was 16% defect. And in the second one, the defect has crossed the CGS line, and by PICO method it was 27% defect. There is a similar example. With this study, we confer that the CGS line is an effective tool for screening and identifying critical bone loss, and there is more emphasis on the antero-inferior rim of the glenoid, which is more important for dislocation. And we do not need any additional software to measure the glenoid bone loss. So we conclude that assessing the glenoid bone loss is critical to decide on the surgical approach to a patient, either to do a soft tissue or a bony procedure. And the patients with a glenoid bone defect, where the defect has crossed the CGS line, should directly go for a bony procedure. Thank you.
Thank you, uh, Dr. Prajwal. Now we go on to the third talk by Dr. Nishant Muppa on modified digital dependence score and neck-related disability in adults aged 18 to 45 years. It's a cross-sectional study.
Good morning, everybody. Good morning, Jain speakers. I'm Dr. Nishant Muppa. I'm an associate professor at Mallareddy Medical College for Women, which is a constituent of Mallareddy Vishwavidyapeeth. So I'll be doing a small talk on modified digital dependence score and neck-related disability in adults. Slides. Can you see? Sorry for the glitch. Again, I'm Dr. Nishant Muppa. I'm an associate professor at Mallareddy Medical College for Women, which is a constituent of Mallareddy Vishwavidyapet. On the outside, I would like to thank Tosa and Oasiscon for giving me this opportunity. And again, these lovely girls who have helped me get on with this pilot project. I would mention their names. So, device-related neck symptoms are now a routine presentation in young adults. The common explanation is because of prolonged device use in a flexed or a forward neck posture. But the problem is lots of papers have described this as a text neck problem. And when it comes to the functional outcome, it is by neck disability index. But none of us are able to catch the behavioral patterns of the teenagers, which are also influencing this problem. So we've been in a pursuit of getting to the behavioral pattern of the individuals in this. So this is the neck disability score. So usually when we take history, it's about how many hours are you on the phone or the laptop, but the duration is a crude measure. Two people with the same hours may use the device very differently. So that is not exactly depicting why this problem is coming. And when you ask the patient his posture, everybody is not able to quantify or give a perfect description about a comfortable posture. And when it comes to do you take breaks, the problematic engagement may include difficulty stopping, repeated checking, emotional dependence with the device, and its interference with work or studies not being quantified. So we have done a cross-sectional study, and we had a population of 921 individuals screened. Finally, we have got an adjusted model of 658 people. This was done in last December in people around 18 to 45. And people with previous neck injury or surgery or migraine were excluded in the study. So what exactly is modified dependence score? It is already a documented score by CAPI, and they also include the behavioral patterns like loss of control, which means you're unable to reduce the usage of a device or unable to control the duration of a particular device, or preoccupation or context. Because of this device, you're unable to focus on your work and you keep checking it in between. And the functional interference with the opportunities that you miss, the classes that you are not listening to are also taken as functional interference. Emotional dependence has also been there in this, and habitual attachment. So all these points have been graded, and all these 18 items based on the score has been combined with the neck disability index, and finally has been given a diagnosis. So what we actually did, we converted this broad complaint of neck pain in young individuals and defined the outcome functionally by neck disability index. Also tried to add on to the behavioral patterns which cause this by taking into MDDS and analyze them together and finally got up with an output. So of the sample size, if you see, relatively 45% were not in any sort of issue, but 54% of the population was having some sort of neck disability because of prolonged usage. And the adjusted prevalence ratio is 1.91. So the signal was behavioral, not simply time-based or self-perceived posture-based. A device use history based on only hours per day may miss the clinical relevant pattern of use. The modified device disability score may reflect difficulty disengaging, persistent checking, emotional attachment, and functional interference. The result is useful for the clinical questioning and future research, not just diagnosing someone with digital addiction. So in this young convenience sample, neck disability index was common but predominantly mild. In the 18-point MDDS was only a consistent adjusted correlate of disability, including across sensitivity analysis. A daily device duration, break frequency, self-perceived forward head posture was independently associated overall in the same model. The limitations of my study is convenience, electronic recruitment, young and medical college based population was chosen. So that is the sampling problem. And design was a cross-sectional thing. and measurement was self-reported. Questionnaire was given, so there is a bias, common method bias, which could be possible, and there is residual confounding, where we did not cater the sleep, stress, physical activity, and workstation design into this. Thank you.
Thank you. Now, may I call upon Dr. Vinay Kandukuri? He is going to present a paper on early outcome of protean nail, indigenous design of intramedullary nail in unstable diaphyseal fractures of femur and tibia. Dr. Vinay Kandukuri.
That's it. Good morning, respected seniors and my dear colleagues. I thank Tosa and Oasis for giving me this opportunity. I am here today to discuss about a new design of intramedullary nail. It is mainly designed to tackle two main problems, that is metadiaphyseal junction fractures which are unstable and segmental fractures. As we know, metadiaphyseal junction fractures have more than 20% of non-union rates. Because of long lever arm and wide medullary canals, there is macro motion at the fracture site leading to non-unions. And in segmental fractures, as we all know, one fracture unites and the other doesn't. It happens more than 30% cases. That is because, as we can see, the pictorial representation of wide medullary canal and macro motion at the fracture site, despite having 3 locking screws. And this is fluoroscopic demonstration of macro motion at the fracture site despite having 4 locking screws. So in this evidence, there is enough evidence to say, especially in Romans and Hessman textbook of nailing, they said that intermediate segment is a floating segment and is rotationally unstable because of missing interlocking screws in the intermediate fragment. This particular line, when I read it, that is when I got the idea to introduce holes in the intermediate segment. This is one case where a metadiaphyseal junction fracture has gone into non-union, for which revision surgery with opening the fracture site and adding an additional anti-rotation plate with bone grafting had to be done. This is a commonly performed procedure, but it creates more morbidity and financial burden to the patient. This is again a pictorial representation where wide medullary canal causes toggling effect at the fracture site, but by adding another screw in between, it reduces the working length, thereby providing stability to the fracture site. So what are the advantages of this nail? We have intermediary locking holes where we can control working length depending on the fracture pattern. Mainly working length is only discussed with plates, but never in a nail. So this nail has a property of load sharing combined with control of working length. And it is a modification in a regular nail, so it doesn't cost anything extra. It is going to cost the same. So first, anybody who has seen this nail will ask whether the holes will make it weak or not. The first thing we have done is send it to a NABL accredited lab to test it. They have tested for 2 million cycles for axial loading, 3-point bending and torsional strength, and they have given us a certificate saying that all these tests are within the load limits of the regular nail. And this is a video representation of when we add a screw, you can see that the macro motion is converted to micro motion. So we have done a preliminary series where we included metadiaphyseal junction fractures, segmental fractures in all age groups of femur and tibia. The exclusion criteria were intra-articular extension fractures and associated neck of femur fractures. This is one example where distal third, these are very notorious for non-unions. Now, once we add a screw in between, the decreased working length provided more stability at the fracture site, going into complete union. This is another case of subtrochanteric fracture, where we have done recon nailing. This nail has a recon option also. And we have introduced an intermediary screw, decreasing the working length, and it has gone into union. This is a segmental fracture where we have fixed the intermediate segment, and that has led to good stability and union. This is a femur fracture where we have stabilized the segmental femur fracture, where we have stabilized the intermediate segment. This is one of the initial cases which we have done. This is a perfect example of a non-union resulting in macro motion at the fracture site of metadiaphyseal junction. As we can see, immediate post-op, there is a beautiful reduction, but over a period of time, it went into non-union just because of macro motion at the fracture site. Usually in this scenario, we have to open the fracture site, either exchange nailing or put an anti-rotation plate or bone grafting. But what we have done is, we have just exchanged the nail and added a screw. No opening the fracture site, and that resulted in a stability, and it went into good union in 4 months. So results, we saw in these cases that there was better stability and better control of motion at the fracture site is achieved by decreasing the working length. An extra locking screw near the fracture site reduces the working length. And we can use this as a primary setup also, not just for revisions, so that better stability gives better unions. This is, we do accept that the study has some limitations. This is a preliminary case series of only 20 cases. Still some cases are underway. We are still waiting follow-up. Till now we have done more than 35 cases, and some are yet to come for follow-up. There is no control group. We didn't have a comparative study with the standard nail. And to establish this theory, we have to have a larger prospective randomized control studies, which are actually in process. So the take-home message is, in metadiaphyseal junction fractures of femur and tibia have suboptimal stability. So stability at the fracture site is of extreme importance. Optimal stability can be restored by decreasing the working length and using an intramedullary nail with control of working length, so that we can weight bear early and achieve unions. The protean nail combines working length principle of a plate and load sharing nail. This particular design I dedicate to my professor A.S. Rao, who has been instrumental in guiding me. Because of his thesis topic he gave to me, my thesis topic was implant failure in long bones. That is where the research and the idea has started. And after 4 years of research and doing cases, we have reached to this level. Thank you.
Thank you, Dr. Vinay. I now call Dr. Amarnath Surat for his talk on trochanteric rotation osteotomy, a modified surgical technique in the management of avascular necrosis of the femoral head, an Indian perspective.
Respected chairpersons and delegates, good morning. Today I would like to share with you our experience with modified Sugioka osteotomy in AVN of the femoral head. This is an Indian perspective. So the study is a prospective study with a retrospective cohort. And in this era of orthoplasty, you might wonder what is the need for an osteotomy. And there's a definite subset of population where osteotomy is still very relevant. So the problem is the young patients getting COVID and avascular necrosis in the 25 to 35 age group. Some of them were manual workers with low socioeconomic status. And for these people, orthoplasty was not an option, both either financially or vocationally. So we'll have this roadmap. We'll talk about all these aspects of the procedure. And our inclusion criteria was all the patients who are below 40 years. Non-traumatic AVN only was used. They were Ficca Tarlet stage 2B and 3. The lesser stages and the advanced stages were treated by other methods. We used the Kerbal angle and chose an angle between 190 to 240 degrees to include in the study, because the Kerbal angle gives you the volume of the defects, its location, the operability, and the direction of rotation. Sugioka in 1978 first described this procedure in AVN. He used a lateral approach with a trochanteric flip, did a circumferential capsular incision, followed by the first cut was distal to the intertrochanteric ridge, and the second cut was proximal to the lesser trochanter. Parallel K wires were passed into both the fragments and they were rotated so that the avascular area was rotated out of the weight bearing zone and normal bone was brought into weight bearing. How much rotation to give? If you do an anterior rotation, it's limited to between 60 to 90 degrees, and a posterior rotation we can do a greater degree of rotation because the vessels entering the femoral neck are likely to be stretched when you do an anterior rotation. Western literature has shown really bad results with Sugioka, and that's probably the reason it has not become very popular with us. So why were Sugioka's results not replicated? One is not only the manipulation of the vessels, but also Western literature. I have seen the publications. They all showed valgization of the neck, and two, they allowed early weight bearing. We will come to the significance of early weight bearing later. So what did we modify? First thing is we did a safe surgical dislocation described by Gans. And when Sugioka did it, the safe surgical dislocation had not been described at that point. After doing a trochanteric flip, the anterior capsule was incised by a Z-shaped incision and the femoral head was dislocated outside. Once dislocated, the vascularity of the femoral head was assessed by drilling it with a 1.6 mm K wire. You will see that the vascular part of the femoral head will bleed, whereas the avascular area will not bleed. And the vascular part has to be rotated into the weight bearing zone. And the other thing is, we have to always keep in mind that the medial circumflex femoral artery supplies almost 3/4 of the femoral head. And because of that, our incision, that is the incision at the trochanteric ridge, is taken as lateral as possible to avoid injuring the vessel. So the sequence of cuts, we reverse the sequence of cut. The hip is first dislocated, and then the cut proximal to the lesser trochanter is made, followed by the cut between the intertrochanteric line. Once that is done, the rotation is done as described. Sugioka used cancellous screws to fix the osteotomy, but we thought that the cancellous, a more stable fixation can be provided by using a DHS screw. And depending on the size of the bone, we used a pediatric DHS also. And all of the avascular area need not be rotated outside the weight bearing zone. A study showed that if more than 35% normal bone is there, it is sufficient to prevent further collapse. If you see in this picture, the yellow line indicates that is the avascular area, and about more than 50% of normal bone is there under the weight bearing zone. And the other thing is the inclusion of some varus into the osteotomy. Usually we tend to put about 20 degrees of varus that also will medialize the defect and get it out of the weight bearing zone. And here again, you will see that the red area marks the avascular area, and almost 75% of the femoral head is having normal bone here. So the importance of non-weight bearing, almost patient has to be about 8 weeks of non-weight bearing or partial weight bearing. Sugioka mentioned that the non-weight bearing trabeculae are rotated into the weight bearing area in these bones, and hence about these trabeculae could get restructured before you can bear full weight. That's why that's the importance of delaying the weight bearing in these patients. Our average age was 31.3 years, and the etiology was post-COVID in 71%, grade 3 in 73%, and the Kerbal angle was 227 degrees average. And the Harris-Hip score initially was 46.5. It improved to 82 in about 12 months' time. After 12 months, we didn't get a lot of improvement. And this corresponds well with the other studies. Only thing is we could not achieve the success rate of Sugioka. We fell short of it. And the complications were 3 patients underwent a total hip arthroplasty. 2 patients had intra-articular BMAC, and surprisingly they improved. And 6 patients developed a little bit of osteophyte at the superior part of the femoral head, which we treated. I mean, they had symptoms of FAI kind of symptoms. They are under observation. Here are some of the cases. This is a preoperative X-ray. Here showing the large avascular area. This is 3, 6, and 1 year follow-up. If you notice the 1 year follow-up picture, you will see that the trabecular pattern of the femoral head is improving close to normal. This patient had a failed cord decompression on the left side, which was treated by THA, total hip arthroplasty first, followed by an osteotomy on the right side. This is a follow-up of 24 months. We see that the femoral head has maintained its sphericity, and the question in our minds will be, is the vascularity of the head still preserved? We did a bone scan, and we find that the femoral head vascularity is intact, and we did not damage the vascularity during the procedure. This is a 33-year-old male, Ficata Arlet 3, and this is the osteotomy immediate postoperative, and you can see the amount of varus that we have incorporated here. This is a 2-year follow-up. And finally, patient came to us for removal of metal at 4.5 years. And surprisingly, we found that the varus also got corrected by remodeling. And this is a young lady of 21, whom I was talking about. These patients getting a small osteophyte at the upper superior part of the femoral head, and she was having some symptoms of femoroacetabular impingement when she's trying to squat and things like that, but she was able to do her daily activities, and hence she's under observation. So the take-home message is that proper case selection and counseling is very important, because a neighbor of this patient for osteotomy would have gone for a total hip arthroplasty and would have been walking very fast. And this fellow is disappointed. We have to tell them it's going to take a longer process. And one should be familiar with safe surgical dislocation and fixation of the osteotomy. And we have to adhere to the post-op protocol. I definitely agree that it's a steep learning curve here. And the takeaway again is that the femoral head need not always be replaced. It needs respect, rotation, and time. These are my references. Thank you very much. If there are any questions, I'll take them.
Have a question and answer session. And sir.
Madam? Okay.
Thank you, sir. Thank you, Amarnath, sir. And now may I call upon Dr. Muhammad Jalal Mohinuddin, and he'll talk on outcome of uniplanar angular deformity correction around the knee using osteotomy rule 2 and external alignment devices and a prospective study. Dr. Jalal.
Good morning, everyone. I'm Dr. Muhammad Jalal Mahiuddin. It's a prospective study which shows the outcome of uniplanar angular deformity correction around the knee joint using Rule 2 of osteotomy and external alignment device to check the alignment. Knee joint alignment changes with the age. It is varum at the time of birth, decreases till age of 24 to 36 months and get straight and start going into valgus, peak valgus at 6 years, which is around 11 degrees. It decreased to normal at the age of 11 years of age. So deformities around the knee joint is one of the commonest presentation in pediatric orthopedics outpatient department. So we need to take anterior posterior projection full length standing radiograph, which is a primary tool for evaluating the deformity and alignment. And we need to consider various axes to calculate the alignment. So various axes which we use to calculate the alignment is mechanical axis of the lower limb, tibiofemoral angle, anatomical angle of tibia and femur, mechanical axis of tibia and femur. So how will we analyze? We take standing stitch view, mechanical axis deviation. If it is moving medial side, it is a varus deformity. If it is going on the lateral side, it is valgus deformity. So to localize the bone affected with the deformity, we either use mechanical axis or anatomical axis. That is mechanical lateral distal femoral axis or anatomical lateral distal femoral axis, mechanical medial proximal tibial angle or anatomical medial proximal tibial angle. So angular deformity around the knee either originate from tibia or femur or both, and it required precise correction based on location of deformity. So restoration of anatomical axis is essential for achieving optimal alignment. So this is an external device which we can use to align the anatomical axis. So as a distal and a lateral distal femoral axis 80 degrees, so one is of 80 degree, another is 90 degree for medial proximal tibial angle. This device facilitates accurate deformity assessment and correction during the surgery at it is radiopaque and we can sterilize it. So osteotomy rule to allow correction while providing adequate space for hardware placement when the center of rotation, that is scora, is very close to the joint line. So this is a diagram showing the rule 2 osteotomy, where we are doing osteotomy distal to the cora, but using center of rotation correction at the cora. So it needs angulation along with some amount of translation. So using this external device, to our knowledge, there is no previous study which is using any similar dedicated external device for measuring the alignment. So aim of study to evaluate the outcome of angular deformity correction around the knee joint using osteotomy. Rule 2 in conjunction with the external alignment device. Objectives are to find out bone involved with varus and valgus deformities, to evaluate time for union after osteotomy, look for any complication and need of any secondary procedure during the course of recovery. So it's a prospective study over the 50 patient. We excluded the patient with open physis. All uniplanar deformity were included, mature skeleton, and there is no associated arthritis patient are excluded, and deformity due to any pathology was included in the study. So we did clinical examination of patient, then took stitch view of lower limb hip to ankle, analyze on the paper and mark the anatomical and mechanical axis, and preoperatively we tried to get the correction on the paper. The intraoperatively similarly we try to replicate the same thing to identify cora and osteotomy and stabilization with the implant. So this is one picture where we have corrected the genu valgum. In the first thing, we have drawn the X-ray on the paper, marked the anatomical axis of the femur, then localized the cora, did the osteotomy, did little translation and alignment. So on table, in the upper picture, we have checked the deformity of the tibia, which looks normal as anatomical axis of tibia is maintained in 90 degree. In the lower image, we have aligned the distal limb of the instrument along the joint line and pointed the cora. We did osteotomy and correction. The same way we have used for, excuse me. Okay. For the genu variant correction, we have drawn the X-ray picture on the paper. We marked the osteotomy and along the anatomical line, Cora, they did osteotomy and translated. So the same thing we did on the patient. First fibulectomy, then followed by marking of the Cora, then osteotomy, then alignment and fixation. Results were we out of 50 patients, 5 were male, 45 were female. It was varus deformity in 20% patient and valgus deformity in 80% patient. Age from 13 to 25 degree with mean age of 19 years. It was varus deformity, tibia was involved in 10 patients, femur, valgus deformity, 35 patients were femur, and the remaining 5 were involvement of both tibia and femur. So it was nutritional rickets in almost 90% of patients, hypophosphatemic rickets in 6%, and renal rickets in 4%. There was bilateral involvement in 20 patients, unilateral involvement in 10 patients. Pre-operative angle variation, it was ranged from 20 to 35 degree with mean angle of 28 degree. After correction, the range was between -3 to +5 degree and mean angle of 2 degree. And PAID t-test p-value was less than 0.5, which is statistically significant. This is the pre-op and the post-op X-ray, pre-op and post-op picture of the patient. Union was achieved in all patients. In 2 cases, we need secondary procedure of dynamization. Implant use for the femur, almost in 38 patients, we have used locking DCP. In 2 patients, we used intramedullary nail. For tibia, 4 cases, Elixir was used. 2 cases, we used suprapatellar nail and plate for 4 patients. So there was no implant-related issues other than the palpable implant. There was no infection in any of the case. Knee range of movement attained within 3 weeks to full range. Delayed union in 1 tibia which need dynamization. There was transient EHL weakness after a fibulectomy which recovered fully. No CPN palsy in any of the cases. 3 patients had additional patellar instability which need realignment procedure when we are doing osteotomy. Discussion here is angular deformity of lower limb alters biomechanics of joint. So these abnormal forces predispose joint to destruction. So isolated mechanical axis correction sometimes straighten the limb but create secondary deformity. So anatomical axis alignment align mechanical axis too. Osteotomy rule 2 allows adequate room for implant placement when Cora is very close to the joint. Implant of any choice, if used appropriately, will give good result. So uniplanar angular deformity correction around the knee joint using osteotomy rule 2 and dedicated external alignment device for femur tibia enable precise identification of Cora and reliable restoration of anatomical alignment. Anatomical axis restoration of individual bone automatically align the mechanical axis. Any implant, either external or internal, either surface or intramedullary, when used appropriately, will act as an ideal fixation device. These are the references. Thank you.
All the 6 speakers, please come up to the stage. Dr. Jalal, you can please stay here also. Each speaker will have 2 minutes to answer the questions from the audience and the judges. Each speaker time is limited for 2 minutes only. We'll start one by one. Since Dr. Jalal is already here, we can start with him. Any questions for Dr. Jalal? Dr. Jalal, please sit down. Okay. You can go to the. Any questions from for Dr. Jalal from the audience or from the thing? If I can ask you a question on this, how was it different when you were managing femur using your external device as compared to when you're doing it for tibia?
For femur, if you are using external device, the stiffness chances is more, ma'am. I mean, when we are using LRS system to correct the for the femur, patient is losing the knee joint movement sometimes, ma'am.
So When you're using the external fixation device, is only for identifying the cora. It does not assist you in any other way.
Yeah, just to identify the core. For one or two patients in the beginning, we use it for correction of the deformity as a permanent stabilization, but it was giving stiffness. So we use external device because I follow your method only, ma'am. We put two shank pin, one distal and one proximal to the osteotomy, then provisionally fix with the LRS, and then apply the plate after attaining the required anatomical axis.
Any other questions? To Dr. Jalal, yes. Okay. Since there are no other questions, we'll go on to the next speaker, Dr. Shravan Kumar. Dr. Shravan Kumar's paper is on TLIF, open versus endoscopic. Any questions for that? In your practice, are you doing open now or are you doing endoscopic?
Both, madam,
So
because
when do you choose open and when do you do
when
endoscopic?
I require more than one level, because exposure is limited, because in the endoscopy you have a limited vision where you can't do adequate second level also. So more than one level or two levels, usually open is better because you reach a long segment of vision when you are doing more than one level. Whereas in a single level, a sentinel graft with minimal bone graft is sufficient for union.
Does pre-existing neurology affect your decision making?
Yeah, madam. Even if it is pre-existing, the only chance would be for the decompression aspect, whereas not the fusion aspect. But when it is a pre-existing neurology, we see to that the traversing route is also decompressed adequately.
But endoscopic or open?
We have done in both, madam.
Oh. Any other questions to Dr. Shravan? If there are no questions, then we'll move on to the next speaker, Dr. Prajwal Ganesh. His talk was on coracoglenoScapular line, based on an already previously published paper by him, and to assess the amount of glenoid loss.
The published paper was on normal shoulder.
Exactly, but it's similar
Yes,
based
similar.
on a previous. I'm just giving credit to your previous
Thank you,
paper. Any questions for him? Any questions from the judges, please? I think your paper must have been so crystal clear, but I think it is very useful way, and I'm quite happy to see that you can before itself.
For any orthopedician can easily choose the procedure. We need not have any software or anything. Just an OP basis, we can decide whether to do a soft tissue or a bony procedure.
Thank you.
Thank you.
Next speaker was Dr. Nishant Muppa, and his talk was on modified digital dependence score and neck-related disability in adults between 18 to 45 years of age, cross-sectional study. Dr. Muppa is not here. Dr. Nishant. Okay, I think since he's not here, we'll go to Dr. Amarnath. Trochanteric rotation osteotomy. I thought since your patients were doing well, why do you say that still you will consider THA and not this surgery in eligible patients?
Madam, thing is, the rehab part is very long, and we have only a midterm follow-up about 4.5 years. In an affordable patient, the THA survival in all the registries is easily 20 years plus. We have about longest follow-up is about 4.5 to 5 years. And I'm picking up people who at any cost cannot have a total hip arthroplasty. So that is the reason, madam, because nowadays the results of total hip arthroplasty are pretty good. So when a patient can afford it, quick return to normal activity, I would choose a THR.
Okay, if I was in that age group, I would have actually preferred to have had a rotation osteotomy and keep my own hip. That's why I asked you why you were condemning everybody to having THR only.
No, I'm not condemning anyone, man. I'm making sure that a proper case group is selected.
Any questions from the audience? When you rotate that, when you make a more distal cut and you rotate, do you have a big bump anteriorly, and how do you get rid of it?
Not at all, man. Yeah, what happens is when you rotate anteriorly, the proximal part is a little elevated. So what I do is I nibble off the bump and put it in between the osteotomy site for better union.
So you do get rid of that bump.
Yeah,
because I was
I'll get rid
wondering
of
how
it. Yeah.
people will have severe impingement when trying to.
Yeah. So I get rid of it and put it at the osteotomy site, madam. Actually, what happened was this nitty-gritty, I could not, I prepared for a paper for 8 minutes and the organizers were good enough to make it 10 minutes. So I didn't include all these smaller parts.
Good anyway.
Thank you.
Paper was good. Thank you. Any questions from the audience? Thank you very much.
Thank
Thanks
you.
to all the speakers. Very nice presentations. And I don't do adult orthopedics, but I really enjoyed the session. Thank you very much.
Now we request the chairpersons to come forward. We want to do a small felicitation. Thank you.
We have been operating this nail for the past 2 years, and we have follow-up of 1.5 year. And in our case series, 3 patients have got their implants also removed.
Generally, how many years I have to elapse to establish a procedure? That's what I want to know.
I didn't understand that question, sir. I mean,
No, suppose a procedure is introduced 1 year back.
yes,
There can be some failures, there can be some success.
exactly, sir.
See,
That's
I
what.
have operated one case on hip. After 4 years, he developed avascular necrosis. So, what is the time duration you want to see for this?
Usually,
results?
fracture union happens within 3 to 6 months. Any nail, any successful fracture, I think more than 1 year of waiting period is more than enough, I guess.
Thank you.
Yes.
Thank you, Dr. Vinay. I'm so sorry I missed out because of the jump in the.
Excuse me. I got one more question.
Yes.
I mean, the essential difference between a plate and a nail is torsional strength,
Yes.
rotational strength.
Yeah.
I mean, the plate is stronger compared to the nail.
Yes.
How can you justify putting a single screw in the middle segment to say that it is stabilized? Just a single screw in the middle segment, and you're saying it is as good as plate.
I'm not saying it is as good as plate. I'm just saying that it is.
It is going to stabilize.
We are going to introduce the working length concept of a plate in a nail. So when we put one screw, the mechanical strength of including the torsional strength, it is still maintaining. When we sent it to the mechanical testing, they have done the torsional strength in a bone model while putting a intermediary screw that sustained up to 100 newtons of force. That is 10 kilograms of torsional, which is actually the standard nail requirement of torsional strength for a standard nail is only 55, for which we have tried up till 100 and it still withstood.
That's fine. Thank you.
Yes. Yes, sir. We don't need a dynamization because all the holes are here dynamic holes. So usually in segmental fractures, when we do, we fix static proximally and static distally, and we put a dynamic screw in between. For metadiaphyseal junction fractures, the femur you have seen, there is only one dynamic screw in the proximal, one in the middle, and three in the distal.
So all are dynamic.
All are dynamic except for the distal.
But if you want to do, means it's only few but if you want more dynamization,
Dynamization maximum of 5 is allowed. Other than that, we don't need. So this, I think, 3 to 4 of movement at the fracture site is more than required for union. We don't need more than that because more than that is what causes the non-unions.
thank
Dr.
you.
Vinay, one more
Sir.
question for you.
Sir.
What is the period of immobilization, or when do you want to mobilize the patient for?
Mobilize immediately, sir. I mean,
Immediately.
partial weight bearing from day one. Yes, thank you.
Thank you. It was an excellent our session of consultants. Now we go to the next session, that is pediatric orthopedics. I request Dr. Raji Reddy sir, Dr. Jagan Mohan Reddy sir to kindly chair this session. So Jagdish sir is also here. We want Jagdish sir also to be here. Run sir. Raji Reddy sir, please. Sir, three of you can share this session, sir. All of you are seniors to us, and we respectfully want to involve all of you here, seniors, to share some session so that it gives a more dynamization to our. Sorry. No, just. Pencil.
Good morning once again. Now 2 days I have been seeing only the orthoplasty and trauma. Now is the time for the real orthopedics, which is called now pediatrics. Do you agree or not? Real orthopedics only pediatrics, only orthopedics. All these days I have been seeing all replacements, fractures, and tumors. Now we are entering what's called the pediatrics, which is the real orthopedics, what I think. That's pedia, right? Okay. Shall we start with the session? Please. Now the first speaker. Who is it? By Srikant. Now may I request Srikant to come up to the dais, please? Srikant is Skefi. You want to talk? Skefi. His topic is skip and grip regarding the Skefi. Please, go ahead. Acha, I know, I know. Okay. Oh, the time is only for 8 minutes, right? Okay.
I've been given a topic slip and grip, the race to save Skiffy. Very catchy title given by the organizers. Our aim is in a slip capital femoral epiphysis, our aim is to save the hip by not allowing it to go for AVN and avoid FA, femoroacetabular impingement. Skiffy, as the name suggests, is slipped capital femoral epiphysis. The epiphysis slips posteriorly and inferiorly. Actually, it's a misnomer. What actually slips? I have a pointer. What actually slips is the metaphysis. It slips anteriorly, superiorly, and the limb external rotates. And usually it occurs in pre-pubertal and adolescent age group. It's a three-dimensional deformity. As you can see in the 3D picture, the femoral epiphysis is actually behind the femoral neck, and it is inferior relative to the. Yeah, thank you. Yeah, and it is inferior and posterior. Most of the times, it is posterior to the neck. What causes this actually? If you see the histological picture, in normal histology, the zone of hypertrophy, there is a well organized architecture in the normal physis. But in a case of a slipped capital femoral epiphysis, the epiphysis here, the hypertrophic zone, the chondrocytes are not well organized, and that is the weak point where the slip occurs. And as you can see, a lot of extrinsic factors are also there where femoral retroversion, increased angle, increased slope of the physis, they contribute and cause slip. And we have to first look whether it is acute or chronic. In acute, it is less than 3 weeks. Chronic, it is more than, any case which symptoms more than 3 weeks, it is chronic. So actually, the analogy here is ice cream on cone. An ice cream on the cone doesn't slip suddenly. It happens over a period of time. Like it, there will be, it melts at the junction and falls. It occurs as though it's a sudden event or a fracture, but it is not. Actually, it occurs over a period of time. There is nothing called a acute slip. It's always acute and chronic. You have to go into the history in detail. So it is, the point here is slip differs from a transphysial Delbet type 1 fracture in that it is a high energy trauma in a young child, while slip it is a low energy trauma in a adolescent child. In a Delbet type 1 fracture, it is a abnormal load on a normal physis, and here is a normal load on abnormal physis in a case of Skiffy. Look at this example. This patient came to us like this, where he came in an acute unstable situation. But just look at the 2 days ago, his X-ray was like this. If only someone had picked this up and drawn something called Kleene line, also called Trithoven sign, a tangential line drawn along the neck, it in a normal X-ray it passes through the epiphysis, but in a slip it goes tangentially. It is more clear on the lateral X-ray. In this stage, the treatment would be just pinning, but here it is a catastrophic event, more chances of AVN and bigger surgery. And again, next classification, is it stable? Is it unstable? A slip is always stable, said to be stable if the patient is able to walk with or without crutches. If the patient is not able to walk, even without crutches, then it is classified as unstable slip. Unstable slip has more high risk of AVN, requires more urgent surgical intervention, unlike a stable slip which has lesser risk of AVN. And the third thing is how severe is a slip. The slip angle is calculated usually in the lateral view, and it is the angle between the epiphysis and the shaft, epiphyseal shaft angle. A perpendicular is drawn to the epiphysis and the shaft. This angle is compared to the normal side. The difference in the angle is called the Southwick angle, and the difference is less than 30, it is mild slip, 30 to 50, it is moderate slip, and more than 50 difference, it is severe slip. So is it acute or chronic? Is it severe, or is it stable or unstable? These three things are important. And coming to clinical examination, usually they are adolescent boys, and more than 50% of them are in the high BMI, more than 85 percentile. Something called the Drehman sign. On clinical examination, when you flex the hip, it automatically goes into external rotation and abduction by flexing. So that happens because of the sleep. And this is a very subtle finding. And most important, the red flag sign. The red flags are any adolescent, or for that matter, even in younger children with knee pain, they should be examined for hip, because we should not miss a chronic slip. And Drehman sign is very important sign. And all the slip cases, they go for endocrinology department, because we want to rule out endocrinopathy. If the patient has endocrinopathy, probably he will need a contralateral pinning also. And most important, we'll get a thyroid profile and complete metabolic profile, calcium, phosphorus, alkaline phosphatase, vitamin D. And if there is a suspicion of hypogonadotrophic hypogonadism, that kind of picture, serum cortisol at 8 a.m. And children who are having on growth hormone therapy are more susceptible to sleep and parathyroid hormone. All this endocrinological evaluation is a must in every case, especially in atypical cases where the child is very young, less than 10, or very old, or the older side more than 16, or his height or weight is below the 10th percentile. Timing of surgery, they say acute unstable sleep is a surgical emergency and slipped and should be fixed within 24 hours. But it is not always possible to fix within 24 hours. And this is classical teaching that 24 to 7 hours is an unsafe window, but it is questioned, debatable. The point is to do as early as possible if it is an acute unstable sleep. What are surgical options we have? In situ screw fixation, in situ screw fixation with or without osteochondroplasty or so-called bumpectomy, which you can do by open procedure, or if you have trained, you can do arthroscopically, or and incidental or gentle reduction, so-called controlled repositioning, because we should not try to get a complete forceful reduction that will jeopardize the blood supply. And Parsh method of open reduction are that gentle technique. And in severe cases, capital realignment, very exciting surgery by modified Dunn operation, or anterior open reduction without dislocation. We can go with the anterior approach dues or capital osteotomy. I'll go through all this by case examples. This is an in situ pinning example. Look at the right side. He has got a mild to moderate slip. So we did only in situ screw fixation. And again here, if the slip is very, very severe, this entry point will go way much anterior. So much so that if you want to try to go perpendicular to the physis, the screw head itself may cause impingement. So to avoid this, there is a paper by Dr. Prasad Gauraneni where he has described oblique in situ screw fixation, where the target is the center of the epiphysis only, but the screw will not be perpendicular to the physis. If you want to go perpendicular, your entry point will be somewhere here. So we can as well go start slightly laterally, anteriorly, and target the center of the epiphysis. And but we should see that on either side of the epiphysis, there are 2 to 3 screws at least. And it is controversial again whether to use half threaded or fully threaded. That's a different debate. Next, Parsh method. Parsh paper, where they have treated acute unstable sleeps. They did ultrasound and see whether it is effusion is there or not. And by minimum anterior approach, it's a gentle manipulation with the finger and reduction. And the aim is not to get a complete full reduction. Get as much reduction as possible.
It's time up now.
Okay, sir. I'll run through the slides. This is an example of acute and chronic Parsh method. Controlled repositioning, so-called controlled repositioning, where there will be gentle manipulation. This paper from Ganga, where interrotation of the hip is done gently as much as possible, and then flexion is done. It's a combination of Ledbetter and Whitman's technique, which we use in routine neck fever. And the hip is taken to 90 degrees and completely extended again. This capital realignment by modified and very exciting surgery. A 12-year-old child. This was how he was walking. As you can see, external rotation deformity and extension deformity. FIR is negative. This is the slip angle. MRI, he showed this Yeah, this is, we have seen modified done method, but modified done, it's not simply a safe surgical dislocation, it is much more.
Yeah, please go through the slides, sir. Already
Okay,
over.
sir,
So
okay.
just run, please.
Yeah.
Yeah.
I think people have known
Yeah.
it. So can you, any questions from the audience regarding this? Anyone?
And then the head was bleeding.
Right. Okay, sir. Thank you.
Dr. Srikanth,
Okay, sir.
you could be a young surgeon. How many cases have you seen till now?
Let me run through, sir.
It doesn't matter.
Subcapital osteotomy. This is how we do subcapital osteotomy by anterior approach.
Okay.
So he's
Let
asking
me go
some
to
questions.
control slide. Yeah.
All these are there in the book. Doesn't matter now.
Yeah, yeah.
In your experience, you look to a young surgeon now. How many cases you have seen till now within these 2 to 3 years?
Modified done, we have done
How many cases you have
6
seen till now?
cases, sir, out of which 1 had AVN.
In my experience of 45 years of practice, I have seen only 5 to 6 till now. Is
Okay.
it not easy to make out the cases here to diagnose? I don't think so many cases we get here. But still, they have done all these things. But what the treatment you want to advise a obese child with the acute slip?
In acute slip, depending on the severity of the slip, if it is too severe, in situ pinning is a gold standard, sir. All said and done, in situ pinning is a gold standard because we don't want to take the risk of AVN. But if the child understands the complications of complex surgery and is able to follow the post-op protocol, definitely we can go for modified done depending on our expertise.
Modified, yeah, okay. But can we tackle the head, neck and outside? So which one do you prefer? Suppose
Sir?
the surgeries can be done in the head, neck area, neck as well as the subthoracic.
I didn't get you, sir.
Surgery for the patient can be tackled at head, neck position, neck as well as outside neck. Which one do you prefer? The case which is a chronic.
The last slide was on rotational osteotomies. We can do in situ pinning and leave it, and at a later date we can do rotational osteotomies to correct the deformity. That's a safe play. But the only thing downside is if the patient wants a THR at a later date, we are making it a complex primary because of the rotational osteotomy we do distally.
How many complications you got till now? We have seen 6. What complications you get?
Acute slip AVN, like in a series of 6 cases of modified done, we had 1 AVN, and another one in anterior approach. Yeah, acute unstable cases, they have prone to AVN. But in a chronic setting, most of the times AVN may be iatrogenic because the slip is stabilized in that case.
Okay, thank you very much.
Thank you.
Good. Next speaker, please.
May I request Dr. Risha Madhuri madam to please come and give a talk on growth arrest and infection of young bones and joints. Madam is going to give 2 talks together.
Continuously, right? One by one. Dr. Risha Madhuri is a well-known pediatrician. He has been coming to our all conferences, pediatric conferences also. Talk on facial arrest. Quite an interesting topic for pediatricians.
Good morning. I'm going to talk on facial arrest, which will be almost like 75% cases of the knee deformities that will land up for you for correction. This is based on a series of which we had to do previously, and mostly the surgery is required around the knee for the facial arrest or distal radius. So damage to the facial cells in the germinal layer will cause a facial arrest. This may be due to trauma and infections. Commonest cause in our country is infections, and also other causes such as metabolic, iatrogenic, like in the last case, radiation, vascular deprivation, tumors, as well as mechanical, like Blount's disease. So I'm going to just take this talk through a series of examples of cases which present and how you deal with this. This is hemiepiphyseal loss, which you can see now at 1 year. You can see very clearly the half of the epiphysis lost. This is something that you might have to do, you might see frequently and not know what to do about this. So what we have done here is we have taken half of the femoral shaft and distalized it because we know that there is an underlying epiphysis there. Okay, that is can be checked on the arthrogram. You can see now the epiphysis is start to form, and as you see now the epiphysis is much more clearly seen. Okay, at the same time, because there is a problem with the proximal femur loss, we have also done a osteotomy for the pelvic support osteotomy for the proximal femur. Now for this next child, there is a 1-year-old child here. You have a lateral physeal damage. Lateral physis has not appeared. Probably it's a fibrous bar and there's a valgus deformity in an otherwise stable joint. So what we do is you can actually stimulate this to grow by adding a 8 plate on the opposite side, temporary epiphysis, which stops the growth on the other side, which while allowing to change the loading pattern as well as growth of this. And you can see that this recovers completely and it starts to grow when you do this. And at the same time, your deformity is corrected. Now, there are other surgical options when your physis is permanently damaged. You can do an epiphysiodesis on the opposite side and correct the limb length discrepancy. Easy option. This can be both temporary, as in if you use 8 plates, or it can be permanent by doing a drill epiphysiodesis. The other way to deal with this is by doing a limb lengthening. If you have a very shortened limb, more than 3 to 4 centimeter, you can deal with this very easily by doing the limb lengthening. Now, when you have a physeal arrest which is complete or partial, you will get either a limb shortening plus a knee deformity, or you will get a angular torsional deformity. So both of these will have different outcomes. So you have to decide how you're going to treat them. The decision will be based on size and location of bar, which physis is involved. Fast growing physis, you will want to recover the physis, age at presentation, and combine with the osteotomy when there is a deformity is very severe. It's better to combine it with osteotomy because at least patient can see the improvement immediately. In the lower limbs, when you have a expected shortening of more than 5 centimeter, you would prefer lengthening. If it's going to be 2.5 centimeter, you will just do a shoe lift, and between 2.5 to 5 you can plan on epiphysiodesis. Just to see how you can tackle angular deformities at maturity, especially in places where you have got very well designed very well designed implants, as well as no lengthening is required. You just correct the deformity. No lengthening is required, as you can see using a Tomofix to correct the deformity in this particular situation. So you've corrected both actually the anterior tilt as well as you have corrected the deformity. Here, if you need a lengthening as well, then we would suggest that you use the external fixator, where you can combine a small amount of lengthening along with your deformity correction. Here you can see there's a recurvatum deformity, abnormal tilting of the proximal tibia, and this deformity is corrected as well as lengthening is planned. The gradual lengthening can also be done while correcting by using some of these micrometric swiveling clamps in the orthofix system. You can see this, you correct it, and you can actually, because it is a dynamic process, if you have a small amount of translation to be done in the micrometric swiveling clamp, you can allow the translation even at a later stage to correct your deformity. This is a very unusual situation when you have a non-union very close to where the fibula physis is placed. So here what we have done is we have just translated the fibula physis exactly into the gap, correcting the physeal abnormality completely. This is very rare that you are going to be able to do it, but when you are able to do it, it works very well, and the remaining length discrepancy, which has already happened, you can correct by adding the lengthening, thus correcting both the problem of further growth as well as past growth. The technique that we all talk about when we are talking about physeal arrest is how to do a physeal bar dissection and replace it with either fat or cement or cranioplast. Now, the indication for this is you must have at least 2 years of growth remaining, at least 2.5 centimeter growth remaining should be there. And the commonest indication for this is around the knee. The bar type must be favorable. It must not be avascular, and there should not be a there should not be a what do you call it? Bar should not be greater than 30%. Angular deformities can need to be combined with corrective osteotomy. Okay, this is just to show how you do the planning. There's a deformity as well as this thing. You remove the bar through a hole, and completely after you remove the bar, make sure that you see the physis all round. These physeal bar dissections are used for those children which are amenable to surgery, mainly young patients, and when there's a growth potential that can be seen in the physis itself. It's not just that the bar should be showing some evidence of growth potential. This is a proximal tibial osteomyelitis in infancy, progressive deformity. Here you can see the bar removed and corrected, and you can see that the growth is restored in this child. This is another one, complete physeal arrest, 4-year-old child, history of osteomyelitis around the knee. Here there's a bar both in the tibia and femur. It's not just the shortening which is a problem, because the whole of the tibia is being sucked, whole of the knee joint is getting sucked in. You've got a knee deformity. Here you have to actually excise the physeal bar, because if you don't do it, you cannot correct that knee deformity. So here we have excised the bar with cement interposition. You can see that it started to grow and corrected also the remaining lengthening. Can you see that the knee deformity is completely corrected? There's no other way you could have corrected this. Now, one of the things that which we have worked on for very long time is how to restore the physeal integrity, which means not replace it by cement, but replace it with cartilage. Okay. So this is just something which we have worked on for nearly 15 years and used the iliac crest physis, taken the cartilage out, grown it as chondrocytes, culture expanded. Now I'm just showing one case for this. This is a 3-year-old boy, 3 physis. This is one of our early cases. Femur tibia and the opposite side tibia. There's shortening and there is deformity, and the physeal bar can be seen in the MRI. Okay. And this is just to show you the image of how the chondrocytes are tested for being collagen 2 positive and collagen 1 negative. This is the correction, 1.5 years, 2.5 years. And then you can see before and 3 years after the surgery, you can see the correction of the deformity and the length being restored completely. The femoral shortening also get reduced from decreased from 5 to 3 centimeter. So my take home in this is that when you're making a decision, you have to be very careful about the hemiepiphyseal damage. When you decide the hemiepiphysis is missing, check it with arthrogram or MRI, because the cartilage enlarged may be there. Beware of temporal evolution of physeal bar. Some physeal bar looks small when their child is young. By the time they become 8 and 9, they will actually fuse completely. So these surgeries are destined to fail. So you should be careful. Okay. In infantile infection, physeal bar excision is warranted even when the bar is 70-80%. I would suggest that you always consider this as an option, because the knee itself gets destroyed and it's not just the length issue. And the future growth must be taken into account when you're reconstructing. So don't just plan for now. Remember that deformity can recur, shortening can recur. So take all that into account when you plan. Thank you very much.
Thank you, Risha. You want to continue the second talk? You want to continue for the second talk, or is it?
Okay.
Or else I'll ask some questions for this. Later on you can ask. Can I? Questions in the audience? Anyone? Yes? Don't talk. You have some question there? No.
Oh. Yes, please.
What?
Fat interposition.
Yeah, I think cement interposition is what I prefer. Main reason is that the fat can sometimes, the space can get filled with blood. So fat, when it works very nicely. But remember, it only creates a non-union. It does not cure it. Always replacing it with a chondrocyte is better than replacing it with fat. But fat, when it works well. There's no problem about it. But cranioplast works much more reliably. Cement or cranioplast work much more reliably.
Will you remove the cement after some time?
No, you don't remove. You remove, you'll get your physeal bar back.
Bisha, one more question. Hello. About the middle length deformity, where you can get physeal arrest in the middle. People always describe about the Vickers ligament. I have not come across this ligament.
So mid-lungs deformity, I have done quite a few physeal bar excision, because when you see that
I know.
thing, it gets pulled down, and you can actually see it getting pulled down into the shaft. So I have done physeal bar dissection and seen the growth recur in those patients.
There was a physeal bar or just adherence of a ligament there?
So even a Vickers ligament kind of thing is like a fibrous physeal bar. So not all physeal bars will be bony.
I tried to find out many times. I couldn't get. Only thing I had to open the physis and then do some surgery.
No, I think you have to identify it beforehand. mark it with your points from where to where you think medial to lateral where the bar is, and then just exercise.
If the
It will be a fibrous bar. It's not a bony bar.
ligament only, I think.
Yeah. So you should exercise about 3 millimeter deep, and that will take care of it will release the bar as well.
Right. What about the fishtail appearance of the lower end of humerus?
Sorry?
Fishtail appearance of the humerus after the injury to the lower end of humerus.
Yeah.
So how to tackle this?
Distal end of the humerus.
Yeah.
I don't ever correct distal end of humerus.
So there is a fishtail appearance.
No, distal end of the humerus is a very slow growing epiphysis. And the bone actually is quite tolerant of up to 5 centimeter of limb length discrepancy. So I would not do distal end of humerus. I never done distal.
But deformity will come, at least with angular deformities.
Sorry?
Angular deformities are common there.
In distal end of humerus, do an
Humerus.
osteotomy.
Okay.
Because when we say physeal bar, we should have at least 2.5 centimeter of growth remaining. If you don't have that, you're going to gain only 5.5 millimeters, 1 centimeter, then you might as well do the osteotomy, and that is much more reliable and predictable answer.
Okay, thank you. We can start the next talk.
Yes, can you put that on? Is this? Yeah. I'm going to just focus on the neonatal septic arthritis because I think septic arthritis in the older child is much more easy to recognize, much more easy to deal, and the anesthetists are not scared of giving them anesthesia. So there is less issues about that one. So how is this neonatal septic arthritis different? Because this baby has a decreased immune response, so the symptoms and signs are much less. There's a very high morbidity and mortality in this age group, and there is a higher association with osteomyelitis. I've written more than 50%. But in one study where we did look at it very carefully, we found 83% of the patients had some amount of osteomyelitis, though not always became chronic, but it was there. There is emerging resistant organism coming on, and many of these babies will have multifocal osteomyelitis. Almost 30% of them could be having it. We consider that the pathogenesis could be femoral vein puncture and also from septicemia, again very common in these babies. Most often it's the umbilical sepsis and then septicemia and then the septic arthritis. Femoral vein punctures are, I think, less common because of that, because I think now you have much more of the ICU care possible. The focus for this is usually in the metaphysis, and from the metaphysis bursts into the joint because the joint is almost entirely the epiphysis and the metaphysis are intra-articular. So it can either burst directly or through the physis. If it goes through the physis, it will cause a physeal arrest. If it goes directly into the joint, it just causes septic arthritis and dislocation. If it goes and pushes under the growth plate, it causes the separation of the physis. So all of these are possible complications even without having a very advanced problem there. Okay. So what are the pathogens involved? Remember, unlike the adults where you get only staph and strep and older children, here you'll get staph, strep, gram-negative rods, group B streptococci from the maternal birth canal, as well as fungal in children who are on supports like immunocompromised or have IV alimentation. The important thing to remember is almost 30% of these patients have gram-negative organism. So when you provide antibiotics, it should cover gram-negative very strongly as well as gram-positive. This is just to show 50% of our patient had staph and 30% of our patient had gram-negative organism. So in specific risk groups, coagulase negative Staph aureus is common when IV catheters are being used, group B streptococci with mother infection, and candida in prolonged critically ill neonates, and salmonella when there is actually a breakdown of hygiene in the food, in the feeds, water, and with the mother. Risk factors are prematurity, venous cannulation, perinatal asphyxia, sepsis, nursery and ICU stay, and umbilical or other sepsis. Almost more than 50% of patients will show at least one of these risk factors. The delay in presentation can vary widely. Now, as the time is going on, we find that the delay is less, but we are also finding that more and more babies are being treated just with antibiotics, and they lose precious time before they can be drained, and therefore still do have much more adverse effects. In a study done in Sweden, uh, Norway, they have found almost zero sequelae in their septic arthritis series, whereas our septic arthritis series have very, very high sequelae. Uh, Clinical features are irritability and failure to feed, pseudoparalysis, very common, swelling and other local signs, fever, hypothermia, multiple sites, and when late, it can be dislocation, facial fracture. When I get a call from a DIC saying there's a baby who has got a paralysis, can I send them? I know for sure that it won't be a paralysis because lower limb paralysis is not such a easy thing to have. It's much more likely that the child has septic arthritis. Investigation, most important investigation, which I consider is CRP. In a neonate, there is no reason for a CRP to be high. When this is high, you should consider it as very significant. All the other things are actually not so important. I've listed them: ESR, hemoglobin, joint fluid counts of more than 50,000 WBC, and scintigraphy for picking up multiple areas of involvement. That is when you know that two areas are already involved and you think more areas may be involved. So investigations are as for septicemia, serum electrolytes, blood sugar, a neonatologist should be involved and from the beginning, and the patient should be admitted under them because they can get DIC, they can go into meningitis, all sorts of problems are possible. Investigations, radiographs are useful in ruling out other pathology. You can see subluxation and dislocation and associated osteomyelitis in late stages. Ultrasound is important, but if ultrasound is negative and you think it's positive for septic arthritis, you are right, not the ultrasound. Remember, because that is observer dependent. But you can also pick up any instability in the physis, and that can, so this may be like at an instability in the physis. And if you can look at the previous ultrasound, and you can see later on that there must have been a lot of movement at the proximal proximal humerus. Other investigations which are useful are MRI for localizing the soft tissue, bone, and cartilage component. So if you're not sure what all areas you have to drain in an extensively involved limb, CT is useful for identifying a sequestrum. Differential diagnosis, abscess, soft tissue, psoas. In babies, if you see, please consider septic arthritis of the hip. In the older children, yes, psoas and all are possible. Isolated osteomyelitis. Then when you see physeal separation, birth traumas, scurvy, NAI, they can look very much like septic arthritis. So they are important differential diagnosis. Treatment is with antibiotics, which is mainstay. IV for 3 weeks or less, following the, depending upon your CRP. Once the RP becomes negative, we do not give it for more than 5 days after that. Immobilization is a Pavlik harness or a plaster splint. Surgery is arthrotomy, debridement, pus drainage, drain the osteomyelitis and all the other foci. Medical management is IV antibiotics, Kalakshethram in a non-susceptible area, and in a non-resistant area, vancomycin in the resistant areas, and more higher antibiotics where you have had multiple prior treatments. You should change to specific antibiotics when culture is ready. Surgical management, I'll say no role for aspiration, but we have had to do in a very sick child where we put 2 needles into the joint and wash out the joints because the child can't be anesthetized. You should also drain the adjacent osteomyelitis. Reposition a displaced physis, but if it's totally detached when you're operating, then just remove it. You're just leaving a sequestrum behind. Drain has to be removed once the drainage stops, and appropriate antibiotics follows culture, which usually come within 3 to 5 days. A 5-day CRP will give you an indication to stop the antibiotic if everything is good. At 10-day, again, you repeat the CRP. And then if 10-day it comes negative, then you give the antibiotic for another 5 days and stop. You don't have to keep giving the antibiotics. Splinting is important. We use Pavlik harness very, very commonly for the hip. In fact, all septic arthritis baby get Pavlik harness. For the other joints, you can use we can use POP splint. Monitoring, like I explained, the CRP at 5 days, CRP at 10 days, and CRP at 42 days are all very important. Outcomes, you can get complete resolution in 65%, sequelae in 35% in Indian series. Chronic septic arthritis, osteomyelitis, loss of epiphysis causing Tom-Smith arthritis, a dislocated hip which has to be treated later, and physeal arrest are all common complications. So the most likely prognostic indicator is the delay in therapy. Bad organisms like resistant organisms, Staph aureus, gram-negative and fungal infection, large joint involvement like hips and shoulders, associated osteomyelitis and physeal damage. Prevent by improving perinatal care, prevent by improving prevent by perinatal care for the mother, child, and postnatal care for the baby, and very high alert in children for septic arthritis in those requiring intensive prolonged alimentation. So early diagnosis, early appropriate antibiotics, but don't forget that if unless you do arthrotomy, that hip joint is going or that knee joint is going. So along with the other two, the third one is just as important. Thank you.
Thank you. Any questions from the audience regarding this? Anyone? Regarding septic arthritis? No one. Ma'am, one question from my side. If the child about one year has come with a septic arthritis with epiphysis inside the joint and the shaft is outside. As if it's
What is outside?
epiphysis inside the joint,
Yeah.
but the complete upper end of femur is outside the joint. Looks as
Yeah.
if it's a dislocation.
Yeah.
How to tackle this?
So I think there you have to actually go open it up and see there is a connection between their epiphysis and your metaphysis. If there is a good soft tissue connection, you just reposition it and put a wire and take out the wire after 3 weeks. But if it is detached, don't put it back. It will always come out. It will come out as pus slowly draining for a very long time.
One thing I had that only thing I again put it back inside and put a hip striker for some days. It has unit completely. That's what.
Yeah, but then there would have been soft tissue connections. There should have been some blood supply. Because I have done like what you have said, because I don't feel like throwing out the epiphysis. And then I've regretted it because it eventually has to come out, or I have to go back and do a rearthrotomy and take it out. So if there's no soft tissue connection, we understand that it is a sequestrum. Just putting it back will not help it.
Okay. About the antibiotics you want to use, how many days? Suppose.
So antibiotics, 5th day CRP is normal. If it's come down to normal, I will maximum give for 5 more days and stop. IV antibiotics, once the clinical signs are down and the CRP is down, then stop the IV antibiotics. Oral antibiotics after CRP is down, there's no indication for giving it more than 1 week after. The CRP is actually already having some lag time. Patient's already better before the CRP shows it. So that's why we don't give. After for the last 2-3 years, once the CRP is normal, maximum 5 days to 1 week after that antibiotics.
If it is resistant, then recalcitrant. It's very difficult, no?
Sorry?
Change it. If the infection is so resistant, it's not respond to any antibiotic, what do you do?
So then you have to go in for very newer, higher antibiotics, which are even difficult to source everywhere. I remember we recently had a child who was resistant to all organisms except for some of the new ones, not even available in Tirupati.
Even if you do culture also, all will be negative only.
No, we have to drain it. You have to actually find the antibiotic and give it, because neonates cannot deal with the infection by themselves. They don't have the resistance that the older people have.
Okay, thank you.
One more question, madam. What is your post-op protocol after arthrotomy? Do you immobilize externally?
Yeah, so post-op protocol after arthrotomy for the hip is always Pavlik harness. Because if there is no dislocation, it can still happen. So, and it is very comfortable for them to nurse it. For the knee and all, you can give a splint. For ankle also, we can give a splint. Hip, give harness.
Thank you.
Thank you, madam.
Thank you.
Sir. The next speaker is ready. Roshan. Yes, Val. His talk on pink pulseless hand is commonly asked in the exam.
Good morning, chairpersons. Good morning, everyone. I would be speaking on pink pulseless hand, the evidence-based approach. So we all know that whenever we find a child with no pulse present, or for that reason any other person with pulse absent, the first thing comes to our mind is we need to explore and operate and restore the vascularity. But what we are speaking here is about a pink pulseless hand. Means the pulse is absent, but still the microcirculation is still intact. The capillary filling is still good. So when the microcirculation is good, why can't we go ahead and do a conservative management? Why we have to go and explore it? So this is the dilemma which arises whenever a pink pulseless hand presents to us in the emergency. So what I tried to do is, let's find out what the literature says. So I went on to the Google, which is a very normal thing which most of the people do now, and try to find out the literature. And I've typed this treatment of pink pulseless hand. So it gave me some 57,000 results there, and it directly told me that surgical exploration is the treatment of choice. So a young surgeon who finds that there is a pink pulseless hand and literature says it's a surgical exploration is the best option, the vascular surgeon comes in and you go in and try to repair this. But I just thought whether this process is correct or not, because many a times the answer is given based upon the type of question you ask. When you go and research the literature as well, it depends upon the way the question is asked. So I just changed the question which I asked to the Google here, asking it approach to the pink pulseless hand instead of asking the question what is the treatment of pink pulseless hand. And again it gave me quite a significant number of papers there, and the point which came out there was it is controversial. So initially when my search told me that it is direct exploration, and later when I changed the question slightly, the algorithm changed there and the Google started searching different kinds of paper and it's told it's controversial. And in some papers it also told me that conservative approach is better than going for a immediate vascular exploration. So where are we heading to? When what we are supposed to do finally when we get a pink pulseless hand? So there are various papers available in the literature which tell us we have to go and we don't have to go for it. So there are two schools of thought. So these papers by Choi et al. And Grubbers, published in JPO, they told close observation of these pink pulseless hand is enough. And a review literature, because the best article is a review literature given by Griffin, it also shows that treatment for this pulseless hand is a close observation. But a lot of authors like Fritz, Schad and Shaw show that the outcome is better when you do a immediate vascular repair. But contradicting this, Sabharwal says in his article in 1997 published in JPO that there is a lot of complications when you try to do a immediate open exploration of this vascular injuries and try to repair them. So what are we finally trying to do here? Everyone says that whenever there is a vascular injury, we should be aggressive. Aggressive in what? Vascular exploration or evaluation. So nowadays we feel very proud to say that we are an aggressive surgeon. So aggressive surgeon doesn't mean that you find a fracture like this, a small pulp fracture, and you go and operate that. Instead of that, aggressive surgeon is one who does aggressive evaluation of these injuries. So vascular evaluation, aggressive vascular evaluation and repair is required in selected cases. How this exploration evaluation you are supposed to do? So magnetic resonance imaging angiography is the gold standard, but we don't get this magnetic resonance imaging at every place. So other two options, what we usually have locally available at our hands is a color duplex monitoring and a wave pulse oximeter. Pulse oximeter is a very common thing. It's even available at homes nowadays. No, post-COVID, everyone has this pulse oximeter. And as an orthopedician, we find it very easy to use a simpler device than using something like an angiogram and all those things and trying to interpret what is shown on that. So this is a paper by Dr. Venkat Das and et al. From Ganga Hospital in IJPO, which clearly says that the treatment of choice in all pink pulseless hand is a simple observation, given that the pulse oximeter shows you a good waveform, and so it shows a good waveform and saturation. Just presence of a saturation without a good waveform is contraindicated. Means you have to do a vascular repair in this. The same thing is highlighted here in this article by clinical orthopedic surgery, where it shows the importance of a simple pulse oximeter, how it can help us to know whether the vascularity is good. So, but why are we debating when the vascularity is good and we know that the capillary filling is good? Many people debate on this, telling that we might miss the early compartment syndrome and thus we might miss a hand or the functionality of the hand. And the other main common question asked is long-term subtle ischemia which can occur. A given hand post-injury might show good vascularity, the capillary filling, but on a long term the ischemia might be bad because and they might have reduced efficiency. But both these questions can be answered by simple things by monitoring the AAA of a compartment syndrome in pediatric age group. Unfortunately, in a child, understanding a compartment syndrome and diagnosing it early becomes difficult because the child doesn't tell you what the symptoms are. So these 3 A's of pediatric compartment syndrome have to be clearly kept in mind. The 5 P's of the adult compartment syndrome doesn't hold good in a pediatric age group. So any of these 3 A's present, we have to immediately explore. And when it comes to subtle ischemia in long-term outcome, there is a study by Larry et al. Wherein kids who are undergoing renal transplant for some reason, they undergo a brachial artery ligation. And all these kids who undergo brachial artery ligation do not show any subtle signs of ischemia when the hand is put to any excessive function like they are playing or doing something. No, they do not have subtle ischemia. So the long-term effects are not there. So the point here to take home is any child who has a ping pulseless hand can be managed with close observation given that he doesn't have any signs of compartment syndrome. The point here to understand one more thing is any child who has to present with a compartment syndrome or to diagnose a child with a compartment syndrome, the median nerve should be intact. If the median nerve is injured, then the 3 A's of compartment syndrome may not be manifested, and all these kids requires immediate exploration. So to conclude to my talk, the point would be very close monitoring of all ping pulseless hands is very important, given that the pulse oximeter shows a good waveform and saturation both, and the exception here being a median nerve injury. Associated median nerve injury needs immediate exploration and repair. Thank you.
Thank you. Thank you, Rosh. Any questions from no one? Not interested. It don't show us how many people are interested in pediatrics. Hardly anyone. Right. Regarding this pulseless pink hand, how to make out it's a spasm or if they turn brachial artery, how to tackle these things?
Sir, the point here is we are not trying to diagnose what kind of injury is there to the brachial artery. What we are trying to understand is whether the hand is perfused or not.
Right.
If the hand is perfused, that means the saturations are good and a good waveform. A good waveform says that the anacrotic and dicrotic notch is there and that's the flow is good. It may not be through radial, but it might be through ulnar or the collaterals. That is more than enough.
How to manage suppose it? How to manage this, suppose this?
Immediately a ping pulseless hand comes. The first point what we do here is see whether the median nerve intact. Given that the median nerve intact, SpO2 is good, waveform is good, take him directly to the OR, close reduce the fracture, and then again check for your pulse. Pulse if doesn't come back also doesn't matter given that the SpO2 and the waveform is good, but it should not disappear. It should not become a white pulseless hand. If it becomes a white pulseless half post reduction, that means your artery is getting impinged within the fracture site, which needs to be immediately explored.
With the nerve also, it's got to can immediately do. No repair.
If nerve is involved, immediate exploration is the answer, sir. Because we may not be able to pick up early compartment in those cases.
Right.
Thank you.
Anyone else? Right. Thank you.
Thank you, sir.
Next speaker, I think, Sujit. We'll be talking on Montague fractures. Elbow trapezius.
I thank the organizing team for giving me this opportunity, respected chairpersons and my teachers. My talk is on elbow trap. We see pediatric forearm and elbow injuries day in and day out of our practice, but sometimes there is a trap in diagnosing and managing these cases. Let us see what it is. Yeah. I'm Dr. Sujit, pediatric orthopedician from Ankara Children's Hospital, Hyderabad. Let us go through this trap through some examples. There is a 5-year-old child with fallen outstretched hand, came to ER. The ER doctor has seen this. He has noted it down as a subtle hairline fracture of the proximal ulna and given a slab. Yeah, given a slab for 3 weeks. After 3 weeks, this is the status, and there is a progressive valgus deformity. This would not have happened if it was properly evaluated, and this simple line, radiocapillary line, is drawn at the time of injury. So this is radiocapillary line is called McLaulin's line. If you draw this line, if it is not bisecting the capitulum, then it is a Montesia lesion. So one more case, 4-year-old child, history of fall from monkey bar on outstretched hand, went to an orthopedician, diagnosed as soft tissue injury, and given a cast for 3 weeks. As you can see here, the X-ray looks fairly normal. There is no obvious fracture there unless you specifically draw this radiocapillary line. You can easily miss this. What else is there in this? It's not an isolated radial head dislocation. If you can draw this Mubarak's line, which comes from the proximal ulna to the distal ulna metaphysis, if there is a ulnar bow, if the distance between the maximal ulnar bow and this line is more than 0.1 mm compared to the opposite side, that means there is a plastic deformation of ulna. In these cases, you should be suspecting the radial head dislocation and Montesia lesion, and you have to treat it accordingly. This case, as you can see, compared to the opposite side, the radiocapillary line is missing the capitulum, and there is a, compared to the top image, the bottom image, the ulnar bow sign is positive. This is missed initially, and this is an example of ulnar bow sign. And Scott Mubarak in this article has clearly shown that there is nothing called isolated traumatic radial head dislocation. There is always a plastic deformation of ulna associated. There's another article with the same thing. And in these late cases, when diagnosed, you have to do a flexion osteotomy of the ulna to realign the radiocapillary joint. Yeah. Say another case, there's a distal radius fracture and proximal ulna fracture. Again, as you can see, the radiocapillary line is missing the capitulum, and Mubarak's line is again positive here, and it was treated with flexion osteotomy of the ulna to reduce the radiocapillary joint. So Sir Watson Jones in 1943 itself has mentioned that there is no other fracture with so many problems, and no injury has greater difficulty, and no treatment has more generalized failure regarding the Montesia lesion. Beddoe has described, as we all know, into 4 types. Type 1 is apex anterior with anterior dislocation of the radius. Type 2 is posterior. Type 3 is varus stress with lateral dislocation of the radial head. Type 4 when there is an anterior dislocation with both radius and ulna fracture. Let's has subclassified it into type 1 into 3 types, 3 subtypes. Type A is plastic deformation. Type 2 is green stick. Type C is complete fracture of the ulna. So let us see how do we treat each of these. Type 1, there are 3 mechanisms of injury. It can be either direct blow or hyperpronation injury. The most common accepted theory is hyperextension injury, where the radial head, when there is a hyperextension at the elbow, the radial head dislocates first, and then there is a tension failure at the ulna. The treatment here is you have to do angulation correction first, and then with traction reduce and then do supination, and then flex more than 90 degrees to reduce it. I'll show you with an example. This is an example of type 1 fracture with anterior dislocation of the radial head with plastic deformation of the ulna. As you can see, the Mubarak's line and the ulnar bow sign is positive here. In this case, you have to do gentle manipulation of the ulna, give sustained pressure over the ulna. You have to give over a 2 minutes time over a bump. Once the sustained pressure is given, you will get the straight ulnar border. And to maintain that reduction, I use a wooden board to maintain this ulnar bow. And as you can see, the flexion is more than 90 degrees to relax the biceps and to prevent the redislocation here. And type 2, it's an axial loading on a 60 degrees flexed elbow where there is a posterior displacement of the radial head. In these cases, you give extension to reduce it and give an extension cast if you are doing a close reduction. This is an example of type 3 where there is a lateral subluxation of the radial head. It happens because of the varus stress. So in these cases, you do extension as well as the valgus to reduce it. With an example, once you reduce it, it was not stable. We did an arthrogram to check the congruence and then fixed with an intramedullary wire. Type 4 is hyperpronation plus direct blow injury. In this, you convert the type 4 to a type 1 injury by fixing the radius first, either closed or open, and then continue with your treatment like in type 1 Montegia. You can do open reduction if you are not sure if you cannot get the radiocapsular alignment well. There could be some soft tissue interposition, especially your annular ligament might be there in the way. You can repair the annular ligament with either Cocker's approach or Boyd's approach. And if it is a old standing case, long case, neglected Montesia, you can do belt Aussie procedure using a triceps fascia to repair it. So one small tip for the young surgeons: when you are doing open reduction for these Montesia lesions, you have to pronate the forearm to protect the posterior interosseous nerve when you are going posterior approach or posterolateral approach, because when you do pronation, the posterior interosseous nerve goes anteriorly and you can release from the origin at the ulna. If you are going anteriorly, you have to supinate it so that the nerve comes posteriorly and you can release from the radius. And in neglected Montesia, as I have shown before, I'll just rush through the slides. Yeah. In neglected Montesia, you can do this flexion osteotomy. If needed, you can repair the annular ligament.
Okay, thank you.
Thank you. Thank you.
So, hardly anyone is there to ask questions.
Any questions?
One question.
Yes, sir.
In neglected cases, after correcting the deformity in the ulna by osteotomy and all, how often you require to open the radio ulnar joint and reduce it?
Yes.
Usually,
There are
does it
two
come
schools of thought, sir. Some surgeons open the radiocapsular joint first, visualize it first, and then do flexion osteotomy. But what I prefer is I do flexion osteotomy first, try to get the reduction. If it is not coming, then I'll do a open reduction. Otherwise, I don't open the joint.
How often you get spontaneous reduction?
Spontaneous reduction in 50% of the case. Usually in less than 3-month-old Montesia lesions, you can get away with just a flexion osteotomy.
So may I request next speaker, Dr. Venkatram sir. Thank you, sir. Thank you, Dr. Sujit. Nice talk. Dr. Venkatram sir is going to talk on timing and technique in pediatric knee deformity.
Good morning to everyone. Thank you, Chairman sir, for giving this opportunity. Today I'm going to speak about timing and technique in knee deformity correction. So deformities are seen at different ages from newborn to old age. So there are various physiological and pathological conditions. Before treating the deformity, we need to treat the underlying condition, especially in pathological conditions. So physiologically, we see varus below 2 years of age. Later on, the deformity gets corrected and followed by valgus deformity up to the age of 3 to 7 years of age. So whenever you see child in the OPD, you need to check whether it's single plane or two plane deformity or three plane deformity. Followed by you get this canogram where you need to check for the mechanical axis, LDFA, MPTA, and tibiofemoral angle. So once you calculate the angles, you need to find out where exactly deformity is there and plan accordingly. If it is before skeletal maturity, you will go with the fascial plates or the transfascial screws, or after skeletal maturity, you plan for the deformity. Is it single plane or two plane or multiple levels? The deformity is there. So deformity correction before skeletal maturity, you can go for conservative based on physiological and pathological conditions. Or if it is late, you can go with guided growth 8 plating or transfacial screws or combination of both. After skeletal maturity, you can plan for corrective osteotomy. Either it could be percutaneous or open. Fixation could be with K-wires or just plasters or screws or plating or ring fixator. I prefer to go with the percutaneous method. So braces are available in the market, different types, but not every child will accept brace. So when to use guided growth 8 plating? So if it is idiopathic deformity, you can use up to the age from 18 to 14 years of life. And if it's pathological, you can use from say 2 years to 13 years of age. And considering the deformity, the tibiofemoral angle should be more than 10 degrees. So it is a idiopathic child condition with 11 years child went with guided growth 8 plating. So the technique is when you're planning correcting the default on the right side, the right lower limb should be at higher level, and so that the opposite limb will not come into picture. So you need to fix it in both AP and lateral views, and the one person should be holding the ankle in a neutral position so the patella will face the roof and the monitor should be comfortable. So first you pass so first you need to pass in the femoral epiphysis, followed by both you need to check in the AP and lateral views, followed by fixing the plate and shifting it fixing in the metaphyseal region both in AP and lateral views. So when to use percutaneous transfacial screw fixation? Most of them have fear because of the damage of growth facial growth plates. So when there is no growth and girl child is beyond 10 years of life and 8 plate is less effective, then transfacial screw fixation is better. And here the procedure is I try to put a subcutaneous K wire in the AP view, check it in the AP view, followed by shifting the C-arm in lateral view and put the it's a modified technique where you put the guide wire from the retrograde way from the epiphysis to metaphysis to decrease the number of attempts, to decrease the radiation and time also. So first you place the wire from here, pass it out, and you need to drill from the antigrade way. Then fix the screw in the antigrade also. So in this article, normally most of the time we will be using 6.5 mm screws or 7 mm, but According to this article, if the child is below 7 years, you can go with 4.5 to 4 mm screws also. This is a 5-year, 6 year child with hypophosphatemia rickets on regular treatment by the nephrologist. So, according to this, at 6 years, we went with the guided growth 8 plating. After the deformity correction, we have removed the plates. In the follow-up, we have seen mild deformity, which has corrected with transfacial screws. The same child. This is again a 11.5 years child. Parents were not, it was late presentation, so significant deformity. Parents were not filling for corrective osteotomy. They wanted to trial with 8 plating. Over a period of 1.5 years, the deformity has not been corrected. So we went with percutaneous osteotomy at the proximal tibia. Every time after the correction, we used to check for the mechanical axis. Post plastering. So the follow-up after 6 months, we can see the deformity corrected. This is again a neglected child, 15 years old, hypophosphatemia rickets, never treated before, and you can see 3-plane deformity below the knees. So we went with the single-stage multilevel corrective osteotomy. Sometimes medially in the osteotomy, you need to medially mobilize the distal fragment, but it's quite difficult. So finally, over a period of 8 months, we see the alignment. This is again a 13-year child with post-traumatic deformity. You can see the deformity here and limb shortening of 4 centimeters. So after percutaneous osteotomy, we have corrected the deformity and checked the mechanical axis followed by fixation. So the limb after the post deformity correction, the limb shortening was addressed by limb lengthening. This is a special child followed over a period of 5 years, diagnosed with rare disease and under follow-up with a pediatric gastroenterologist. So when they came, there was no over a period of time there was no growth in the child. So we gone with 8-plate correction. They were on and off follow-up, not on regular follow-up. Deformity corrected. Then later on we put the brace. Again we did the surgery. Went into overcorrection with implant failure. Later on secondary deformity has been developed. So over a period of sequence, still the deformity is going on. So this is a child with MPS child, post deformity correction. And this child with multiple exhaustions complaining of knee pain. So we went
Sir,
with
please
transfacial
conclude
screws.
the session, please.
There's a significant deformity of the knee. Went with multi-level corrective osteotomy. The taller child. So biggest problem is removal of the transfacial screws. So we started shaving the square shaped head into this circular ring, circular head size into a square, so that easy removal of the screws. We adapted at our place. Thank you.
Next, we have interesting case discussions. Closing? Yes, sir.
Request Dr. Maheshwar sir, Scientific Committee Chairman, to kindly fill such chairmans of the session. Request all the three chairmen to kindly come on the stage. Jagdish sir, Haji Reddy sir, and our own Jagan Reddy sir. So for today, we have just gotten the emblems of all the things, all the associations for all of us to enjoy. Small change in the schedule. Open it. Request all the speakers to come, please. We would like to felicitate the last session. Shah Madam, Srikanth, Roshan, Sujit and Venkatram. Please, kindly come. We'll go to the next session. This is interesting case discussions. Thank you very much, Jagdish sir. This is on interesting case discussions. So I request Dr. A.V. Anand, Dr. Mrudula Madam, Dr. Arjun, and Dr. Santoshini to come. Each one of you can be seated one after the other. You can proceed on with this interesting case discussions. The chairpersons for this would be Dr. Risha Madhuri Madam. After her felicitation, I request her to come here. Next, I request Dr. Roshan Jaiswal, who has presided or he has talked here, also to come and chair this session, and Srikanth as well.
స్టక్ అయిపోయిందిరా. Yeah. Shall we start? We'll start? Yeah. Good morning, everyone. I'm Dr. Anand. I'm a pediatric orthosurgeon. Thank you for the opportunity. So, first of all, it's a very common case and it's a failure story. We always talk about success stories. I'll talk about my failure story today. So, yeah, 13-year-old obese baby presented with an RTA with injury to the left hand. This was the X-ray. What do you think you should do? Obese kid, 13-year-old. What would you like to do? Roshan sir? What would you do, sir?
Obese means what is the weight means?
He was 56 kgs, sir.
So what my criteria would be is any child who is beyond 50 kgs of weight, I would like to prefer and put a surface implant than going for an intermedullary implant, and especially with the
Absolutely.
fracture pattern, the subtrochanteric fracture, which is
Hmm.
long spiral oblique, may not give much stability.
Yes, yes.
But at the same time, there is one more option there where you can put a tense nail and a fixator for around 3 weeks.
Internal on external fixator kind of idea, right? Yeah, that's a very nice idea, sir. So this is a very interesting paper. I would like everyone to read this once. This is about the age-based what kind of implant and what kind of treatment you would choose for different. This is a very nice paper. So yeah, this is the algorithm that they had shown. So our category is on this on the right side. So when you see, go back to the last unstable thing, more than 49 kgs, what this guy was selling is do a submuscular plating or a flexible intermediate using with a stainless steel and or external fixator. That's what Roshan sir was telling. So plate fixation, what I felt was a very good option rather than intermediate. Intermediate also I had measured it was only 5 mm. So 5 mm implant, getting an implant for GT entry, it's tough. I felt so I went for a plate. So I had my implants, but then I did something like this. Srikanth sir, you are happy with it? Like, you're happy, sir? Like, I put an intrafrac screw also. I had to open a little, you know. Your mic is not working, sir. Sorry.
It is not submuscular plate, right?
Yes, yes, yes.
It was open reduction.
Yes, yes, kind of.
See, when you go for open reduction, we need not have such a long plate.
Mm.
It is just put interfrac, but a short plate. It is open reduction.
Okay, sir.
But in pediatrics, we want to preserve the periosteum muscle. So either do submuscular plating, put a long plate, and don't touch the fracture.
I kind of couldn't get the reduction, sir. The baby
Reduction
was
is
too
not
heavy.
needed. Reduction is not needed.
Okay.
Or if you want to do biologically, you can as well put a TENS and put a supplemental X fix because it is a subtrochanteric fracture and a short span segment is there.
Yes, sir.
My options would be TENS plus X fix,
10 plus X
or just do a biological plating. Forget about the fracture reduction.
Okay, sir. Okay, sir. So maybe that was a mistake I did. So this was the interfrac screw, and this is about the one interesting paper where the screw should be a little at least more than 2 centimeters from the
Why did you put the nail into the neck as well? Was any
madam. It was like the fracture was very proximal, ma'am, up to the what do you say, lesser trochanter. So I was not happy with that. So I had to put another screw into the neck, madam. So this was one paper that was supporting what I did. Yeah. So after the 6 weeks post-op, it was looking good. It was a long spiral. Till the LT, the fractures line was extending, madam, in drop. So after that, this was happened in 6 months. I think we are still happy with it, right? But there was a lot of stress shielding at the end. And 11 months post-op, what happened was baby was walking, playing around, and finally they had to go send him back to the hostel. Madam, please.
when you said looks okay, I would not agree with that.
Okay,
There are
ma'am.
lytic areas around every screw.
Yes.
So a plate like this doesn't fail little by little. It will
Yes,
fail
yes,
only suddenly.
Yes.
But these are a clue that the fracture is not
Yes,
united.
madam. Yes, madam. That was a mistake. Yeah. That's why I told you it's my failure story, madam. So after this, he had to go back to hostel. So they wanted to implant removal at the age of 11 months. What would you suggest, Srikanth sir? Would you remove the implant, or they wanted to send the baby back to the hostel? So
no, we cannot send. We have seen lysis. Anytime it can fracture.
That's what, sir. That's what I had also suggested them. He will wait for another few months. We'll see like that.
This
But
fracture and fixation pattern is not suitable for weight bearing.
yes,
I'm
madam.
feeling all this has happened because this child who's already little overweight has been
Yes,
weight
madam.
bearing
Yes.
throughout.
Now when he came this time, he was 68 kgs, madam. He was almost 70 kgs. Like he gained a little more weight, over 10 kgs like
Was
that.
he non-weight bearing or was he weight bearing?
He was
after
weight bearing.
fixation?
He was weight bearing. Yeah.
The problem is not with your fixation or anything.
Okay, ma'am.
Problem probably was that you allowed the child to weight bear straight away.
Okay. Yeah. So after this, we somehow the parents convinced me to remove. So I was also like, okay, I removed it. And then this guy went back to the hostel. And then, what do you feel about this? Are you happy? Or not? I'm
Usually plate we don't remove before 1.5 years. I'm
yes,
not
madam.
sure how
Yes,
you got convinced by the parents. I
that's
think
all.
the lesson here is that
Why I
parents
got
don't
convinced?
decide.
I'll show you why I got convinced. So this was the papers I was reading. Once they asked me to remove, they had given a clear indication that after 8 months you can go for a very good implant removal. Nothing is going to happen, and the failure rate is very low.
8 months is a very arbitrary number. There should be other criteria which should be included into it, whether it's a intramedullary
Yes, sir.
or a surface implant, whether you have done a submuscular plating, you have done an open reduction. There's so many factors which come into account.
Absolutely,
Before
sir.
we think of lot of right.
Yes, sir.
For a 13-year-old implant removal, you should apply the adult criteria,
Absolutely.
not a criteria that you would use in a 3-year-old.
Yes, madam. Yes, madam. Yes, madam. So these were all about adolescent fractures only, madam. So he fell down and he came like this. So now what to do? 13 years. Sir. Now 14.
I think so. Adolescent trochanteric entry nail would be the best option for
That's what, sir. So finally, I learned from my mistakes. So I understood that this was the screw that was going into lytic region and had a fracture. So metabolic workup was done, and then I had done and this was the thing I was going through all the papers for what is happening with what has gone wrong and what all I had done wrong. So yeah, so what I did, I went ahead and these are the refracture rates that I had going through, and plate had a lot lesser than the other implants that you were
plates will
talking
have
about,
a
sir.
higher refracture rate because of the shielding effect.
Yes, sir. Yes, sir.
That's
Stress
the
shielding was
problem.
one
So
very big
post
thing that happened
removal
here.
also we might have to keep the child around
Dr.
6
Anand,
weeks.
can
not
we go
like
to the next case?
Yes, 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 yes. So this is what I did. Sorry. Now he's doing good. So yeah, he's walking around. Thank you. Thank you.
Thank you.
Thank you. Thank you for the criticism. Thank you. Yes,
I
yes,
think
yes.
one of the points which I learned from one of the AO teachers long ago is they said that initially AO was very much pro plate and then they changed over to nail and they said it's meant for unsteady drinking, people who drink a lot and things like that in the beginning. And then suddenly the whole world has become, as far as lower limbs are concerned, they become drunkards and, unsteady guys. So I think the probably the take home from this that I'm taking is that nails are safer in the lower limb
Yes, ma'am.
than
Yes, ma'am. Yes, ma'am.
plates.
Yes, ma'am. Yes. Thank you. Thank you, ma'am. Thank you, Srikanth sir. Thank you, sir.
Now we invite Dr. Mrudula.
Good morning, everybody. I'm Dr. Mrudula. I work for Kim Sunshine Hospital. I'm a pediatric orthopedic surgeon. My case for today is mismanaged pediatric both bone forearm fracture, which is a very common fracture seen and most commonly mismanaged as well. So I would like to get few points from this discussion. So here is a 5-year-old boy. He had a fracture both bone forearm. He was treated conservatively, that is a closed reduction and an above elbow cast by an orthopedic surgeon at Rajahmundry. And the child also presented with a restricted pronosupination. So this is the immediate X-ray showing an apex volar angulation of around 20 degrees in the radius, which was, this is the first X-ray, and the 1 week post-op X-ray has shown some amount of correction. And the 3 week post X-ray is showing some radius angulation, which was then ignored. And finally, he presented to me at 2 months post cast removal with an apex volar angulation of radius at 34 degrees and ulna at 18 degrees. So at this point of time, how to manage this case? So is it, should we wait for remodeling because he's 5-year-old? Should we attempt a closed reduction casting? Should we do an open reduction casting or an open reduction TENS fixation?
How much is the supination pronation?
Pronosupination was 60 degrees, ma'am. So he had 30 prono and 30 supination.
And comfortable.
He is comfortable, ma'am.
I would wait for it to remodel. Because we have followed up forearms for more than 5 years, almost 6.5 years. And we found that the deformity starts to, unless there is a narrowing of the interosseous space, these kind of deformities are correcting gradually. And after 5 years, every year the deformities were decreasing by 20%. So there was hardly any deformed forearms left at the end of 5 years.
Okay.
So the deformity does correct, and in forearm diaphysis, they can correct for a very long time.
Roshan, sir?
So, madam, you are telling that the intraosseous membrane maintained well. You will wait for this all angulations to correct. But in
Duration
this
of
fracture, I think
Sir?
duration.
intraosseous membrane is
2
not
months,
very
sir.
well
2 months
maintained.
post.
Maybe the view, yeah, view is not correct. But yes, madam. I would also wait for it to remodel.
But it will do well with without, eventually it will disappear.
But what about the parents and the child's distress, ma'am?
So I think that's where you need to take parents into confidence. You should have some pictures from the thing and ask them, do you want a surgery or do you want the child to not have scars and get better eventually? If you can get them to trust you, I think in over 5 years it will correct.
Yes, sir. Shrikant, sir. Same, sir.
Definitely. Yeah.
Oh,
When most important criteria for me would be getting a true AP and true lateral
yes.
and assessing forearm pronation and supination. Because rotational
Yes.
component has a lesser degree to remodel. So if pronation supination is okay, then we can leave.
Okay. So,
Okay,
how should
madam.
have it been managed in the initial sitting?
The
Initial sitting, like whoever the treating orthopedic doctor was there, what could have been done? What were the mistakes done,
I
sir?
think 1 week post-op cast is correct. 3-week post-op cast is also, I would have accepted.
Ma'am,
But they
gap
should have-
index.
Huh?
Gap index, ma'am. Gap index, ma'am.
I understand that part, but at 3 weeks it would have sort of become quite
I would rather say what probably usually go wrong in this case is people think as a routine fracture where we give traction, counter traction, and do that angulation. We have to follow the principle of correcting the rotational component.
Yes.
If volar apex, it's a supination injury, you have to pronate, and then you cast it in supination or pronation. That's a different thing. It's a dorsal apex, you supinate because it's a pronation deformity. The rule of thumb should go towards apex of the. If that concept is followed in the beginning, I think things will be all right.
Okay.
We don't know because you are not the surgeon. No,
Yes, sir.
we don't know what was done.
Okay. So I couldn't gain much of the parents' confidence, so I had to do an open reduction and casting. So this is recently done, ma'am. Yes, ma'am. Yeah, I did an osteoclasis.
Percutaneous osteoclasis.
No, sir. I opened it.
Open. I mean,
Sir, not a very big incision, sir. It's a very tiny one.
Why did you not put a...
Yeah, that would be better. You would have prevented it for a longer period of time. Cast time will be
Same
reduced.
thing, again, the same problem repeats itself. It's possible, no?
A problem of implant removal again.
You have already operated. You might as well be safe now. You don't want to risk a problem.
Yes. So one small take-home message: always assess for the pronosupination in forearm malunions. Take a check X-ray immediate post-splinting. Never hurry to put an above elbow slab in casualty in pain. Always sedate, reduce, and apply. Consider applying a 3/4 circumferential slab at an initial sitting, neither a proper slab nor a cast. So this way we can have less chances of loss of reduction. 1 week post-reduction satisfactory, convert the same slab into a cast. Then weekly once follow-up at least for 3 weeks to check for the loss of reduction. If loss of reduction is there at any point, consider cast wedging, a forgotten simple old school science, and follow a good gap index when you're casting.
Thank you, Madam.
can we now call the...
Thank you, ma'am.
Have the next case, Dr. Arjun.
Thank you, organizing committee, for this opportunity. My name is Dr. Arjun. I am pediatric orthopedic surgeon working in Paramita Hospital, Hyderabad. I am presenting a case. This is 4-year-old male came to history of RTA and came to with complaints unable to bear weight and painful movements of both lower limbs. And we take an X-ray. This was treated outside. This X-ray is showing like this: right side mid shaft femur fracture, upper 1/3, and left side neck of femur fracture. Sir, what, Srikant sir? What you can do?
Age, I missed.
4 years.
4 years.
Here, fixation was both side because there is a polytrauma. That in my hands, I would put a Thomas Flint traction and then like that. But here, anyway, we are going to fix this. We can put a TENS on the right side. On
Yes,
the
sir.
left side, it is a mini DHS or a short plate or simple screws with spica.
So right side was treated with TENS nailing, that was healed very well, and left side was femur was. These are the treatment options like close reduction or hip spica, or close reduction or CC screws at the hip spica, or closure or open reduction with pediatric DHS, and close reduction and CCS with side plate. And treated outside by orthopedic surgeon with this, passing 3 CCS and followed by hip spica and immobilization and non-weight bearing. Madam.
I think in this particular situation, there is a dilemma. Now, if you don't put an extension plate on the lateral side, you may get a problem there because it will go into a malunion in varus. If you don't extend the screw into the head, you can again you can get into either varus plus non-union, or you can go because one of your screws touching the physis. When a screw touches the physis, it creates an instability in the physis because physis is not a rigid structure, so it will cause some inflammation because it moves. When it moves, especially because there is in between there is a fracture. When the screw moves, it creates inflammation that causes the physis to lift up and will cause the physis to displace. So if you are doing something like this, you should have a plate where the screws go into the head, and you should fix laterally because though you may not see it here, but it can happen many times that the whole thing goes into varus. Both sides you have to protect it.
Okay. This same thing is happened, and this is the 3 months X-ray, and the fracture is healed well, but there is a slip at the physis, and the patient complains of pain and again, and we operated with, and we passed the screws this time, passing the head and sacrifice the physis, and this is the follow-up X-ray after 3 months. But now the screws are penetrating into the joint and touching the acetabulum.
This is very unsafe. You're going to get a chondrolysis without doubt. So I think you should withdraw the screw and exchange it for shorter screw or leave it prominent outside.
Yeah, this is already 3 months, ma'am. We are planning to do implant removal and wait for recovery of femoral head to recover from AVN.
You are also having AVN, so I would suggest AVN since it's not yet collapsed. You should give a bisphosphonate either intra-articularly or IV.
Okay.
At least for 3 cycles if you're giving IV, or intra-articular, I don't know because I don't give, but some people do. That is another possibility. But if you give bisphosphonate, it's got 2 advantages. It decreases the
Chances
inflammatory reaction and the synovitis in the joint because you're also getting a subluxation. And secondly, it will prevent the collapse of the head.
Add to one point, madam. If we see the inferior aspect of the neck there, it seems to be there is not a slip but also a small fragment of bone of the neck. So is it a refracture? Can you go back to the previous X-ray? Is it a refracture or it's a slip?
I think it is a
There's a
slip.
metaphyseal bone there along with
No, I
the
think
physis.
that is because when the physis slips, it's slipping with the periosteum. So that is forming new bone. That always happens.
And would a valgus osteotomy be helpful?
At a later stage, I think
You can wait
now,
and
when there is AVN, if you do a valgus osteotomy, you will uncover a head which is about to collapse. So wait till the AVN heals. After that, you can plan for a
valgus osteotomy later stage. Thank you.
Thank you, Dr. Arjun.
Thank you, Arjun. Next speaker is
Dr. Santoshini.
Santoshini.
Good morning, everyone. I'm Dr. Santoshni, pediatric orthopedician from Amur Hospitals. Today, I'm going to discuss a case that is puzzle of pediatric trauma. That is elbow. We have too many ossification centers. We may get confused. It's not. Seven-year male child. There is history of trauma. Srikanth sir, is it acceptable?
No, the radiograph is not acceptable. We have to get a true AP and true lateral. That's everything. Here, just now we had a
From
talk.
what is visible?
Yeah, radiocapital line you have to draw. It's a Monteggia fracture.
Yes.
Yeah.
Any forearm fractures, the prerequisite is you need to have a joint above and below in a true view.
Yes.
So that's probably missing here.
Yes, sir.
Victim is any isolated ulnar fracture is a Monteggia lesion until proved otherwise. You have to prove yourself that it is not Monteggia.
Yes. What we see is what you said is right, sir. Monteggia fracture. What to do, ma'am?
Okay, first thing I would like to get a proper radiograph done first. That would be my priority. Many a times surgeons tell that the child is not cooperative. That is excuse. As a surgeon, we should accompany the child, probably get the proper view done.
Yes, I accept that.
And mostly it will come out like a Monteggia only. That's what is because
Yes.
the ulna is also fractured and radial head in this view also looks away because in whichever amount of flexion you see, if you draw the radiocapital line, you will know that where the radial head is heading to.
Okay. So he underwent close reduction and casting by general orthopedic surgeon. 6 weeks post cast removal. This is the X-ray.
Do you have the cast X-ray? No.
No, sir.
It's not there.
Next. This is the 6 weeks post cast removal. There is radial head dislocation and proximal ulnar fracture. What to do next?
The opposite side elbow, do you know what? 7-year-old, no?
Yes,
It
ma'am.
says 7-year-old medial epicondyle should be there. So where is the medial epicondyle in this? Did you check for it on the opposite side?
Yes, ma'am. We have to check.
It is there?
No, ma'am. It's not there.
Okay.
It was treated elsewhere, ma'am. What to do now?
Treat it like a chronic Monteggia.
Yes, sir. It is a chronic
Angulation osteotomy of ulna.
Yes, sir. So again, what could have been done to prevent this initially?
So as we discussed initially, a proper radiograph would have told us that this has happened, and then a close reduction in hyperflexion would have reduced this fracture well, and the story would have ended there most probably,
Yes.
instead of landing here.
This is type 1 Bados classification, type 1 Monteggia fracture. Closed reduction, correction of ulnar bow and cast in hyperflexion was done.
That's what was required, but
Yes,
probably
sir.
it was not done.
So again, after 6 weeks, X-ray is like this. So there, someone has done nailing for ulna. Still, radial head is not reduced. What do you think, sir?
Not nailing, we need angulation. That was not followed here.
Yes, sir. We need definitive fixation for this. Nail won't be suffice. Still radiocapitular line is not aligned. What next?
The probably thing what was missed here is doing a proper angulation and fixing with a plate, because your rush nail probably they have tried to correct the angulation, but they did not fix it well.
Yes.
So still that instability was there.
I think what the mind doesn't know, your hand are not going to undo.
Yes.
So if they, since they're not even aware of the
Radial head.
head dislocation, they have not concentrated. Even when they were doing this, if they had noted that the
They
radial
didn't
head was out, they
concentrate
would
on
have
radial head.
opened the radiohumeral joint. They would have reduced it. That fracture was still mobile. They could have angulated it slightly to put it in position. So it would have been
Yes.
easier at that time. Now that this has been done, you have to go now next stage.
Yes.
I think one more round of surgery.
One
will
more
be
round of
required.
surgery. Primum non-necessary. Then what next? So again, same surgeon has done osteotomy and plating for ulna.
So they have listened to you and they have done a plating. They've done a plating, but the radial head is still out.
Radial head this
So
still
just
out. They
angulation is
didn't.
not enough. We have to do
Radial
something
head
to
has
the.
to be reduced. They
So
didn't
this is third
notice.
procedure.
Yes, sir.
What is the range of supination, pronation, flexion, and extension in this child?
Uh, he didn't come at this time, ma'am. At the end, he.
All things have been going on with him, still to present to us.
Because I think side by side, you need to notice that the ulna now looks very much shorter compares to the. Can you see that?
Yes, ma'am.
Because you
Yes.
have shortened the ulna a huge amount. That itself will now contribute it. Because when you do an ulna osteotomy, the ulna osteotomy has to be a lengthening osteotomy for radial head to go inside. If the ulna osteotomy is actually shortening osteotomy, you're making it impossible for the radial head to go inside.
Okay.
And let's see how short the ulna is now.
Then fourth procedure is done by us. Corrective ulnar osteotomy and plating and radial head was reduced. Okay.
AP view. Uh,
Yes.
A good Montague surgery is not just angulation. Key to doing a good Montague, because angulation can itself sometimes shorten it. Key to doing it is it's a lengthening angulation osteotomy. It's never just a plain angulation osteotomy. So usually you're supposed to put a graft and lengthen it at the same time. About a 1 centimeter on one side graft, if you use, it will lengthen it at the same time.
Oh.
You can afford to go and do shortening only if you are already quite short.
Yes.
You can do just angulation if it's very, very short. Even then, if you do a gross angulation, you can shorten ulna and again make it difficult for radius to reduce.
Previous surgeon has put some allograft also, which was removed in this stage.
this phase, step cut osteotomy was done so that they get a length also and also the bone contact. That's what probably was done.
Secondly, is when you are going back to correct it. Now, this has happened. When you are going back to correct a failed Montagia, your ulna was relatively straight. So you don't touch that area, you leave that. The best place to correct a radial head relocation will be and just at the neck area of the neck of the radius. Because if you do your osteotomy there, you've got the greatest leverage and greatest chance of correcting a radial head movement with very little change in your angulation there. If you do it far away, it will be like those Paley's thing. No, you're far away from the cora, so you have to do big displacements. When you're close to the cora, you've got to do small displacements.
Is radius shortening is also recommended one in severe or difficult cases?
Not for the Montagia. Radial shortening I've done for HME and things like that, where there is a massive difference and I cannot get anywhere near, then I will do the radial shortening. Not for this condition. There are some conditions where you will do radial shortening, but not a trauma, not this kind of patient.
Radial head is reduced now. Radiocapitular line is maintained. Re-injury after 6 weeks, there is wound dehiscence and plate got exposed following re-trauma. What to do now?
Can we rush through the slides?
Yes. Yes. Then fifth procedure, because of wound dehiscence and plate got exposed, we had to remove the plate, debridement, suturing, and POP was applied for temporary stabilization.
Next.
6 weeks post plate removal.
This is the status. There is healing of ulna and radial head is still in place.
Yeah. So because the head is in place, but the healing is not very good in the ulna, we need to protect it for a longer period of time. Because doing any operative procedure now to fix it or do a interim surgical thing is will be out of question. So protecting it for probably 3 months more with a forearm brace would be better.
Okay.
Thank you. Thank you, doctor.
Thank you very much, madam.
Thank you, sir.
Thank you.
This ends this session. We thank all the
Thank you,
speakers and we request them to come on to the dais for a small felicitation with our organizing secretary. We thank the chairpersons for sharing it. It was an entertaining topic, sir. Most commonly seen and most commonly missed things. We thank all the three chairmen for this session. Thank you. Now we get into an Oasis program. So this program is with respect to the Oasis committee is invited onto the dais. I request Oasis President Dr. Vijay Chandra Reddy garu to come onto the dais, please. I request President-elect Dr. Shivakumar sir to come onto the dais, please. I request Secretary General Dr. Roshan Kumar garu to come onto the dais, please. I request Oasis Treasurer Dr. Manjunath garu to come onto the dais. I request Oasiscon 2026 Organizing Chairman VCR sir is already here. I also request Dr. Ramkumar Reddy sir, Organizing Secretary, to come on to the dais, please. This is with respect to announcement of the academic work, that is with respect to the PG and consultant gold medals. Apart from that, there would be a takeover of the Secretary General of Oasis. All the big guns of Oasis are here. We request all of them to be at the center stage.
Very good afternoon. We are here today. We had Dr. A. John, consultant best paper session today morning. Also, best PG paper session held in different halls today. And we had 3 judges for each session. And they have selected the winners of the A. John Consultants Gold Medal winner. And the Dr. A. John Consultant Gold Medal for consultants goes to Dr. Vinay Kandukuri from Telangana. I request Dr. Vinay to kindly come onto the stage and receive the medal.
Dr. Vinay. He's unavailable probably.
Yeah, no problem. Sir, please come over to this.
His father, another senior doctor, colleague of us. We request Ramkumar sir to receive.
I'm extremely sorry that he is not available. He's just gone out. I don't think that it's wise to wait for him to come here. On behalf of Vinay, if you permit, can I receive it? Yeah. Thank you.
And the Oasis Best PG Paper Gold Medal goes to Dr. Rajiv Reddy from Telangana, from Hyderabad. Dr. Rajiv Reddy, if you're around, please come and receive your medal. Okay, looks like he's not there. Now I take this opportunity also to hand over the secretary post to the incoming Secretary General, Dr. Naresh, and also Secretary General elect for this year would be Dr. Vijay Raghavan from Pondicherry, and Treasurer Dr. Manjunath's term is also getting over this year, so we are handing over the Treasurer post to Dr. Moparthi Srinivas as nominated by the Secretary General elect. So I just ceremoniously I will hand over the book, Secretary General Office book, to Dr. Naresh now.
I think for the last 3 years, Dr. Roshan as Secretary General has done excellent work and he was very active and interactive. Let us all applaud. Today is the last day for Dr. Roshan as Secretary General. Your services will be well utilized for the years together by Dr. Naresh. He needs your help, please. Yeah.
Consult your directory and call again or ask your operator for assistance.
This side.
This is a recording.
Everyone. Yeah. Is only book or treasure also there? So the organizing committee wants to felicitate Secretary General. No. Yeah, we used to disturb even in midnight. Thank you very much. So we will felicitate the new secretary, Dr. Naresh. For the accounts which are very transparent for all these 3 years, Dr. Manjunath is being felicitated. Thank you. Dr. Rakesh, please take over.
Thank you very much, sir. Great changing of hands. Reminds me of many old things that we did in 2014. VCR, sir, as Secretary General and myself as Treasurer of that association then. Thank you very much, sir. Thank you very much to all the dignitaries. One minute, please. Yeah. There is a next Oasiscon is being held in Tamil Nadu. Mathura specifically. Dr. Vishnu Kumar sir will be
అంటావా అమ్మవా ఊ అంటావా అమ్మవా కన్నలే ఎనర్జీ పెట్టే బేబీ హాట్
Thank you very much, Shivakumar sir. You made a nice thing. Let's all go to Tamil Nadu for the next conference. We are all there with you, sir. So next in this today's program, we are going to go ahead with okay.
Session.
Marat sir. Marat sir, అన్ని ఇందులోనే లోడ్ చేసి
ఇక్కడనే ఉన్నారు. Yeah. We also have Dr. Rajiv Reddy sir, who has been selected as Tosa PG Gold Medal Consultant Gold Medal Paper this year. We request the Oasis President, the Organizing Secretary Ramkumar sir and Roshan sir to kindly present Rajiv Reddy for this medal. Why replace when you can reuse? Extracorporeal radiation therapy, surgery in bone tumors. It was an interesting topic, well selected. Chip Oasis Gold Medal Consultant Paper. Just give him a round of applause, please. This awakens the crowd in the hall, I believe. More enthusiasm from crowds, enthusiasts, the speakers too. Now the oration is going to start. I request Tosa President Dr. Ramkumar Reddy garu to come on to the dais, please. We're extremely honored to have you with us, sir. We have Tosa Secretary Dr. Jaganmohan Reddy, sir. I request him to come on to the dais, please. Thank you, Jagan, sir. Always active, enthusiastic.
Welcome to all. Now we are proceeding with the orations. Now I request the orator of past president's oration, Dr. Y. Timmareddy Garu, onto the stage to deliver Dr. A.S. Rao Memorial past president's oration. I request my secretary Jagan Mohan to brief about the A.S. Rao sir and also the orator.
Good morning, all. ముందు చెప్తా. Yes, sir. So good morning. It's a past president oration in remembrance of Professor A. Srinivasa Rao sir. So Professor A. Srinivasa Rao sir was born on 2nd of July 1940, represents a generation of orthopedic surgeons who combined exceptionally clinical ability with academic excellence, innovation, teaching, and institutional leadership. He completed his MBBS from JIPMER Pondicherry in 1962, followed by MS Orthopedics from AIIMS, New Delhi in 1968. His academic pursuit later took him to the Hospital for Special Surgery in New York, USA, where he undertook a fellowship in orthopedic pathology in 1981. His distinguished teaching and professional career spans several decades. He served in various academic positions in government medical colleges in Andhra Pradesh and went on to become professor and HOD orthopedic departments at NIMS, Hyderabad. His leadership and responsibilities extended beyond the department to major administrative positions, including Additional Director of Medical Education, Principal of Gandhi Medical College, Hyderabad, and Superintendent of Gandhi Hospital, Secunderabad. He subsequently continued his clinical work as a consultant in Hyderabad, including in the fields of general orthopedics and orthopedic oncology. Professor Srinivasa Rao sir has made important contribution to research and indigenous innovation. During his academic career, he was a research fellow at All India Institute of Medical Sciences, New Delhi, and contributed to the development of a low-cost shank for immediate post-surgical prosthetic fitting in below-knee amputees. His academic and professional excellence has been recognized through several honors, including Johnson & Johnson Traveling Fellowship and Bombay Orthopedic Society E-Merck Fellowship, and the Wagner's Gold Medal for Best Paper and other awards recognized his professional and social contribution. As an outstanding teacher and mentor, Professor Srinivasa Rao sir has delivered numerous orations and guest lectures, served as a faculty for orthopedic courses and postgraduate teaching program, and act as a postgraduate examiner on multiple occasions. He has also represented the state orthopedic fraternity at the national level and contributed extensively to the organization of the conference, educational program, and courses in the prosthetics and orthotics. His academic contribution includes 27 publications at national and international journals. He has served as a sectional editor of the textbook of orthopedics by V.S. Kulkarni. His innovative contribution included double contrast orthography of the knee using existing equipment, a low-cost shank for immediate prosthetic fitting, and metal clock for Jaipur type of calipers. His commitment to the orthopedic professional is further reflected in his association with several professional organizations, including Indian Orthopedic Association, AP chapter of IOA, Orthopedic Society of Twin Cities, Association of Spine Surgeons, Hyderabad Surgeons Society, Indian Medical Association, and Indian Orthopedic Rheumatology Association. The Professor A.S. Rao sir oration at TosaCon 2026 honors not merely an illustration professional career, but a lifetime devoted to the advancement of orthopedic care It celebrates the value that the Professor Srinivas Rao sir has represented throughout his distinguished journey, excellence in teaching, clinical leadership, scientific inquiry, innovation, mentorship, institutional development, serves as an orthopedic thing. Though this prestigious oration, TOSACON 2026, pays tribute to the legendary teacher whose influence has extended across the generations of orthopedic surgeons and whose contributions have helped shape the development of orthopedics in our region and beyond. There are a few photos of Dr. A.S. Rao sir. A great teacher does more than impart knowledge. He creates a generation that carries knowledge forward. TOSACON 2026 proudly honors Professor A. Srinivas Rao sir, past president oration, for his outstanding contribution and lifelong service to the orthopedics. May I request President sir, Ramkumar sir, to felicitate past president. Yes. Projective. Sir, Dr. Thimareddy Ingala sir is a professor and head of the Department of Orthopedics, Usmania Medical College and General Hospital at Hyderabad. Dr. Thimareddy sir is a distinguished orthopedic surgeon, academician, teacher and administrator whose professional journey has been closely associated with Usmania Medical College and General Hospital, Hyderabad. An alumnus of Usmania Medical College, he's completed his MBBS from 1986 to 1991, subsequently pursued MS Orthopedics from Usmania Medical College General Hospital between 1995 to 1998. He secured a gold medal in general surgery. He is an examiner for postgraduates and undergraduates for last 2 decades, and he is an examiner for DNB Orthopedics. And over the course of academic career spanning more than 2 decades, Dr. Thimareddy sir has progressed through the ranks of assistant professor, associate professor, and professor and head of the Department of Orthopedics. He also served as a professor and HOD of Orthopedics at Government Medical College, Nizamabad, professor of Orthopedics, KMC Warangal, before returning to Usmania Medical College. Since December 2018, he has been serving as a professor and HOD, Department of Orthopedics at Usmania Medical College and Usmania General Hospital. His contribution to orthopedic care in the public sector has been substantial. He has been instrumental in introducing and advancing orthoplasty and arthroscopy procedures in the government hospital settings, has performed more than 1,000 joint replacement surgeries in government teaching hospitals. His contributions has extended beyond his own institutions through the upgrading of orthopedic services and mentoring of surgeons in newly established government medical colleges across Telangana. A committed postgraduate teacher, Dr. Thimareddy sir has consistently emphasized practical skill development, structured training, and academic accessibility for young orthopedic surgeons. His leadership within the Telangana Orthopedic Surgeons Association has been particularly noteworthy. During his presidential tenure, he has initiated short-term fellowships within Tosa, providing young surgeons opportunity for focused subspecialty training. As a part of his presidential academic vision, he organized 12 hands-on postgraduate workshops across Telangana, placing practical surgical education at centers for association of activities. He also successfully led TOSACON 2021 in a hybrid format during COVID-19 pandemic, reaching more than 1,000 delegates. through digital and virtual participation. Since 2018, he has spreaded the home Hyderabad Orthopedic Medical Education Program at Usmania Medical College and subsequently translated the program to a virtual platform during the pandemic. His organizational ability were further demonstrated when he served as a treasurer for IOCON 2014 in Hyderabad, contributing to the successful conduct of the national conference. Beyond the academic and clinical practice, Dr. Timareddy sir has remained actively involved in community initiatives and is a member of Indian Orthopedic Association, Telangana chapter of IOA, Twin Cities Orthopedic Society, Spine Society of India, Indian Orthoscopic Society, and Foot and Ankle Society. And his career exemplifies the value of service, teaching, surgical excellence, mentorship, and institutional development. Through his contribution to government sector orthopedics and his commitment to training the next generation of surgeons, he has made a lasting contribution to orthopedic education and patient care in Telangana. It is therefore a privilege and honor to recognize the professional journey of Dr. Timareddy Engala sir through this oration and to celebrate a career dedicated to advancing orthopedics through knowledge, skill, leadership, and service. We warm welcome, sir. Ladies and gentlemen, it gives me immense pleasure to invite Dr. Timareddy Engala sir to deliver this prestigious oration. Sir, we warmly welcome you and request you to take the podium.
తెలుపుతారా కొంచెం ఓకే గుడ్ గుడ్ ఆఫ్టర్నూన్ గుడ్ మార్నింగ్ గుడ్ ఆఫ్టర్నూన్ రెస్పెక్టెడ్ seniors, my teachers and my dear friends and my beloved students and respected chairpersons. This photograph, I never expected this would have been the last photograph I have taken with A.S. Rao sir. After that, I could not meet sir. And this is the one I believe. Guru Brahma, Guru Vishnu, Guru Devo Maheshwara, Guru Sakshat Parabrahma, Tasmai Sri Guru Namaha. This is exactly fits for sir. I am very fortunate to deliver today Professor A.S. Rao sir, past president oration, who is the Professor Emeritus and who is the teacher for most of the present day teachers. As all of you know, during COVID times, Usmania Medical College organized virtual home for 3 days. During that period, Professor A.S. Rao sir has attended all the 3 days program as faculty, sitting continuously in front of laptop, wearing blazer and tie with full suit, despite he is on dialysis twice a week. It is a pure passion that drove him towards teaching, which always inspired me. On that basis, this is my oration on roots, responsibility, and reforms, and lessons from a life in orthopedics. The 8 pillars of meaningful career: roots, rigor, responsibility, reverence, reforms, relationships, resolve, and reflection. These are the pillars of professional career that makes a meaningful life. I will deliver lessons from my orthopedic life in these pillars as chapters. The privilege of being orthopedic surgeon. We restore independence. Every fracture and joint we fix is a life we put back in motion. We are privileged to attend every stage of life, from newborns to elderly. We work with hope. Patients come with trust. Our aim is to make sure that our patients should live with happiness. Of all the professions one could choose, few only have the privilege of relieving pain, restoring movements, rebuilding confidence, and witnessing gratitude almost every day. That is why being an orthopedic surgeon is not merely a career. It is a lifelong privilege and profound responsibility.
Every surgeon remembers the first patient who walked again because of their efforts. This oration is not a story of achievements. It is a reflection on the values that shape a surgeon, a teacher, and a responsible citizen. If even one young surgeon leaves this hall inspired, not only to be a better surgeon, but also to be a better human being, this talk will have served its purpose. My journey in orthopedic life, a journey that began as a young medical student with dreams, continued through countless nights in emergency theaters, evolved through setbacks and successes, and eventually became a journey of service as an orthopedic surgeon, a teacher, and president of Tosa. Chapter 1 Roots. A surgeon is not shaped on the day he performs his first operation. He is shaped long before that by his family, his teachers, his values, and the choices he makes when no one is watching. The foundation that shape a surgeon, family values that instill duty, and integrity has made me what I am today, and I am indebted to my parents and my family for the same. Long before medical school, discipline, honesty, and responsibility was taught by my family. Medical college teaches more than anatomy. It teaches empathy, teamwork, resilience, and professionalism. Knowledge begins in classrooms while wisdom begins in the wards of the hospital. Observation. Best things from my postgraduate learning was observation skills. Learn to observe. Learning what not to do is also important. For that, you should keep observing everything around you. Observe patients, observe seniors, and also staff, nurses, and technicians exactly what they are doing, and also learn from mistakes and complications by observing them. Fellowship. From competency to mastery. A fellowship gives an opportunity to explore your field of choice. It gives you focused exposure, mentorship, refinement, repetition, networking opportunity, and innovation of ideas. Residency teaches you to become a surgeon. Fellowship teaches you to become the surgeon you aspire to be. Humility. Humility makes learning possible. Learning is a continuous process with no expiry. Attend conferences and workshops and training programs. And remember, arrogance stops learning. A surgeon who stops learning means stop growing. Patients. Patients are very important. Every patient is a teacher. Some teachers respect. Some teachers humility. Some teachers patience. Some teachers courage. Everyone leaves a message to us. Surgeon leadership qualities. Medicine is one profession where success is defined by patient's recovery. A successful surgery is always a team effort. Build leadership as a surgeon and lead the team. We are recognized not by our degrees but by our success. Chapter 2 Rigor. Every expert surgeon was once a beginner who refused to quit. The discipline of young surgeon during PG training. PG residency teaches responsibility. It is the transition from observing to doing, from answering questions to making decisions, from reading textbooks to treating patients. Talent may open the door, but discipline determines how far a surgeon will go. Residency is measured by not hours of work, but by commitment, emergency calls, endless dressing changes, theatre after the theatre, uncounted patient counseling. Fatigue teaches endurance, repetition creates confidence. The courage to admit mistakes. Every surgeon makes mistakes. The difference lies in recognizing them, learning from them, preventing repetition. Failure is a poor teacher only when we are refused to learn from them. One complication analyzed honestly teaches more than 10 uncomplicated cases. Judgment, decision making. Judgment develops through experience, mentorship, and reflection. A good surgeon knows how to operate. A better surgeon knows when to operate. A great surgeon knows when not to operate. And learn patience. Some residents are naturally gifted, others are simply consistent. Over time, discipline always overtakes the talent. Great surgeons are built through thousands of small habits. Patience is one such key habit. Remember, the operation is not finished by the end of the suturing. It finishes only when the patient recovers. Next, every day is new beginning. No matter how experienced we become, every operation deserves the same preparation, same concentration, same humility. Complacency is the enemy of excellence. There are 7 disciplines that shape a surgeon for life. Read every day, observe carefully, Practice deliberately. Respect every patient. Question yourself. Remain humble. And last, reflect after every case. Chapter 3 Responsibility. Patients trust us at their most vulnerable moments. The trust is sacred. The duty we owe our patients. Every patient entrusts us with their future. Remember, and I believe, when they sign the consent form, it is the trust, which is the greatest honor of our profession. The most important quality of a surgeon is not skill or knowledge, it is responsibility. The first responsibility is to listen. Patients often tell us their diagnosis and investigations they did already. Interrupting them is the first mistake. Some patients need our ears before scalpel. Honestly, patients accept bad news. They accept complications. They even accept failure. What they cannot accept is dishonesty. Truth delivered with compassion is always better than false reassurance. The courage to say, I don't know. No surgeon knows everything. The professionalism means recognizing limitations, seeking help, referring appropriately, asking seniors when needed. I was fortunate to mentor my colleagues at various new medical colleges in starting arthroplasty services at their places. Responsibility extends beyond OT. Our duty does not end when skin is closed. It continues through pain management, rehabilitation, follow-up, learn, and long-term care. Successful surgery ends only when the patient returns to life. Responsibility towards patient's family. Patient suffering means a family is suffering. One honest conversation can relieve hours of fear of the family. Good communication is as good as any medicine. Responsibility towards teaching. Teach your colleagues, mentor them. As Tosa president, all of you know, we organized 12 hands-on training programs for postgraduates. More than over 500 postgraduates has been trained in this program. Home, Hyderabad Orthopedic Medical Education. We are continuing the legacy started by our teachers, mentors, in training as many as 5,000 postgraduate students, young professionals so far, not only in the state but also across the nation. We are glad to share the news that we are conducting Silver Jubilee Home this year from Osmania Medical College. The 5 responsibilities of every surgeon. Responsibility to patients. Provide safe, ethical, compassionate care. Responsibility towards colleagues. Respect, collaborate and support. And to students, teach knowledge and values generously. To society, provide advanced health care beyond personal success. And responsibility towards yourself, you should remain humble. As surgeons, we believe our greatest responsibility is to perform successful operations. With experience, we realize our true responsibility is much greater to earn, preserve the trust of every patient. Skills may define our profession, but responsibility defines our legacy. Chapter 4 Reaching for Excellence. The joy of lifelong learning. Medicine is a science, is unique. Unlike many professions, what we learned yesterday may not be the best treatment tomorrow. Knowledge evolves, evidence evolves, technology evolves, therefore, surgeon must also evolve. Excellence is a continuous cycle, not a final achievement. Cadaveric training to reach the excellence. Graduation is not the end of the education. It is the beginning of self-education. Cadaveric courses are opportunity to refine and fine-tune the craft. The day we stop learning means we stop growing. Conferences and CMEs, lifelong learning, it is ethical responsibility. Patients deserve today's best treatment. Keeping updated is not optional, it is a professional obligation. A degree qualifies us to begin. Lifelong learning allows us to remain worthy of our patients' trust. Curiosity is the fuel of the growth. How can this to be done? We have to be done better. We have to question ourselves. Curiosity transforms routine surgeons into innovators. Technology changes, evidence changes, techniques may change, but principles remain the same. Robotics may replace many things, but not the judgment. Evidence must guide the experience. Experience is invaluable, but experience alone is not enough. The best decisions occur when clinical experience meets scientific evidence. Evidence refines experience. Experience reciprocates evidence. Publications. Publications reflect our work. Publications contribute in decision making. disseminating knowledge and experience. The operating theatre tells us what happened, but research asks why. Publication ensures that the lesson is not lost. Publish or perish. Conferences inspire growth. A conference is an opportunity to exchange ideas, challenge assumptions, learn new evidence, build collaborations. Knowledge grows when it is shared. The ladder to excellence. Excellence is a journey built one step at a time. The steps to achieve excellence are read, research, learn, reflect, practice, teach, share to reach the excellence. Excellence is not an event, it is a lifelong climb. One simple truth I realized that in every stage of my journey, whether in the wards, OT, conferences, or academic meetings, is that excellence is never inherited and it is never permanent. It must be earned again and every day through curiosity, humility, disciplined practice, and unwavering commitment to lifelong learning. A surgeon who continues to learn never grows old in the profession. Chapter 5, Reproducing Knowledge. Technique Teaching gives immortality. The best way to master a subject is to teach it. Every teacher, every lecture focuses to read again, question again, learn again. Teaching transforms knowledge into understanding. Every operation has an end. Every career has an end, but teaching has no end. A student whom we teach today will treat thousands of patients tomorrow. A candle loses nothing by lighting another candle. Students rarely remember every lecture you teach, but they always remember the teacher who inspired them, who encouraged them, and who believed in them. Good teachers educate, great teachers ignite curiosity. Teach the why, not only the how. Residents may learn how to insert a nail, how to reduce a fracture, how to perform an arthroplasty, but they must also understand why this procedure, why this is implant, why this approach, why not another approach, option. Understanding creates judgment. The greatest gift a teacher should offer is not just technical skills, it is the surgical judgment. Surgical judgment is knowing when to operate, when not to operate, when to wait, when to ask for help. Surgical judgment separates a technician from surgeon. We started Tosa fellowships in subspecialties to provide opportunities to younger surgeons in the Telangana state. This platform gives an opportunity for them to observe and interact and to identify their interests and refine further. Mentorship. Postgraduates need more than instruction. They need encouragement. They need guidance. They need honest feedback. And we have to give good career advice. Mentorship uh, shapes the careers. Friendship sustains them. On this occasion, I would like to thank and I would be grateful to my mentors, Dr. Murthy sir, Dr. S.S. Reddy sir, and Dr. Ravindranath sir, Dr. Kodandapani sir, and my professor V.S. Reddy sir, and Anjaneyulu sir. I am really thankful to you, sir. What I am here today is because of you. This vision behind the whole program was that is Hyderabad Orthopedic Medical Education. Knowledge should travel, not the people. High quality education should reach every district. Every resident deserves exposure to experienced faculty. So Tosa President theme. As a part of Tosa presidential theme, progress with practical skills was translated into action through 12 hands-on workshops, empowering over 500 postgraduate students with practical skill-based training, covered multiple orthopedic specialties, training delivered through the experienced faculty and experts. Live demonstrations or techniques were demonstrated. Simulation-based practical learning as given and dedicated hands-on skill stations was allowed. Case-based discussions are discussed, and also supervised skill training for postgraduate training was provided in this under this theme. When I reflect on my career, I realize that some of my most satisfying moments were not inside OT. Those cherishing moments are in teaching that make young surgeons develop confidence, judgment, and compassion. Operations restore mobility, but teaching creates a legacy that continues to heal long after our hands become still. Reverence. My teachers corrected me, encouraged me, and sometimes criticized me. Today I realize those criticisms were acts of kindness. None of us become successful alone. Every one of us is standing on someone else's shoulders. Mentorship is not simply teaching surgery, it is teaching judgment and character. The greatest tribute we can offer our mentors is to become mentors ourselves. What mentors truly give: knowledge, judgment, when to operate and when not to operate, character, professionalism and humility, courage to speak truth and admit limitations, and compassion for patients and younger colleagues. Relationships. Leadership is not about authority, it is about creating opportunities for others. Associations are not numbers, it is unity. Ensuring every member felt included, young or senior, is motive of leadership in association. Association is building a community to belongs to everyone. Relationships are greatest investment. Professional success is built on trust, respect, and collaboration. Healthy relationships makes difficult work enjoyable. Your network is not measured by the number of contacts in your phone, but by the number of people who genuinely wish you well. Workplace. I always believe workplace is another home. We spend more times awake at workplace than home. Build your relationships with colleagues and they remain your lifetime friends. You need to motivate, encourage, maintain cordial relations with your colleagues for making your life easy. Workplace is second home. Enjoy your work. Reaching the Unreached, Chapter 8. Quality healthcare should never depend on a patient's financial status. I was fortunate to have a chance to expand complex trauma arthroplasty services in government hospitals, mentoring young surgeons in underserved conditions. Healthcare equity is perhaps the highest form of public service. Investments that outlast a career. Training centers. We have to establish training centers to train the junior surgeons. Arthroplasty in government setup. And mentorship, returns that benefit to the society for decades. These are the investments whose returns will benefit the society for decades. Now, Chapter 9. Resolve. Growing through challenges, the strongest tree grows in the harshest conditions. Here rock reflects obstacles, roots reflect values, trunk reflect character, branches reflect service, fruits reflect impact. Every career encounters setbacks, failures and unexpected complications. The strongest tree grows through rocks. Character is built not during success but during adversity. Failures taught me caution, success taught me gratitude. Obstacles never define us, but our response does. Disability to mobility. We see bad times in a tough way. We should learn from our patients who are transformed by us from their tough times to be normal again. The greatest outcome of an operation is not a radiograph. It is the functional outcome that brings in mobility from disability. Chapter 10. Reflections. Orthopedics has been a profession that continuously shaped me into a better person. What this journey has taught me: patience taught me humility, students taught me accountability, colleagues taught me teamwork, failures taught me caution, success taught me gratitude. At the end, no surgeon remembers the number of surgeries performed. We only remember patients who smiled again, students who became good surgeons, colleagues who became lifelong friends. Awards fade, titles change, only good deeds remain. To the young surgeons in this hall, master your craft, protect your integrity, teach generously, lead with humility. Never forget that every operation begins with science but ends with compassion. The greatest reward is not recognition, it is the life in work. Thank you.
Thank you, sir. Your very enlightening and your lifelong journey in one half an hour. Thank you very much. Okay.
తీసుకెళ్ళాలి
end, 'cause we are hand in hand. So what if it's the end, 'cause we are hand in hand.
May I call him Dr. Timmareddy sir, madam and daughter.
Madam, please.
Please
sorry,
come on to the
for a
dais.
group photo.
So what if it's the end, 'cause we are hand in hand.
రూపం మసలనేమో మీ మనస్సున ఆర్తసేవను సంఘ సేవకు మేళవించిన అమృతమూర్తివి ధ్యేయ పథమును వీడకుండా సంఘమంత్రము మరువకుండా సంఘ జీవన సరళి ఇది అని సరళముగా బోధించినారు సత్యమూర్తి అమృతవర్తి సంస్మరింతుము మిమ్ము నిత్యం మా మనోకుసుమాలు పూచను మీదు పదముల నర్చించనేడు వేనవేలుగా ఆర్తజనులా పాలిటా నారాయణుడవు దిక్కులేని ధనం లేని పేద ప్రజలకు అభయమూర్తివి మిమ్ము చూచినంతలోనే వ్యాధి వ్యాకుల పడెడు నందురు మీదు హస్తం రోగిపైన అభయమై కనపడునటందురు సత్యమూర్తి అమృతవర్తి సంస్మరింతుము మిమ్ము నిత్యం మా మనోకుసుమాలు పూచను మీదు పదముల నర్చించనేడు సత్యమూర్తి మీదు దేహం సత్యమై సాకారమందెను సేవకే పరిభాషయయ్యను ఆదర్శ జీవన కుసుమమయ్యను భరతమాతా మీదు సేవకు మురిసిపోయెను ప్రతిక్షణమునా బాలికై మీ సేవలంది హసితయై మీ సేవలంది పరవశించను మనసునందున సత్యమూర్తి అమృతవర్తి సంస్మరింతుము మిమ్ము నిత్యం మా మనోకుసుమాలు పూచను మీదు పదముల నర్చించనేడు.
Thank you, everyone. May now take the honors of inviting the senior most orthopedic surgeon, very much associated with VSN Murthy sir, Dr. Raghuram sir, to come forward and light the lamp.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते
Next, I request Oasis President and another contributor with him, VCR sir, to light the lamp. Matko. Such was his soul that it attracted so many people across Telangana now, and even in the United Telugu states, he was such personality which demands this amount of respect for him. Thank you, everyone. I'll share few flowers, and all of you can put before sir.
आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः 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 शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु
Any students who are there, if you want to pay respects, you can come here. Ravikiran sir. Anyone? All the students of Murthy sir. Bangar Swami sir.
Thank you all. I request our Tosa Secretary, Rajanu.
Yes, sir.
Please read
We'll-
out our biodata of the VSN Murthy and we'll proceed
call-
with the oration.
Yes, sir. We'll call the Dr. Ajit, sir.
For this, I will call upon Dr. Ajit Kumar Shettigaru onto the dais for delivery his lecture. Okay. చేరే అక్కడ మధ్యలో చేరేసాడు.
Sarvesham Shanti Bhavatu.
Tony. We'll start the second oration. Professor Dr. Vedula Satyanarayana sir oration, The Legacy of Service, Teaching and Orthopedic Excellency. Professor Vedula Satyanarayana sir was an eminent orthopedic surgeon, dedicated teacher, committed clinician, and respected humanitarian whose contribution to our orthopedics continues to inspire generations of surgeons. Born on 15th of February 1951 at Kotapet, in East Godavari district, he completed his early schooling at Kotapet and joined Andhra Medical College, Visakhapatnam in 1967 for his MBBS. He subsequently pursued post-graduation training in orthopedics at Andhra Medical College. His distinguished academic career at Kakatiya Medical College, Warangal began in 1978 when he joined as an assistant professor of orthopedics. Through commitment to clinical excellence and teaching, he progressed academically and was promoted as a professor of orthopedics in 1995. Professor Vesan sir was remembered as a selfless, dedicated, and deeply committed orthopedic surgeon who devoted himself wholeheartedly to patient care. His commitment to the hospital was exceptional, and he was known for remaining available to his patients virtually round the clock. At the same time, he trained and mentored numerous undergraduate and postgraduate students, earning a reputation as a strict discipliner and inspiring teacher, and above all, a true gentleman. His surgical work covered a broad spectrum of orthopedics, including complex trauma, poliomyelitis related deformity corrections, and tumor surgeries. He was instrumental in introducing total hip replacement at MGM Hospital, Warangal, and pioneered the use of Meyer's magical pedicle graft procedure in his institution. His academic contributions were presented through numerous papers at state and international conferences. A surgeon ahead of his time, Professor Mutsar is also remembered as the first person in the state to perform titanium prosthetic hip replacement and pelvic surgery. His enthusiasm for continuing medical education remained exceptional throughout his career. He regularly attended the state and national conferences and CMEs and was recognized with the Best Participant Award at National CME in Indore. Beyond the medicine, he was deeply involved in social services and contributed actively to community activities. His professional life reflected a rare combination of surgical skill, academic curiosity, discipline, compassion, and social responsibility. In 2001, Professor Murthy was diagnosed with primary hepatocellular carcinoma and underwent hepatic transplantation in England. Remarkably, following his return, he resumed his professional responsibility and continued performing major orthopedic surgeries with the same commitment and determination that had characterized his entire career. Professor Vesan Mutsar passed away on 30th of March 2003. His physical presence may have been lost, but his influence has endured through the innumerable students he trained, the patients he served, and the institutions he helped strengthen them. His students and disciplines have continued to honor his memory by organizing the CME programs in his name since 2004. At Kakatiya Medical College, football tournaments and blood donation camps have also been organized in his memory, an enduring testimony to the affection, respect, and admiration he inspired among his students and colleagues. Professor Vesan Murthy sir's memorial oration is more than a scientific lecture. It is a celebration of values that defines the finest tradition of orthopedics. Professor Vesan Murthy sir's life reminds us that the true legacy of a surgeon is measured not merely by the operations performed, but by the patients healed, students inspired, standards established, and values passed on the next generation. We remembered and salute Professor Vedula Satyanarayana sir for his exemplary commitment, selfless service, and lifelong dedication to the orthopedics and humanity. At Tosakan 2026, we proudly continues this tradition by remembering a remarkable surgeon whose influence extended far behind his lifetime. Great teachers leaves behind more than knowledge; they leave behind generations inspired to carry their values forward. May I request, Sir Miru,
Request the secretary to introduce the orator.
yes, sir. Yeah, please. Sir, for this Vedil Satyanarayana sir oration, sir, Dr. Ajit Kumar sir from Mangalore, he is giving this oration. Dr. M. Ajit Kumar sir is a senior consultant, HOD, Department of Orthopedics at Tejaswini Hospital, Mangalore. Dr. Ajit Kumar sir is a distinguished orthopedic surgeon, academician, teacher, and professional leader whose career represents an exceptional blend of clinical excellence, international training, postgraduate education, and organizational leadership. After completion of his D-Ortho and MS Ortho from Kasturba Medical College, Manipal, he pursued advanced orthopedic training in Republic of Ireland and the United Kingdom, working at several renowned institutes. He subsequently obtained his MCH in orthopedics from Liverpool, United Kingdom in 1995 and completed fellowship in pediatric orthopedics at Royal Hospitals for Sick Children, Glasgow. He was also awarded an AVO Trauma Fellowship in Germany and became Fellow of International Colleges of Surgeons. Since 1997, Dr. Ajit Kumar sir has been associated with Tejaswini Hospital, Mangalore, where his clinical practice encompasses complex trauma, primary and revision, and knee orthoplasty, knee arthroscopy, pediatric orthopedics, and navigation assisted and minimally invasive joint replacement surgeries. His contribution to the orthopedic education has been equally significant. He has served as a DNB faculty for 25 years and DNB examiner for last 15 years, while remaining actively involved in postgraduate training, teaching, instructional courses, cadaveric workshops, and live operating training. He has also contributed to the evaluation of postgraduate assessment, including the OSCE system in DNB orthopedics. Dr. Ajit Kumar sir has led several prestigious leadership positions. He is currently a chairman of AVO Trauma India for 2024 to 2028 period. He has previously served as a president of Indian Orthoplast Association, president of Karnataka Orthopedic Association, secretary of Canara Orthopedic Society, and secretary of Indian Medical Association Mangalore branch. And he has been closely involved in organizing numerous state and national academic meetings, including IOCON 2024 as an organizing secretary, in addition to several trauma symposium, AVA programs, instructional courses, and orthopedic conferences. Through decades of clinical practice, teaching, mentorship, and professional service, Dr. M. Ajit Kumar sir has contributed meaningfully to the advancement of orthopedic surgery and to the training of generations of orthopedic surgeons. It is therefore a privilege and honor to have Dr. M. Ajit Kumar sir to deliver this prestigious oration, and we look forward to benefiting from the experience, perspective, and wisdom of a surgeon whose career has been devoted to orthopedic excellency. May I request Dr. Ajit Kumar sir to take over the podium? Yes.
Sit there, Jagan, come.
Respected President of Telangana Orthopedic Association, Dr. Ramkumar Reddy, Secretary Dr. Jagannath, and the entire Executive Committee of Tosa. I am deeply humbled, extremely honored, and very privileged to be delivering this oration in the name of Professor Vedula Satyanarayana Murthy Garu. For a person to be remembered as such 22 years after his demise speaks volumes of the type of individual he was. So I hope what I'm going to say, what I'm going to speak in the next few minutes will do some justice, at least partially, to the great soul. Like I said, I'm extremely grateful to the organizing team headed by the President, Secretary, incoming President, and all the Executive Committee members, and also to the Oasis team, my dear friend Dr. Vijay Chandra Reddy, who must have played a role in getting me here because of our connections from Mangalore. At the outset, I must say I am a Hyderabadi by birth and growth. I grew up here, I studied here, I did my MBBS from Osmania Medical College. Jagan forgot to mention that in his most important part, I think that was. I'm extremely grateful to the God Almighty for bringing me up to this level to be able to speak upon a great soul like Dr. V.S.N. Murthy, and also to my parents for all the love and support that they had given me. I did work in NIMS as a junior resident when Professor Kakarla Subbarao first came over, and he was the one who ignited the academic spirit in me. He ignited the fire, which was carried on by Professor Srinivas Rao. I happened to be posted as a final year student in his unit in Osmania, as an intern in his unit in Osmania, and then I went over as a junior resident in Nizams, where I worked with him. And like Dr. Timaredi spoke, we've been greatly influenced by this great soul as well. My Professor Chako from Manipal, who taught us all the very fundamentals of orthopedics, and his team. I think Professor Mohanty is missing in this, the four of them. They were my guardian angels, so to say. They helped me in my career. And since then, I've been working with Dr. Shantaram Shetty in Mangalore, and he's been responsible for pushing me beyond my comfort zone. And I think that is what I'm trying to be addressing today. My team in Tejaswini Hospital, Mangalore, we have a fairly good team. We have about 6 residents per year, DNB students, senior residents, and junior consultants as well. So all has been spoken about Dr. V.S.N. Murthy, but when I actually heard his students speak to me the day before during dinner, it really gave me the goosebumps about the nature of this individual. So without all that has been mentioned, but I think to get the true spirit of this individual, it actually needs one to listen to the stories, listen to the respect that the patients, the students, and his colleagues have towards him. So, with that in mind, my respects to Professor V.S.N. Murthy Garu for his exemplary, committed, and selfless service to humanity. With this, I start off my oration. The Tosacon oration that I thought of is, this is the title that I chose. It is a sin to be good. I'll come back to what I mean by that at the end of my talk. Hopefully, you will be with me. And I'll start with a story. This is Karoli Takas, who was a sergeant in the Hungarian army in the 1930s. He was a sergeant who was an exceptional shooter, but he could not take part in the 1936 Olympics, which Hitler conducted because of his low rank in the army. A sergeant could not take part in those days. You had to be a lieutenant or a colonel to be able to take part, right? He was an exceptional shooter, but a grenade exploded in his right hand, the shooting hand, and it was blown off. Okay, I'll leave the story there and we'll come back to that later. So what does it take to be an Olympic gold medalist? You may be wondering why I'm talking about Olympics and gold medalists amongst doctors here and in an oration for Dr. V.S.N. Murthy. It needs talent, it needs passion, and it needs persistence. Probably the same values that Professor V.S.N. Murthy imbibed in all his students. And what does it take to be an excellent surgeon? It takes the same three things. Talent may be God given in some instances, but it is our passion. And more importantly, over the decades, it is our persistence that takes us. Dr. Timmareddy also talked about the rock. Do not underestimate the power of persistence. Even a tar road can help you flower if you are persistent, if you are really at your job. So we all work hard. We all get into medicine after a tough competitive exam. We love in a competitive exam get into the subject we love, that is orthopedics. And after about 3 years grind, we get trained locally. We continue nationally, and many of us overseas as well. Right? We do that. But most of us do exceptionally well. Many others do very well. And some others do reasonably bad. But a good number of us stagnate. I think I have reached an age where I can actually have the liberty, take the liberty of saying that many amongst us do stagnate. And I think Professor V.S.N. Murthy, a character like that, would particularly advise his colleagues and juniors to keep carrying on, not to stagnate, to uplift themselves, to endeavor for greater heights. I think so. In a way, I'm trying to see if my words probably match what Professor V.S.N. Murthy stood for in all his life. Most often, we do not even realize that we have become stagnant because of various pressures that we have, all these day-to-day activities that we have, and we continue to probably do bread and butter stuff. And we lose sight of the ultimate aim that we are actually meant to be doing. So maybe it is complacency, maybe it is contentment in what we are doing, maybe it is some family issues like health of parents, spouse, children. These are all genuine reasons. Most of the time it may be genuine, but these are not long lasting. These are all temporary distractions, I think we should consider it as. And once these hurdles are sorted out, we should pursue our passion in earnest. Einstein said, once you stop learning, you start dying. The God Almighty has endowed us in a great extent. It is not, if you are not fulfilling our potential, it is simply not right. It is not acceptable because our complacency or the lack of drive deprives our patients of the very best that we can do to them. In many ways, probably we are compromising on patient care. And you need to reflect and answer to yourself whether that is acceptable to you. Medicine, we all know, is a noble profession. It is a very caring profession, and we all have committed ourselves to this noble profession. But having done that, it is our duty to excel in our specialty. Now, lack of motivation reflects in all aspects of our life. It reflects in our interaction with our patients and their relatives. It reflects in our poor clinical decision-making judgment, and also in our surgical outcomes. So, what has changed over the decades? The practice of trauma and orthopedic surgery has undergone an enormous sea of change with the better understanding of the biology, biomechanics, and biomaterials. It's a totally different world from the time that I grew up as a trainee. We have moved from the conservative era to the operative or the interventional era, which has brought with it its own set of complications and problems. We have infections, we have injury to neurovascular structures, we have failed surgeries, and we have, of course, occasionally wrong site surgery as well. These can ruin our families. What Dr. Timmareddy spoke about, the people coming from the poor backgrounds, what Dr. V.S.N. Murthy treated in most of his career, the people from the lower socioeconomic groups. So if we do not, we have a huge responsibility to our society. And so one has to be not only capable, but we need to be judicious in our decision making in the interest of the patient and not in our own self interest. What does decision making involve? It takes a lot of things into consideration. Most importantly, the patient as a whole and the problem as it is. The most suitable treatment for that particular individual. We need to plan, we need to execute the procedure, and more importantly, we have to rehabilitate what going back to Dr. Timareddy said, the ultimate result is the follow-up, is the outcomes of your procedure. People have said that there is no better humble follow-up than a good follow-up. Okay, so we need to follow up the patients. Unfortunately, in many of us, including me, there is a gap between the quality of that care that we deliver and that which we are capable of achieving. We come across on and off x-rays like this. In this era, I think this is simply not acceptable. You're actually seeing newer implants, newer gadgets. It's not somebody who was not trained. He has been exposed to good implants. There is a locking plate there. You see that. And you see the number of hideous implants that have been put there. This is simply not acceptable in this day and age. Okay, it goes on. The story goes on. In a diabetic, if you do this, that ankle is sure to end up with an amputation or at least an arthrodesis. This is not trauma surgery. This is internal decoration, if I may say so. Right? So what are the consequences of such actions? The patient is maimed for life. We could even result in amputation or even sepsis and death. Economic ruin definitely for the family. And mental agony and disrupted social and professional life. Many have ended up with divorces and suicides. Okay, and if an individual is sued, it is difficult to protect our own colleague if such interventions do happen. The current social milieu, all of us know, is at its worst in terms of the doctor-patient relationship. It is at an all-time low. The layman is suspicious of our intent and caliber. They think we are out there to just loot them, to extract the last penny from them. That's what the general public believes. And also, the aggressiveness is a lot more nowadays than it was during our younger days. And not to talk about the media and the politicians. So what are the remedies? No, it's no good just pointing out the problems, but we also need to think of the solutions. So most of the problems lie within us, or at least in and around us, which we can control. And the solution also partly or to a great extent lies within us. We need, for any course correction, we need to analyze the reasons for these poor performances. Is it the lack of self-interest, or is it the lack of motivation? Is it our attitude? Many a times we have seen in the past our own seniors being very, very callous about it, saying, "Chalta hai, anything goes, anything will do." They may be due to lack of amenities in remote towns and remote taluka hospitals. But then I think they should be judicious enough to refer those patients elsewhere. Certain circumstances do, I understand, prevent all that, but then we need to protect our own backsides when we are doing these things. And of course, the training across, we have 830 odd medical colleges in our country, and the quality of training is so variable right across the country. So that is a big, big problem. So what are the remedies? We need to be passionate. We need to persevere with our aim in goal and in life. We need to be committed. These were the things that Professor Murthy stood for all his life. And also we need to be compassionate. We need to consider if we would be treating the patient the same way as we would be treating our own family member. I think only then things would make a drastic change. Of course, like it was mentioned in the past 3 orations also, one does not become a master overnight. It needs years of experience, but it needs consistency, and that's the only way to becoming a master. Now, what do we mean by excellence? Excellence does not mean you're becoming better than the guy next door. It is an effort to improve yourself gradually, to live up to your own potential. It is to be the best version of your own self. That is what we mean by excellence. And how to achieve that? We need to put in an extra effort each and every day, a small bit of extra effort each day, each week, each month. And that will, in the years to come, substantially improve our own results. We can even audit our own performances. But where is the challenge? I think the challenge is in the mindset. The challenge is to overcome the inertia that we have, right? So to achieve excellence, my dear young surgeons, we need to set a target. We need to take one step at a time, attend workshops and meetings, as has been mentioned earlier also. We need to update ourselves with the operative videos, the journals. Many surgeons are self-taught and they do remarkably well. I have a lot of colleagues coming up and showing me procedures they have done, looking at videos and listening to lectures. Okay, we need to discuss with peers, and as has already been mentioned earlier, get a colleague to help with your complex cases. Do not shy away from that. There is no false pride involved in that. What changes with time? Your skill changes with the experience that we have. Our knowledge improves, our decision making improves. Of course, the implants and the designs change. Or more important, the patient expectations. We now live in a unitary family. Unlike the earlier joint families that were there, we now live in a unitary families. Everybody is working, everybody has to get back, otherwise they lose the job, and the costs are phenomenal. What does not change with time? Our commitment, our passion for excellence should not change with time. Our principles, as has been alluded to, what we learned from our parents, our teachers, our mentors should not change. Our love for the patient should not change. And most important, it is our own self-respect that drives us towards better patient care and towards excellence. How do we achieve excellence? Like I said, we need to change our mindset from I can't or why should I to I can and I will and I should. That should be the motto. It comes from experience. And to gain experience, of course, we need proper teaching, we need proper training, we need to put our hands in as a trainee, and we need good mentors, right? We need teachers and mentors to help us at every step. They need to lead us, they need to guide us, they need to train us, and they need to inspire us. And all sitting in the front and all like Professor Murthy have done this for decades and decades. And that is why we are now where we are standing, right? We need to encourage and collaborate. And like I said, people like Professor Murthy have helped us at every step along our journey towards our own upliftment and our own excellence for the betterment of the society. My professor used to always say, a non-union or a malunion has a better outcome than an infected non-union. So don't go around sticking implants into each and every fracture. Be judgmental, be judicious, and take your own step. And Bruce Salter, the man who said, life is motion, motion is life. Decisions are more important than incisions. This was a feedback from one of the universities from Karnataka that I got. My anesthetist came and gave me this paper, and he was supposed to give a feedback at the end of 1 year, at the end of 3 years, back to his university. I think that is a good step. I think if all the institutes and the hospitals make this a mandatory thing, it will actually stimulate some youngsters to perform better than, or at least get off their backsides and do a little better job. Winston Churchill said, continuous effort and not strength or intelligence is the key to unlocking our potential. So we need to take small steps. We cannot jump, it's not a long jump or a triple jump. David Brailsford was the coach of the English cycling team. Between 1908 and 2000 or up to 2000 decade, UK, Britain had won only 1 gold medal in cycling. Right? Then they appointed this Dave Brailsford as the coach. He looked into the reasons, he looked at every aspect, and whether it is nutrition, whether it is diet, whether it is the sleep pattern, whether it is the seat of the cycle, whether it is the tire of the cycle, all of that he improved bit by bit, and you will not believe that in the 2008 Olympics at, I think in Seoul, they got 4 gold medals and 1 or 2 world things. And in 2012 London Olympics, they were the best team, having won about 16 gold medals, 14 gold medals, I think. And by that time, 2 of the Brits had won the Tour de France. That's the most harshest cycling race in the world. So if you change a small thing each and every day, a 1% improvement, you will do better. In fact, if you do not make any change, if you think that's not important, in fact, you do not stagnate. In fact, you deteriorate, as you see in this graph. You, in fact, go down the ladder. So coming back to Kaloji. So once his hand was blown off, he could not take part in the 1936 Olympics. He trained with his left hand. I don't know if you noticed the first photo also, the gun was in his left hand. So that was when it was blown off. He practiced day and night. 1940 Olympics did not happen. 1944 Olympics did not happen because of World War II. But in the 1948 Olympics in London, he won the gold medal. And he won another gold medal in the Helsinki Olympics in 1952. Right? And later, at almost middle age, he won a bronze medal before he quit. So, passion, perseverance, persistence, and commitment, you can do wonders. So a similar fracture that I showed like this, if you are passionate, if you are committed, we can achieve excellent results with the current technology that we have, with the current implants that we have. We can do much better than what I showed you earlier, right? So many a times the injury pattern itself determines the outcome. But we have all heard and seen about what the Ganga people are doing with the teamwork, right? The same limb here, which has undergone an amputation in one center, maybe my own center, could have been salvaged, like that. And if you have an outcome like this patient will be eternally grateful to you. And at the same time, you will have the greatest satisfaction of having restored this patient to his best, to making him a useful member of the society. So Swami Vivekananda has said, if you aim and seek for the highest, you shall reach the highest. Einstein has said, only the one who devotes himself to a cause with his whole strength and soul can be a true master. And George Bernard Shaw said, life is no brief candle. It is a sort of a splendid torch which I have got hold of for the moment, and I want to make it burn as brightly as possible before handing it to future generations. This is what George Bernard Shaw said, and I think this was what imbibed by Dr. V.S.N. Murthy to his orthopedic colleagues, to his colleagues in the society, and also to the patients that he came across, and I pay my humble respects to him. Quality of care remains at the forefront of medical practice, and each patient is unique, and rather than perfection, the goal is to provide the best care for that particular individual given that sin. So coming back to my first slide, it is a sin to be good when you are meant to be great. This was said by a 19-year-old cyclist, Chris Evans from the University of Michigan. He was a footballer, I'm sorry. This is what he said. If a 19-year-old could think that being good is a sin and that you have to be your best, I think all of us should wake up and try to be the best that God has made us to be. So at the end, I'm extremely grateful to Tosa for bestowing me this honor of delivering this oration in the memory of this great individual. I bow down to you all. Thank you all very much.
Thank you, sir, for your enlightening lecture, and the organizers of Oasiscon will remember you as a good orator. Thank you very much, sir. Rakesh. Rakesh ikkada. We'll continue with the sessions. Hall B and Hall A will continue. Rakesh is. So we'll continue with the sessions and there will not be any lunch here as we are running short of time. So the coming session is a spine session in Hall A and Scopy from first portal to rotator cuff in the Hall B. We'll continue. Take up. Kalapan. Huh? Speakers nervo first. I
Thank, sir. Now we are going to start the spine session. I request all the members to be seated. It's going to be an interesting topic for this afternoon with all exemplary spine surgeons across various places. For this, I request Dr. Raju Iyengar sir, who has been doing spine surgery and is a role model for most of us. I request him to chair this session. I also invite Dr. M. Kranti Kumar garu, senior orthopedic surgeon in Warangal, to join him along with Dr. Rakesh Ajmera. I request all the three of you to chair this session. Kindly come on the stage. Done. Come. Yeah. The moderators for this session would be Dr. Satyanan Murthy sir, Bangar Swami sir, Lingutla Kiran garu. మీరు మాట్లాడారు. అక్కడ ఏం చేయడం Yeah.
meeting of Tosa is a conference office. All office bearers, please come to.
Simultaneously, there is an EC meeting of Telangana Orthopedic Surgeons Association, TOSA, in the office room. I request all the EC members of TOSA to kindly join the president and secretary in that hall. Thank you. Sorry, sir. Thank you. Thank you. Thank you.
So, thank you, Tosa, for having me here. So, we have a very good session on this thing. We have a great panelist here, Dr. Satyanan Murthy, a senior spine surgeon. Alage. Okay. So, first అయితే పిలుస్తా. So, I'll call upon Dr. Pavan for his talk on progressive collapse of osteoporotic vertebral fracture. Can we predict what we intervene?
కనెక్ట్ చేశాను లోడ్ అయిందా పర్లేదు
No, no problem. Okay. I'll connect it. Good morning, chairpersons, my friends and seniors and colleagues. Today, I would like to talk about progressive collapse of vertebral fractures. Can we predict when to intervene? Before describing the lecture, just I would like to present two cases. A case one, a 76-year-old female came with uh, pain in the mid-back following a trivial trauma. The patient's neurology was normal and the VAS score was less than 3 and walking with a little pain. Where you can see is the fracture of D12 fracture. And at 1 month follow-up, this is the X-ray. And at 4 months follow-up, after 3 months follow-up, this is the X-ray. Where you can see there is a consolidation of the fracture, but the patient has the pain is increased gradually. And at 4 months follow-up, she came with severe pain, and you can also see there is a kyphosis in the vertebral, kyphosis in the thoracic spine. And the patient is walking with this. And second case, a 70-year-old male came with a complaint of pain in the lower back after a trivial trauma, and the VAS score was 4 at the time of presentation, and the neurology was normal. And the patient was walking with a little pain. At 1 month follow-up, this is the X-ray, and at a 4 months follow-up, this is the X-ray, and the patient was completely normal at four, and was completely, absolutely normal at 4 months follow-up. So, where did it go wrong? So, how to decide which fracture will need conservative management and which fractures need surgical management? How to decide? So, and coming to the topic, not all osteoporotic vertebral fractures need treatment. Some fractures go from uneventful healing to the severe collapse, and with the consequences of pain, reduced mobility, and low quality of life. So, the identifying the high risk fractures at the early diagnosis leads to closer follow-up, early surgical referral, and avoidance of prolonged conservative management. And so, what are the risk factors? The risk factors mainly divide into three things. One is the non-imaging factors and radiological factors like X-rays and the MRI findings. And coming to the non-imaging findings, the patients with female sex and age more than 75 years generally have low T-scores and are more prone for intravertebral clefts, that is a non-union. And the patients which have a previous fracture generally will have a poorer disability, and they will have decreased activities of daily living and quality of life. And all this leads to the diffuse osteoporosis and the more chances of non-union. And the patient which are more inactive, that are literally bedridden, they will have sarcopenia and more bone loss, so there is a high risk of collapse. And the patients who are on long duration of steroid use also are more prone for bone loss and increased collapse. And and as you all know, low vitamin D levels are also lead to increased chances of collapse. And coming to the X-ray findings, which predict the progression of the collapse, are the vertebral instability, middle column involvement, location of fractures, and morphology of fractures. And coming to the vertebral instability, it is defined by the vertebral wedge angle, which is measured by the Cobb angle in the standing and supine position. And it is when the vertebral instability or the wedge angle is more than 5 degrees, it is always a risk factor for delayed union and higher collapse. And coming to the middle column involvement, as all you know, that the middle column involves the posterior vertebral body, posterior annulus, and the posterior longitudinal ligament. The injury to the posterior vertebral, that is the middle column, the chances of the patients will have chances of poorer SF36 scores, reduced daily function, long pain durations, and greater vertebral collapse. And coming to the location, the fractures which are located in the thoracolumbar junction, that means the T12 to L2 fractures are more prone for delayed union and non-union and higher chances of collapse. And coming to the types of fracture, that is the morphology of the fractures. Sujita has divided into 5 types. That is the swelled front type, bow type, projecting type, and concave and dented type. The fractures with swelled front type, bow-shaped fractures, and projecting fractures, these are more prone for collapse and non-union chances. And coming to the MRI findings. In MRI findings, in T2 weighted sequences, there are 5 types changes we can see. That is based upon the Sujita classification. Either it is a confined high intensity, diffuse high intensity, confined low intensity, and diffused low intensity type. The fractures with diffused low intensity and confined high intensity are more prone for non-unions and more vertebral collapse. And also in the MRI findings, we can also see the injury to the posterior ligamentous complex and the posterior wall injury. The fractures with the posterior ligamentous complex injury and posterior wall injuries are more prone for the progression of the collapse. And in the stir images, you can see either it is a linear black fracture appearance or it is a homogeneous high signal or non-homogeneous high signal. In stir images, if the fracture is having non-homogeneous high signal intensity, then it is more prone for vertebral collapse. And in the contrast MRI changes, in contrast MRI, we can see the necrotic region. If the fractures with more necrotic area is there, then it is more prone for the collapse. And coming to the paraspinal muscle degeneration, this paraspinal muscle degeneration, it is graded into A, B, C, where C is the more degeneration, and it is denoted by the functional cross-sectional area. The patients with lower functional cross-sectional area, that means more sarcopenia, are more prone for the progression and junctional kyphosis. So, how to come to that is segregating the risk factors. When you combine all the risk factors, that is the non-imaging factors, X-ray findings, and MRI findings, then you can come to composite risk management. And based upon that, the decision can be made either it is go for conservative or surgical management. However, a recent classification based upon the osteoporotic fractures was defined by the German Society of Orthopedic and which is adopted by the Oasiscon. It is a landmark paper which is a very useful classification and is a paper which defines the protocol for the osteoporotic management fractures. And this classification is called OF classification, and it divides the fractures into 5 types. OF1, where it is mainly based upon the degree of deformation, posterior wall involvement, and the stability. And the OF1 fractures having no deformation and only mild edema, and OF2 where there is a less than 1/5 involvement of the posterior wall, and in OF3 that is more than involvement of the posterior wall involvement, and type 4 where it is again divided into 3 types, whether it is a complete burst fracture where the posterior wall is extending into the spinal canal, or it is a complete collapse, or it is a pincer type. And in the OF5, there is also associated with the distraction injury, and these OF5 are very unstable fractures. And based upon these fractures, and the therapeutic decision is mainly based upon the score. In this score, the fracture classification is where each grade has given 2 points, and also it is not only on the fracture classification, it is also on the bone mineral density, ongoing fracture process, whether it is the fracture is progressing or not, and is the patient is having pain. If the VAS score is more than 4, then it is point is 1, and if the VAS score is less, it is less than 4, it is -1, and the patient is having a neurological deficit, or if the patient is able to mobilize or not, and also the health status also is taken into consideration. Based upon these things, the score has given, and gives an examples in this case. A 70-year-old man presented with the OPD with the low back pain, has a trivial trauma and walking with the support. And here you can see it is a L1 verge fracture, and after the initial fall, it is, sir, 2 more minutes, sir. Okay. After the initial fall, it is the MRI is showing the L1 fracture, And after the 3 months follow-up also, there is no progression of the fracture. As the involvement is involving into the vertebral body at more than 1/5 of the posterior wall, it is a type 3 fracture. So based upon the scoring system, this is based upon the morphology, osteoporosis, and taking all into the consideration, the score comes to be 4, and these patients can be managed conservatively. So we have managed this patient conservatively with an teriparatide and hyperextension brace. At the follow-up, this is the thing. And the patient is doing normal. And in the second case, a 61-year-old with a trivial trauma traveling in a car with a severe pain, and patient has no neuro. And we can see it is a D12 fracture with type 4 fracture, where it is a pincer type of fracture. And based upon the scoring system, the patient is having type 4 fracture and is also having, as though there is no progression of the deformity, but the patient is having severe pain. This patient needed surgery, and based upon the score, we managed surgically, and this is we did with vertebroplasty, kyphoplasty. And another case is balloon another case is a 71-year-old male with a trivial injury at home. The patient had a neurological deficits. It is to decreased power in both hips and knees. And in X-rays, you can see there is a D12 and L1 wedge compressions. And the MRI also, you can see there is a vertebral protrusion into the canal, and the CT is confirming it. And based upon the score, the score is 12. And as there is a progression of the deformity, and there is a neurological deficit, these patients needs a long fixation, and it is managed with hybrid fixation. And this is courtesy to Murthy. Okay. And coming to the take-home message, the poor prognosis in osteoporotic vertebral fracture is multifactorial. It is based upon the clinical, radiological, MRI, and parameters. All has to be taken together. And the key red flags are age more than 75, thoracolumbar location, vertebral instability angle more than 5 degrees, middle and posterior column injury, confined high or diffuse low T2 signal, and sarcopenia. The OF classification provides a practical, reproducible, and a framework linking in fracture morphology to treatment choice. And early identification of the high-risk fractures enables timely surgical referral and better functional outcomes. Thank you.
Nice talk, Dr. Pawan.
Thank you. Thank you, sir.
Next, I invite Dr. Himanshu Prasad to come and speak about hemangioma, Beauty and the Beast.
Good afternoon, everyone. Thank you, chairpersons, and thank you, Tosacon and Oasiscon, for giving us this opportunity. I was asked to talk about tumor, and then I thought I'll talk about hemangioma, because most of the time we see hemangioma is very common, MRI finding. So I thought let's show the other variant of hemangioma. So my talk is Beauty and the Beast, because I just wanted to show about the two variety of the cases, how you can manage them. So the first case, she's a 20-year-old female. She comes with back pain of around 6 months onset. She has only paresthesias in the lower limb. Not much of clinical finding, but she's only a sensory blunting. This is her X-ray. If you see, there's a significant collapse of L1 vertebra. And this is her MRI. Her MRI is the classical picture of a hemangioma. But if you clearly see the boundaries of hemangioma, it has expanded the boundaries of the vertebra. It has gone anteriorly, it has gone posteriorly. So also it has involved the posterior elements. I think this is. I have to face you. Okay. Yeah. So this is the coronal cuts. You can see there is a significant canal compromise. But luckily she doesn't have any bladder issues or any other neurological issues. So options, I just wanted to know a raise of hands from my spine colleagues. Surely we are not thinking non-operative in this case. What are we thinking? Anyone for embolization? Anyone? So, vertebroplasty alone? No. Resection or en bloc resection of the tumor. For 20-year-old female, neurologically intact. Right. So there are a couple of people who raise hand for en bloc resection. But my thought process in this case was she's a 20-year-old female. When you go for resection, it's a hemangioma. You tend to bleed a lot. In spite of embolization, there's a high risk. And of course, in 20 years old, there are multiple complications when you do en bloc. En bloc is not going to be an easy in this case because you have to go anteriorly as well. You just can't do posterior approach as you can do in dorsal. But in lumbar area, you'll have to go two approaches, anterior and posterior. So we decided we'll go only with the simple one, as the family was also not very aggressive on the treatment. They just wanted pain relief because she's come only with pain relief. So we decided on only vertebroplasty. This is what it was post vertebroplasty. All okay, the pain is gone. Six weeks later, she comes to me saying that I have no pain, but my gait is altered. I've got weakness in my limbs. I cannot control my bowel. We get an MRI again, and that's what she is. The hemangioma has expanded. It is significantly compressing the cord at the conus, and now she's come with this deficit. Now what? Again, options. This time, since the bladder is involved, since neurologically she's deficit, we go ahead and we plan to fix her up. I planned MIS fixation for her and decompression in the MIS way. This is the hemangioma cross section. You can see how significantly it is involved. It has breached all the boundaries and it has gone into canal and it's almost squeezing the cord. So before the surgery, we plan embolization at least to make her let the blood pool be less while operating. Of course, we are not trying to resect the vertebra, but we still have to decompress it. As you've seen, the posterior element is also involved. Embolize it, MIS fixation, 2 above, 2 below, and at the center, we do a MIS decompression. Neurologically, she does well. Pain is anyways not there. She started to walk. She's 2 months post-op. She's doing well. This is one spectrum. On the another spectrum, I have another case. She is now thinking of this thing. She's 50-yearish and she's got weakness of the limbs, sudden onset. Again, the hemangioma diagnosis above. You have to be very careful in examining the X-ray. You can see the polka dots and the corduroy appearance above. Again, the canal is compromised, expansile hemangioma, encroaching the canal. This time, now this patient is 55. She has just cured out of her CA breast around 5 years back. The family is again positive in going ahead with curative option for this as well. Now, why I'm talking curative is hemangioma has a very high chance of recurrence if you have done partial resection. So I'm in not mood of doing only partial resection in this. I plan an en bloc. Now, en bloc in this case, the problem would be it's hemangioma. You got to be sure of the vascularity. Hence, the plan would be embolization first, followed within 24 hours or after 24 hours rather, go and do the en bloc resection. Now, the approach would be all posterior. I would have to make a plane between the tumor, the pleura, and the vessels, great vessels you see on the right, without disturbing the tumor. Because the minute you breach the wall, minute you reach or breach the tumor, it's going to bleed massively. And of course, at the same time, you'll also have to decompress. So this is the SAG view. This is the tumor. As I said, we planned all posterior en bloc resection of the tumor, 2 fixations above, 2 below. Proper regular approach posterior. Now I've gone, as I said, I've gone with the blunt dissection, maintaining the walls of the tumor I've gone anterior, I've done a rib resection, gone posterolaterally. With the blunt dissection, I've gone anterior to the tumor and making a plane between the great vessels and the tumor margin, making sure that I am not breaching the wall. Of course, the first step was laminectomy. We have done a wide laminectomy, extending. You can see the laminectomy has gone to the above level also, because once you reconstruct it, there's a high chance that the upper lamina might poke into the canal. So you can see this gauze piece, which is going anterior to the vertebral body. The tumor is posterior to the gauze, and then you can see the dura. After resecting that, I've done a discectomy above, I've done a discectomy below, and now that body, the tumor body is freely mobile. I've spun it across and got it out in piece without breaching the margin. That is what you can see. You can see the retractor going all in all anterior to the dura. We have to ligate couple of roots to get the vertebra out. And you can see the temporary rod on the right side. So now the tumor is all out in piece without breaching the margin. Dura is happily decompressed and the fixation is in place. This is how we spin the vertebra. Easy said than done. That's the lamina margin. That is again taken out in one piece. The lamina is above and the spinous process is pointing downwards. And this is the vertebral body in total. So with this, and this is the reconstruction what we did. And this is the final. So now she's totally out of the tumor. This is a very good surgery for any solitary tumor where you can do en bloc resection. In this, the patient didn't want to have a chance of recurrence. Hence, we went ahead with a complete en bloc resection. Thank you.
Nice presentation. Next, I would like to invite Dr. Satyanarayana Murthy PV for his speech on cervicothoracic fracture with neurological intact, anterior or posterior.
Good morning, everyone. In the spine session, there were a lot of dropouts because of one of the spine course going on in Bhopal. So sorry for not able to give complete plethora of spine. Thank you. Actually, we wanted to do discussions of the case, but because of lack of time, we are not able to do. We are just going through the cases. Here is a 60-year-old male who presented to ER with history of hit by a bull in his farm a day back. He had a brief period of weakness of all four limbs. He could not stand for 2 hours. And there was no history of loss of consciousness or vomitings or GTCS. Make him stand because by the time we reached, we got all the X-rays and workup done. It was showing, I'll show you. This is the X-ray, what showing not working. Pointer. ఇది కూడా ఇక్కడేనా? Acha. Right. This is a plain AP radiograph. On lateral radiograph, we could not see anything, but on oblique view, we could see that there is a C7D1 subluxation. A CT was done, CT protocol. I don't have the images now. This is a C7D1 subluxation. The MR scan which is showing C7D1 subluxation, but there's a cord looks to be intact. There is no compression on the cord, but if you keenly see, there's some edema here in the spinal cord. So what is the plan? These are the stir images where you can see there's a fracture in the spinous process and all. So we could see this cross section where there is a complete destruction of the posterior long ligaments and all the posterior structures. So what are the plan or options? So can we do conservative? No, I believe, because it's very unstable. So surgery. So what surgery we need to plan? Whether you do a ACDF or short or long posterior construct, or both. I mean both if you are not very comfortable with the anterior construct, or if you don't get any proper reduction. So what are the prerequisites? If what are the prerequisites? Usually, you should be able to visualize the D1 vertebra, and also once you place the patient on the table, if you can appreciate the D1 vertebra, we can plan doing anterior ACDF. So, how to counsel the patient about you should talk about the perioperative neurodeficits. Quadriplegia, but in this case it's C71. Maybe you can have weakness of the hands, or you can land in paraplegia. So, because thorough counseling was done and we took him for surgery, we planned for ACDF. If plan A does not work, that ACDF does not work, we can do posterior approach also. So ideally, to have a neuromonitoring, awake intubation, and positioning to see whether C71 is visible on fluoroscopy. So on fluoroscopy, we could visualize the D1 vertebra. So this is the fracture C71. You can see almost subluxating or listhetic C71, traumatic listhesis. So plan to go ahead with ACDF. A plate is mandatory because no standalone cages, because this is for the juniors or who want to think about this, you cannot just do a standalone cage. It should be plated because it's a trauma. So did ACDF under microscopic guidance. This is what we could get. Like we could almost get the reduction, because we never attempted. But once you positioned the patient and gave some traction, we could get, once we put the distal screws, we could get complete reduction. So this is a plate with the interbody cage. This is a post-op X-ray, and surprisingly, post-operatively his motor was intact, but he was having typical posterior column symptoms, like he was having gait instability. I didn't understand, because he was completely neuro intact pre-operative and post-operative. We could not examine the patient pre-operatively because we did not make him stand, but while he was standing, he was collapsing. It was there for a couple of days, and subsequently he did very well. I mean, there were no deficits, but still has some paralysis in both lower limbs. So this is my case. Any questions, or we'll do later? Thank you.
So we'll call upon the next speaker, Dr. Srinivas, for his talk on multi-level cervical disc, what he did.
Good afternoon, everyone. So today my case is on multi-level cervical disc herniation. So this is a 45-year-old female, came with a complaint of tingling, numbness in both hands and legs, difficulty in walking, loss of balance while walking, and instability, and of course needed support for climbing the stairs, unable to get up from sitting position, a weakness in both hands and legs, tightness in the legs, and the tone is 3, reduced hand grip in the bilateral. On examination, reflexes are exaggerated, supinator is inverted, and reduced sensation below C4 bilaterally by 50%. Hand grip is poor bilaterally, and tone is MAS 3. Power is almost like 4.
bilateral upper limb and lower limb, perineal sensation are reduced. So this is the clinical presentation and examination findings. So this clearly shows this is a picture of compressive cervical myelopathy. So as per the clinical history, and this is the diagnosis as per clinical. So this is the X-ray of the patient. You can see a loss of lordosis, except for reduced disc spaces at 4, 5, 5, 6, and 6, 7. Otherwise, this is a near normal X-ray. Then we got the MRI. So this is the MRI of the patient, and you can see there is C3, C4, 4, 5, 5, 6, 3 level severe compressions from the disc herniation, and of course looks like some sort of PLL hypertrophy and severe myelomalacia changes at the 3 levels. And parasagittal images also shows mild compression of the foraminal area, central and foraminal areas. These are the full parasagittal and sagittal images showing severe compressive lesion at 3 levels: C3, C4, C4, C5, C5, C6. So this is the axial image. You can see a lot of compression in the central part at 3 levels. And the zoom in image of the C3, C4, C5, C6 causing severe compression with minimal cord space. Same images, zoom in images. So this is a CT. So CT was taken to see any disc ossification or any PLL or PLL ossification is there. But CT is normal, no PLL ossification or no disc ossification is there. This is the axial images. You can see the canal is free, no ossification features in the axial images. So what is our plan? So 3 level disc herniation, and whether you want to go anterior, posterior, you want to go both with a severe compressive myelopathy, neuric 3 myelopathy. So whether we want to go to anterior approach. So how we decide whether we want to go to anterior or posterior? Mainly the patient has lordosis or kyphosis. This patient has a neutral X-ray, so we can go for both anterior or posterior. And other point is next, what are the levels involved? It is 3 level involvement or 4 level involvement. It's almost like 3 level involvement, which might favor for a posterior rather than anterior. And other one is where is the pathology? Pathology is anterior pathology or posterior pathology. Anterior pathology, better to go with anterior, and posterior pathology, better to go with posterior. Another thing is discal ossification or PLL ossification. If ossification is present anteriorly, better to go from posterior. So these 4 points we need to consider whether we want to go for an anterior approach or a posterior approach. So this case, no discal ossification, soft disc, 3 level involvement with a neutral X-ray. So it is a surgeon choice whether we want to go for anterior and posterior. Other one is complications. What are the complications we expect from this surgery? Is mainly a dural tear or a neurological deficit or post-op infection. So these are deciding principles. That's the same thing. Lordotic curve or a kyphotic curve of the cervical spine. If a kyphotic curve of the cervical spine, definitely we need to fix the spine in if we are going for a posterior cervical fusion. Levels of pathology, 3 level involvement, better to go with a posterior this approach. And compression is anterior, better to go anterior. And pathology is hard or soft, that is disc ossified, better to go with posterior approach. So these are the complications what we expect in surgery. Dural tear. If dural tear is there, we can go with a patch or else a lumbar subarachnoid drain. If a deficit occurs post-operative, whether it is a partial deficit or a complete deficit, we need to see. If it is a partial deficit, we need to get a MRI, whether any compressive element is there, hematoma is there, and plan accordingly. And there is most commonly C5 palsy occurs if you do with posterior decompression multiple levels. We get C5 palsy, tension palsy. So this one we can prevent it with the foraminotomy intraoperatively at C5 C6 level. So to prevent this, you need to do a foraminotomy. So other thing is postoperative infection. So this case we did a posterior approach. We did a posterior 3-level decompression and fusion. So this is the X-ray. We did a decompression and fusion of C3 to C6. The patient went well, and all the symptoms subsided. So mainly recovery will be like initially the symptoms, mainly tightness of the legs will reduce and tingling and numbness will reduce. Gradually the patient becomes normal. This patient became normal in a period of 1 year. He became normal, it's near normal and Nuric 1 grade. He attained in a course of 1 year. So slowly the patient improves, not like immediately the patient won't improve, but it's gradual improvement will be there. Patient recovered completely. Thank you.
The last presentation, thoracolumbar fracture, mobilize or wait to heal. No, sorry. I'm sorry. Post-operative discitis, whether to conserve or to fix it. Dr. Anil.
So good afternoon, everyone. So my topic is post-operative discitis. When to fix and when to conserve. So I have a patient of 27 years old, who came with the chief complaints of low backache radiating to left lower limb. So patient doesn't have any weakness. Only the patient concern is radiating pain and the paresthesias. And he doesn't have any fever or bowel or bladder disturbances. As the patient was on considered treatment for 3 months. So it is not relieved and the patient is suffering from the pain. So on examination, the SLRT is 30 degrees on the left side and there is normal neurology. So first I have taken X-ray which is normal, there is no instability. So I have went for an MRI. So the patient has a L5S1 paracentral disc protrusion. You can see it's severely compressing the left S1 nerve root. So I have performed a L5S1 minimally invasive lumbar discectomy. So post procedure, the patient had a complete pain relief, radiating pain relief. Patient is able to walk. There is a minimal post-operative back pain, and there are no neurological deficits. So the patient came to me after 6 weeks. So his patient developed a severe low back pain, no radiating pain. There is gradually onset and continuous. The patient is not able to sit, stand, or lie down comfortably, and patient is difficult in turn to bed. And there is a history of fever, but the patient doesn't have any weakness or paralysis of bowel and bladder disturbances. So initially I thought it's a discitis. So I have done investigations. It shows neutrophilic leukocytosis, ESR and CRP is elevated. So I have taken an MRI. So this is a T2 sagittal view. You can see that the L5S1, there is a hyperintense intensity at the disc and the adjacent vertebral end plates and bodies. So the T1 sagittal shows hypointense, and the T stir images shows L5S1 hyperintense. The sagittal images shows there is a significant epidural abscess compressing the left S1 nerve root, but the patient doesn't have any neurological deficits or pain. I have taken an X-ray which doesn't show any instability. So what to do for this case? So conservative management or surgery. So patient doesn't have any significant neurology or instability. So I went with a conservative management. So I asked for the patient for a biopsy, either transpedicular or transforaminal, but the patient is not insisted for any further surgical involvement. So I went ahead with starting 3 months of antibiotics. I have given a 6 weeks of Clinda and followed by 6 weeks of tablet clindamycin along with the 3 months of cotrimoxazole. So the patient was followed every 1 month. The patient's symptoms improved. So this is the following 6 weeks of conservative management with antibiotics. Here you can see there is a significant reduction in the hyperintensity. So this is the T2 and T1 weighted. There is resolution of the abscess. So what is the postoperative discitis? It's a severe infection occurring in the intermittent disc space. The incidence range is 0.2 to 0.3, 3.6%. The most common organisms are Staphylococcus aureus and the E. coli, Pseudomonas and Klebsiella. So when to suspect when there is a postoperative discitis? Generally it occurs post 2 to 4 weeks postoperatively. It can range up to 1 to 6 weeks. The symptoms can be acute and continuous back pain, muscle spasms, stiffness, sciatica, and these pain and muscle spasms are usually refractory to bed rest and analgesics. So persistent elevated ESR and CRP along with the MRI findings suggestive of discitis. Generally, the CRP lessens roughly 10 days postoperatively, but if it is rising beyond 2 weeks, you always suspect of any discitis changes. The white blood cell count is a poor marker for surgical site infection in postoperative discitis. So the most valuable method is always diagnosis percutaneously image guided biopsy. So but the yield will be less. So in case if the patient is okay, we can take an open biopsy to increase the diagnostic yield. So we can take if there is a systemic infection also, we can take blood cultures. Always don't forget to take any respiratory tract and suspect urinary and respiratory tract infections and collect urine and sputum cultures. The nucleic acid amplification testing can increase the accuracy in negative aerobic and anaerobic cultures. So always take an MRI and dynamic X-rays to rule out the instability. So whenever there is instability, we need to do a surgery, a fixation. So there is a classification system according to the primary and secondary criteria. The primary criteria is the bone destruction, segment instability, amputable abscess, and neurological impairment. The secondary criteria is a paravertebral involvement. Based upon these primary and secondary criteria, the patients can be divided into 3 types. So type A, there are all cases without biomechanical instability or epidural abscess or neurological impairment. So these type A patients can be treated conservatively once you diagnose with the causative organism with the cultures. So in the type B, in this there is a radiological evidence of significant bone destruction or biochemical instability without acute neurological impairment. These patients can be treated either with rigid orthosis or stabilization. These cases might not need a aggressive surgical approach or decompressions. In type C, so in these cases there is epidural abscess with a significant neurological impairment. So type C cases always needs a aggressive approach with debridement and fixation. Thank you.
Good presentation. Next, the last in this spine series, thoracolumbar fracture, mobilize or wait to heal, the dilemma, by Dr. Mithun. Welcome, Dr. Mithun.
Hello, good afternoon, everyone. Myself, Dr. Mithun Jakan, consultant spine surgeon. Thank you so much, Tosa Oasiscon 2026, for giving the opportunity. So today my topic will be on thoracolumbar fractures, mobilize or wait to heal. So we often like spine and orthopedic guys see the thoracolumbar fracture often in our OPDs. Many a times we know it's a clear unstable fracture where needs fixation or some needs conservative. So the discussion here is when to mobilize. There is still a dilemma on it. So thoracolumbar fractures are like it's a junctional fracture. It's a most common junctional fracture seen. So it's a transition zone from thoracic kyphosis to the lumbar lordosis. A small change in the alignment can cause a major mechanical instability. So the majority of patients having intact neurology, there is a dilemma in management how to approach whether to operative or non-operative. So interesting topic of debate for this, whether to fix or not, how many levels, what is the approach, whether to decompress or not. But today, my topic will be more helpful to my orthopedic colleagues who see these fractures in their OPDs. So let's stick to some basic today. So after any acute spine trauma arrived, just stabilize the patient, get the clinical examination and the neurological examination, get the involved X-rays, check for any other long bone or other bone fractures or any other solid organ injuries, and then plan the line of treatment. So X-rays are the basic tests which are done first. X-rays tells me the alignment in general of the fracture, but the CT and MRI tells me the intensity and the detailed injury. So always look for the involved vertebral height loss, the posterior wall retropulsion, and the canal compromise, and any kyphosis or translation or distraction injuries. So this is the AO morphology, the fastest way to frame the stability. So here we come the type A fractures, which are like stable burst, stable compression fractures, split fractures, incomplete burst where only one end plate and column 1 and 2 is involved, and the complete burst fractures, which is called A4. So the distraction injuries, which mainly the distraction or the flexion distraction injuries, where the fracture line travels or the injury line travels from posterior to anterior. Usually we can see in B1, it's a bony chance we call, where the fracture is starting from the spinous process and extending up to the anterior of the body. B2 is like posterior and B3, where you can see the fracture line either transferring from posterior through ligament and bone, or completely ligament, means from PLC to the disc level. And the third type injuries are translation injuries, either in sagittal and coronal displacement of the whole fracture column or the vertebral column. So this is AO morphology. So the dilemma is the protect the fracture versus protect the patient. So many of the PAC wait for healing, wait for healing of fracture by giving prolonged bed rest, absolutely delaying the loading, deconditioning the patient, but this causes longer hospitalization and its associated complications. But in early mobilization, when to be done, once the pain is controlled, give a protected loading, give good rehabilitation, especially pulmonary and other joints, and help in functional recovery. So how to take the decision? This is not based only on X-ray alone. It based on the neurology of the patient and the morphology and the stability of the fracture pattern. So who is a candidate for early mobilization? One with intact neurological examination, one with a stable AO type and a selected burst fractures, patient having acceptable kyphosis and vertebral height, which we'll be seeing in detail in further slides, and no convincing posterior tension band disruption. What is this posterior tension band disruption? We'll have a pictorial image in our later slides. And once the pain is controlled enough to stand and walk safely. So stable plus intact neurology, early protected mobilization. Don't wait for extended bed rest. So brace or no brace. The brace is a tool. It is not the treatment. So TLSO, thoracolumbo-sacral orthosis, may improve the pain and confidence of the patient. Sometimes early ambulation is also possible in selected patient without a brace. So coming to surgery versus conservative care, a genuine gray zone which we face. Non-operative treatment avoids the surgical morbidity, can help early mobilization with a possible brace is an option, but needs a reliable follow. Just you have seen the patient and told, okay, it's a stable fracture, we'll see you after 6 weeks. No. We tend to do this because we are more behind the operative cases. So in operative thing, immediate advantages are it gives us immediate mechanical stability, it corrects the primary deformity after the trauma, it may facilitate early mobilization, but as it comes with a added surgical morbidity. So when should I stop waiting? When it is B or C type of morphology fracture as per AO classification, patient with neurological deficit, especially progressive neurological deficit, and mechanical instability, PLC disruption, and a stable fracture looking like a stable fracture in early X-rays, later turning into a progressive kyphosis or a collapse of the vertebral body. So failed conservative care, like pain is not improving and which prevents the patient from the safe mobilization. So how this progressive kyphosis, especially in type A, where we see, okay, it looks like a stable fracture. Okay, conservative, put a belt, go take rest for 6 weeks, and we'll see you after 2 months. No. So this is a case where a patient with D12 fracture look like, okay, it can be managed conservatively. You can see the kyphotic angle at this, but later on the follow-up X-rays, it was a progressive collapse. So this is a X-ray taken from this paper. So we say PLC is intact, posterior ligament complex. What is this? This is mainly a complex of supraspinatus, interspinous, the facet joint capsule, and the ligament flavum. Just for the reference, I have added this. So many of the times we get which things to be involved, what to be seen in this. So which can be well appreciated on the MRIs, especially stir images. Sometimes in X-rays also you can see there is an selected increased interspinous distance with a clinical tenderness when we touch the patient, when we see the spinous process. The basic burst fractures or basic compression fractures may not give you posterior spinous ligament tenderness, but this when there's a PLC injury, you will definitely see a classic tenderness and a gap and crepitus. So what is my practical algorithm is the neurology. If there is a deficit, urgent surgical intervention, stabilize, decompress. In the morphology, if it is A, O, B, and C, stabilize the earlier. In coming to stability, when we see, as we see in the collapse and kyphosis, when there is a PLC injury, assess and fix. In function, once the pain is controlled, mobilize early. Don't wait it to heal. And always monitor the patient for the alignment and symptoms. If the alignment is maintained and the symptoms improve, continue the treatment, mobilize the patient with restricted activities. Know the pain is progressing or the alignment is disturbing, convert to surgery. So don't wait for the X-ray to heal. Wait only when the fracture is stable, and the stable plus intact, mobilize the earliest. If unstable, stabilize early and keep a follow for the function and the alignment. Our endpoint is not a healed X-ray. Our endpoint is a walking patient. Mobilize him the earliest. Thank you.
Hello. Yeah, we'll go for the next important session. That is inauguration of the Association of Spine Surgeons of Telangana. That is what. In that pretext, I hand over the proceedings to Dr. Pavan. Please.
I'm taking the honor, sir. Raju, sir, with your permission. It's nice to see a new association come at this Oasis. Warangal, prominent people have graduated from here along with eminent personalities. Raghavadat was a student of Warangal, and we take this privilege of introducing this particular inauguration with welcoming all the dignitaries, Pavan, PVSN Murthy sir, Raju Iyengar sir, and Bangar Swami sir to deliver their initial presentations. Before that, I thank all the chairmen who have chaired this session. I request our scientific committee chairman, Dr. Maheshwar sir, or Dr. Ramkumar sir, organizing secretary, to come and honor them. Dr. Raju Iyengar sir, Dr. Kranti Kumar, and Rakesh Ajmera. So now I request Dr. Pawan Kumar to give his welcome address.
Thank you, sir. Respected President of Tosa, Dr. Ramkumar Reddy, sir, Secretary Dr. Jaganmohan Reddy, sir, President of Oasis, Dr. VCR, sir, and President-elect of Tosa, Dr. Alval Reddy, sir, respected senior colleagues, my fellow spine surgeons and dear friends. It gives me immense pleasure and pride welcome you all to this historic occasion, the inauguration of Association of Spine Surgeons of Telangana, ASST. ASST is being established with a simple but powerful thought to bring all the spine surgeons of Telangana together as one academic. Together as one academic and professional community with a shared commitment to excellence in spine care. Our vision is to create strong, academically vibrant and collaborative platform for spine surgeons across Telangana. We want ASST to become a place where we learn from one another, share our experiences, encouraging young surgeons, and promote research and embrace innovation and ultimately improve patient care. Our purpose goes beyond conducting meetings and conferences. We envision regular academic programs, workshops, surgical demonstrations, cadaveric trainings, research collaborations, and opportunities for young surgeons and trainees to learn from experienced colleagues. ASST not only works alone, it works alone with a close harmony with Tosa and ASSI, that is Association of Spine Surgeons of India, and strengthening the existing orthopedic and spine surgery community rather than functioning in isolation. Our just logo. Yes, sir. Our commitment. Okay.
Brochure and
I request all the spine surgeons, please come on to the dais.
All spine surgeons.
All spine surgeons.
Non-spine not allowed. Spine not allowed.
All orthopedic surgeon who has the spine can
Sir,
become
trained,
spine
but
surgeons.
we are unable to do with Arogyasri, sir. Take a final statement from both these three organizations with respect to that. Scientific advancement and poor scientific costing. So you should take out a message. I request Oasis President to consider this appeal from network hospitals across Telangana and give a press statement through both this Tosa and Oasis together. We are advancing in science, but we are unable to practice and perform.
Sir, Oasis President also I called, sir.
Request Oasis President Vijay Channa to come. నేను కూడా నేర్చుకున్నాను, రావచ్చా? చేయలేకపోతున్నాం కానీ రావచ్చా?
Dr. Nanar Babu sir, senior president. Shirish, please come on to the... All seniors can come for the opening. Ravikant, come. Ashok sir. All of you, this is an opening ceremony of the Spine Surgeons Association. Everybody can come, all can come. Ready, everyone also. Are Srikant, please come. Come.
I request Dr. Ramkumar Reddy sir, Tosa president, to inaugurate the logo, ASST logo. I request Dr. VCS sir, president of Oasis, to inaugurate open the ASST conference brochure, please.
Good job, sir. Request PVSN Murthy sir to deliver his address.
సార్ మీరు వెళ్ళిపోతారా? మీరు మాట్లాడేస్తే వెళ్ళిపోండి. లేదు మాది కొంచెం ఉంటుంది. థ్యాంక్ యూ సార్.
5 గంటల వరకు కదా? 5 గంటల
10 minutes సార్.
కాదా? పోనీ మేము అంత అయిపోయినాక వస్తాం. మీరు ఇట్లా మురు
సార్ నెక్స్ట్ మీరు Welcome, Dr. Ramkumar Reddy, sir, President of Tosa, to give his valuable words.
Dear all, this is a great initiative from the orthopedic surgeons. So I have been looking for this for long years. Orthopedic surgeons, basically they are better surgeons than any other general surgeons, but we have been omitted the spine from long back because of the complexity or something. We are busy with the trauma surgeries and are already occupied with the trauma surgeries. Gradually, the other fraternities, they are taking over the spine. But at the end of the day, now the people are thinking that spine is a area of the neurosurgeons. So that is a common thinking. But we have to rise to the occasion and we will prove ourselves and will flourish as a spine surgeons. Any point of time, we better deal with the bones, the fixation methods or approaches. We will do better than anybody. But gradually, we have to improve our younger generations to rededicate them to spine surgeries. So when we are PGs, we used to see the surgeries done by our chiefs. But తర్వాత న్యూయర్ జనరేషన్ స్పైన్ అంటే మనది కాదు, మనము ఆ న్యూరో పంపిద్దాం, డిస్క్ ప్రోలప్స్ వచ్చినా ఫ్రాక్చర్ వచ్చినా కూడా రిఫర్ టు న్యూరో. ఈవెన్ ఈవెన్ హాస్పిటల్స్లో కూడా వెన్ పేషెంట్స్ కమ్ టు ద హాస్పిటల్, స్టార్టింగ్ ఫ్రమ్ ద వార్డ్ బాయ్, ఫ్రమ్ ద సిస్టర్, స్టాఫ్ నర్స్, ఈ స్పైన్ కేసు, హెడ్ ఇంజరీ కేసు న్యూరోని పంపించేసేయండి. సో వన్ కాంప్లెక్సిటీ ఈస్ most of the patients are polytrauma patients when spine involved. So a added component of neurosurgery will be there. As a legal point of view, you have to include them. So they are getting some advantage over us. Otherwise, we will do better than them. సో న్యూరోసర్జరీ వాళ్ళు ఉన్నప్పుడు చాలా మేము చిన్న హాస్పిటల్స్, మిడిల్ హాస్పిటల్స్ ఈ న్యూరోసర్జరీని ఇన్వాల్వ్ కంపల్సరీ చేయాల్సి వచ్చినప్పుడు దే ఆర్ ప్రపోగేటింగ్ దెమ్సెల్వ్స్ ఆర్ స్పైన్ సర్జన్స్. అట్లా పేషెంట్స్ గ్రాడ్యువల్గా పోతుంది. సో న్యూరోసర్జరీ రెస్ట్రిక్టెడ్ టు బ్రెయిన్ అనేది మనం చాలా సొసైటీ తీసుకెళ్ళిపోవాలి. సో వాట్ వర్క్ వీఆర్ డూయింగ్, యాక్చువల్లీ మన వాళ్ళు చాలామంది మంచి వర్క్ చేస్తున్నారు. దిస్ వర్క్ హ్యాస్ టు బి ప్రొజెక్టెడ్ ఇన్ టు ద సొసైటీ. కామన్ మెన్కి అర్థమయ్యే విధంగా మనం ఎక్స్ప్లెయిన్ చేయగలగాలి. అప్పుడే మనం మళ్ళీ వీ కెన్ గెట్ అవర్ ఓన్ స్పైన్ ఇంపార్టెన్స్.
Share.
రైట్, థ్యాంక్ యూ వెరీ మచ్.
Thank you, sir. Please, yes, sir.
Sir, Vijay Sindarav, sir, please come upstairs for a few kind words for ASST.
Yeah, good afternoon to all of you. At the outset, let me congratulate on the occasion of inauguration of the Association of Spine Surgeons of Telangana on the floor of Warangal. That's also on the dais of Tosa, Oasiscon. It's a proud moment, and also my best wishes. And Dr. Raghav is our student here. And when he was first year PG, I was internship. So we are closely associated. And as Dr. Ramkumar rightly said, spine is the domain of orthopedic surgeons. There is no second opinion, especially amongst the young orthopedic surgeons who are coming out, should remove that from their brains, that this is purview of the neurosurgeons. Never, never. You see, all the books, everything written by orthopedic surgeons, all the work initiated by orthopedic surgeons, all the research work in the spine was the work of our elders. Neurosurgeons, especially in the spines, only intradural, if at all. It's only intradural. When you open the dura, then only their role comes. Any extradural spine is the purview of the spine surgeons. More important is coming out of number of medical colleges in India. Number of young orthopedic surgeons are coming out. If you remove one entire big branch, where is survival for our young orthopedic surgeons? So please keep this in mind. Again, my best wishes to the ASST. Thank you very much.
Thank you, all the members. I think we are running late. Kindly do your presentations as early as possible.
Thank you. Sir, as rightly said by Dr. Ramkumar Reddy sir and VCR sir, actually, many of them think that neurosurgery, they refer to neurosurgery, but I always say to my patients or my colleagues, we are operating on the bone. The only intradural or intramedullary work is less than 1% of our cases. So even intradural also will do. Intramedullary, many times we try to push to neurosurgeons. So my topic is journey, need and unity of ASST. So, respected dignitaries, senior colleagues and dear friends, the growth of spine surgery in Telangana has been built over many years through the dedication, experience and teaching of senior orthopedic and spine surgeons. Many of us have had the privilege of learning from colleagues who generously share their knowledge, experience and surgical wisdom. Today, spine surgery is evolving rapidly with new technologies, new techniques. This is where I believe ASST has an important role. It can bring together experience and youth established expertise and new ideas. Clinical practice and academic research. ASST should become an association where senior surgeons should guide young surgeons, question and learn, and every member feels that he or she has something valuable to contribute. Our strength will come from unity, friendship, and willingness to share knowledge. We should create an environment where difficult cases can be discussed openly, experience can be shared freely, and young surgeons can find mentors. I also believe that an association becomes strong when different generations work together. Actually, we see three generations now. We had our seniors. We, as another generation, now we have some juniors also who are doing extremely good. We should preserve the experience of our seniors while creating opportunities for the next generation to develop and take profession forward. ASST should preserve the experience of our seniors while creating opportunities for the next generation. With the spirit of unity and friendship, I am confident that ASST will grow into a strong professional family and make meaningful contribution to spine surgery in Telangana. Thank you.
Next, I request Dr. Raju Iyengar sir to deliver his this thing on education and academic vision of this new organization.
So, thank you, Ramkumar sir. Thank you, VCR sir, for new society has been born under your this thing. So, in this pretext, I only tell one thing: seeing is believing. Seeing is believing. The minute you see, you start believing. What our postgraduates and what our junior colleagues are believing is spine is not my cup of tea. It is not my problem. But once you start seeing spine cases, when you start seeing them being operated and being well, then you also will come to know that yes, it is our fraternity, it is our own this thing. Because as Dr. Murthy was telling, that bone integrally belongs to orthopedic surgeons, so spine should be for only for restricted for orthopedic surgeons only. Intradural work, yes, I do agree with everybody that intradural work has to be taken care by specialized personnels. But when it comes to spine, when it comes to deformity, when it comes to trauma, when it comes to infection, none other than orthopedic surgeons are the better to take care of that. In this pretext, we at Nizams, we at ASST offer short-term observership, short-term fellowships under the academic purview of ASST, and then teach everybody, teach our general younger colleagues how to take care of a spine and spine problems. The strength of ASST will ultimately be measured by how much we learn, how much we impart by teaching, and how much we contribute to the next generation. In this regard, I request all my junior colleagues to approach to ASST
to observe spine, to observe or do some fellowships under the guidance of great mentors which we are having, and enrich yourself with this thing. And please, in this regard, please do attend our conference which is going to be held on September coming month, where you interact with our seniors. Thank you.
Thank you very much,
Long
sir.
live ASST.
Next, request research, collaboration and future. I request Dr. Bangar Swami to give his address.
Good afternoon, respected dignitaries, the senior colleagues and friends. First of all, I would like to thank the long waiting event which we were trying to inaugurate since very long time. Happened today at Tosakan 2026 in Warangal. I would like to take this opportunity to thank Dr. Ramkumar Reddy sir, President-elect Dr. Alwal Reddy sir, and Oasis President, our teacher mentor Dr. VCR sir. For the years very long back, since last 15 years, 16 years, even in any government institutions or even insurance companies, this spine surgeries officially being done by neurosurgeons. Very recently, the concept is changing that now slowly the part is changing towards orthopedic surgeons. And if you see most of the orthopedic surgeons in cities and in peripheries, they're confined to revision orthopedic surgeons, because many of the times we have seen many cases just a disc prolapse has been ended up in so dramatically disastrous and been repaired by orthopedic spine surgeons. It is our field. It is our putting screws into a bone is the right of an orthopedic surgeon. So this we have to propagate and create awareness, interest in our students, so that many more number of students come into this field. And my speech is on this collaboration and research. The next important pillar of ASST is research. Good clinical practice should continuously generate questions, and those questions should lead us towards evidence that can improve the way we treat our patients. We should encourage multicentric research, Telangana-based spine registry, collaborative publications, outcome studies, and evidence-based clinical pathways. If surgeons from different institutions work together, we can answer questions that are difficult for a single center to answer. ASST can provide the network through which surgeons can share ideas, collaborate responsibilities, and develop research that is relevant to our own patients and our own healthcare environment. At the same time, we should embrace innovation and new technologies while maintaining scientific discipline, ethical standards, and patient-centered care. Our ambition should be not only to adapt knowledge from around the world, but also create knowledge from Telangana and share it with the world. Collaboration with Tosa, ASSI, and Oasis and other academic organizations can create opportunities much larger than any individual institution. If we work together, Telangana can make a meaningful contribution to the wider spine surgery community. I look forward to see all of you in ASST, and it should become a platform where research, innovation, and collaboration become a regular part of our professional culture. Thank you so much. Thank you all.
Thank you, Bangar Swami sir. I request a video presentation. Assist cinematic video. So during this, I take the opportunity. During my PG days, my first seminar was on intravertebral disc prolapse. My first mentor after post-graduation was at Uday Clinic, and I worked with Raghav Dutt sir for 3 years. I learned even scoliotic surgery with him. But unfortunately, see this fate of situations going on, and young orthopedic surgeon then, as I was, couldn't practice spine. So it needs to beg into deeper thought for all of you for starting this. I congratulate you. Take it further forward and see that none who is interested in their PG days or post PG days would leave spine and practice general orthopedics. So just don't be centered around yourself. Coordinate with Oasis, Tosa, give a voice. Spine surgery you do, What is the payment you get from EHS and Arogyashri? Why don't you raise a voice? These are young questions of orthopedic surgeons across.
Delivering exceptional care to our patients.
I'll close down my.
Today, I am happy to announce that we all have come together to form the Association of Spine Surgeons of Telangana. Over the last 3.5 decades, spine surgeons have been delivering exceptional care to our patients in Telangana. Today, I am happy to announce that we all have come together to form the Association of Spine Surgeons of Telangana. Long live this association, a jewel in the crown of Orthopedic Associations of India.
ASST is created to unite spine surgeons across the Telangana and a common academic platform dedicated to education, innovation, collaboration, and excellence in patient care. We are mainly united for the global patient care, and we are planning to educate all the young spine surgeons. Thank you.
Considering the fact that spine specialty is being neglected in orthopedics, a lot of orthopedic surgeons who are like-minded, who are interested in spinal ailments, have formed this group called Association of Spine Surgeons of Telangana. And this is formed predominantly to further the interest of orthopedic surgeons who are interested into spine surgery and spine as a specialty on its own.
Hi, I am Dr. Devan. Welcome to Oasiscon. I have been the main program coordinator of the scientific committee, and we have scheduled a very good scientific program that includes invited lectures by the local faculty, national faculty, case presentations, as well as discussions, and also the advanced spine sessions. So I welcome you all to enjoy this extravaganza of the scientific program and learn the basics to the advances. Thank you.
I, Dr. Bangar Swami, on behalf of Telangana Orthopedic Surgeon Association, I congratulate all the orthopedic spine surgeons of Telangana to come together and form the Association of Spine Surgeons of Telangana. Their responsibility is not, closing at hospitals. Their responsibility coming beyond hospitals, and they are coming together to create awareness in preventive spine care and taking responsibility to, take preventive spine care in the nook and corner of Telangana. And once again, I congratulate all the ASST members and orthopedic spine surgeons of Telangana. I wish them all the best for the upcoming conference. Thank you so much.
The past 3 decades, we see there is a good increase in the spine awareness. And to add to it, we as a Telangana spine surgeons, we appreciate there is a good increase in training over the past 1.5 decades, that is around 15 years. Rather than technology, I appreciate there is a training which is more important than the technology. So we are here at ASST to increase the training for the spine surgeons, for the upcoming spine surgeons.
Spine is the foundation of movement, independence, and quality of life. These days, spine surgery is evolving rapidly with advances in minimally invasive endoscopy, deformity correction, and whatnot, navigation and robotics. So, our aim to create a society to include all spine surgeons and orthopedic surgeons on a common platform to learn from each other and to. So we have created a society called ASST, and we are conducting our first conference, ASST Con, and we warmly invite everybody to attend this. Thank you.
Hi, I'm Dr. Sridhar Reddy, inviting you all for ASST Con 2026. Hope we all have a good time together.
I request Suresh to give the vote of thanks.
Thank you, sir. Respected President Tosa, Dr. Hanamkonda Reddy sir, Secretary of Tosa, Dr. Jagannath Reddy sir, President-elect Tosa, Alwal Reddy sir, President of Oasis, Dr. VCR sir, and our respected senior colleagues, members of ASST, and my dear friends. It's my privilege and honor to propose the vote of thanks on this memorable occasion, the inauguration of Association of Spine Surgeons of Telangana, ASST. First and foremost, on behalf of ASST, I sincerely thank our respected TOSA President for his gracious presence and for supporting this important initiative. We are deeply honored to begin the journey of ASST under the blessings and guidance of the wider orthopedic fraternity of Telangana. I extend our heartfelt gratitude to the TOSA President, Secretary, TOSA President-elect, Oasis President for joining us today, encouraging us and sharing their valuable thoughts and blessings. I would like I would also like to thank all our senior spine surgeons and colleagues whose experience, encouragement, and support have helped make the formation of ASST possible. A special word of appreciation to Dr. A. Pawan Kumar, our secretary, Dr. P.V.S.N. Murthy, EC member, Dr. Raju Iyengar, sir, ex officio member, and Dr. Bangaraswamy, EC member, for their vision and commitment towards the establishing this association. We are also grateful to the Tosa Oasiscon organizing committee for providing us with a wonderful platform and for making this inauguration possible during the conference. Finally, I thank every spine surgeon and orthopedic colleague present here today. ASST belongs to all of us, and its success will depend on our collective participation, friendship, academic contribution, and commitment to the patient care. Today marks only the beginning. Let us work together to make ASST a strong platform for education, research, innovation, collaboration, and excellency in spine surgery. Once again, thank you all for being part of this historic beginning. One state, one spine community, and one mission. Thank you all.
Hello. Thank you, Suresh. It was a nice event for all of us too. What we thought 25 years back is happening now, at least, that we would go scientific and help youngsters. Thank you. Now let us go to the last session today in Hall A. This is Edge Essentials Beyond Orthopedics. And I think all spine surgeons need to know this too. There are going to be something which is very interesting. Okay, ठीक है. Now, may I now call upon the stage the moderators. I request Dr. D. Maheshwar sir to chair this session. I request Archana madam to be another chairperson in this session. May I now request Dr. Ashwin Reddy to start a thing that is very important to young doctors. Even it's essential for even for old doctors too. It isn't limited just to young ones. It is also interestedly required even in old doctors and old hospitals. Going to talk about a financial planning for young orthopedic surgeons. Thank you, Ashwin. Yes, sir. Where's the people?
never mind. Mr. Ashwin Reddy will speak on financial planning for young orthos.
Can you play from your end? Can you play from your end? Fine, sir. Fine. Correct.
I request all the young doctors to come forward. This is all for you. He's come all the way from such a distant place. Come here. Post it lunch nap it's better see you can have a nice fun in the evening in Varangal. So I request all of you to come forward. Be it the postgraduates or doctors.
Yes, sir.
Before he gets his loading done, I request all of you sitting here. If you are medical graduates, kindly come forward. Look, senior orthopedic surgeon Prasad sir is also sitting here. That patiently in the front rows, Doctor.
Yeah, sorry about that,
sitting.
everybody. Please give us 2 minutes. Just sorting it out.
No issues, no issues. That's why I'm trying to engage. No issues. Kumar sir is here, senior orthopedic surgeon. Mahesh sir is here. Our own Mahesh Anna.
Okay. Next sentence. Okay. Yeah. Can you go back to the starting slide? Andy? Yeah. Hi all. Good evening. Thank you so much. It's fantastic being here. Apologies for the small glitch. Let me start with something. Okay. Imagine you are a 35-year-old young doctor doing well. You have a 5-year-old kid and you're planning for his future. Or you are a doctor in his 50s, in his prime, in or her prime, doing well, and you're planning for your retirement. And you want to look at a corpus of 50 crores in the next 20 years. What do you, and you're able to grow your wealth at a healthy 17-18% from today. What do you think you need to start with? Can we have any guesses from the audience? So you need to reach, you want to make 50 crores in 20 years, growing your wealth at 17-18% per year. What do you need to start with today?
Scientific committee chairman, R chair le inchale.
Any guesses? No. Okay. Next. The answer is simple. 2 crores. 2 crores today is what you need to compound at 17 to 18% per year for the next 20 years to reach the magic number of 50 crores. You assume this number is a little high. You want to grow your wealth only at 15% per year. Okay, which is still a very good number. It'll only take you 23 years. This is the magic of compounding. So when you're starting with 2 crores, which by the way is probably a cost of a flat today in Hyderabad. All of you will agree with me today, given the costs where they are. So the compounding, the magic of compounding works like this. You start with 2 crores. In the first year, you're adding 35 lakhs to 2 crores. By the time you reach year 5, you're adding 67 lakhs because the base is increasing. Every year you stay put and you compound your money, the base keeps growing and the addition to your money keeps increasing. By the time you reach your 20th year, in 1 year alone, you're adding 7.5 crores to your corpus. This is what I say is the 8th wonder of the world. The only takeaway, if you want, from my talk today is this: understanding the power of compounding over long periods of time. Say if you take the same 2 crores and see what it will do at different percentage points. If you're going it at 7%, you'll end up at 7.7 crores in 20 years. 14% gets you to 27, 17% gets you to 46 crores. So this is the magic of compounding. Now it looks fairly simple. It is simple math, what we learned in our 3rd, 4th, 5th classes, like percentage increases. But why do people don't capitalize on it? Next, please. So what hurts this gift? So we just given some brief points as to what you should not be doing or why this does not happen in real life. Next slide, please. The first one, not having a plan. Okay, so right now, if you see for many people, investing or planning for the future is simply about buying something randomly and then just waiting for it and not having a plan. So our suggestion is to start somewhere, to have a goal in mind and work backwards. See, everything today, if you got to first think in terms of numbers. For example, okay, I'll just give you a simple example. People say, I bought a plot in Jubilee Hills 30 years back, I bought it for 15 lakhs, today it's at 15 crores. Fantastic investment, well done. You break into numbers. This is nothing but 16.6% per year, every year over 30 years. The magic here is because it was held for 30 years. It is not the percentage growth. So people assume that you have to make a lot of money very fast to reach a healthy sum. That is not correct. As a young doctor, the biggest advantage you have is that of time. Just make use of it. Plan early, have a plan and then like just stick to it. Next slide, please. Second, so what hurts this? While people have a plan, most people are not able to stick to it. The reason being, financial assets are inherently volatile. You cannot expect a straight line. There will be ups and downs. So whenever these things happen, people get shaken out and they sell. So understanding why you're investing, right? For example, investing in real estate. It is a play on urbanization of a city. You're investing in a financial asset like or in the equity markets. It is a play on a country's economy. So understanding why you hold something and not getting shaken out of your plan is the most important thing. Next slide, please. Then again, so this is among my favorites, right? So if you see today, almost, I mean, even lot of doctors I speak to as well, I am surprised again. People are investing, trading, they're doing FNO, which is the futures and options. So when I have conversations with people, right? So what the feedback that I get is you got to take a risk to make a return. My answer to that is, what is your edge? Any activity that you do, the question to ask is, what's your edge? So this is something that most people kind of don't understand, and they make short-term decisions. They make decisions where there are machines trading against them. For example, a US hedge fund made 40,000 crores in the Indian markets by betting against the FNO traders in India. So that is the power of the markets. So it's very important to understand what's your edge. Why am I investing in this asset? What is this asset about? What is the risk involved? Can we go ahead, please? Okay, in the interest of time, I'll just go a little more ahead. Next slide. Next slide. Okay, let me just stop here for a minute. All of you would have been sold some kind of a financial product, right? Be it an AIF, PMS, or something by bankers. You go to the bank, or your RM calls you, or your bank manager calls you, and he'll try to sell you some product. So the way to understand is simple. Everything is a financial asset packaged as a product. You need to understand what is underlying the product. Ultimately, they're all investing in some other asset. So all these mutual funds, PMS, AIF, it sounds complex. They have different characteristics, but they're all financial products. More important than this is what we have in the next slide, which is when you're evaluating a product, what is the question to ask? Very simple. Where does this product fit in for me? This AIF, this PMS, why is it relevant to me? Point number one. Number two, what is the edge? What is the edge that this fund manager has? Number three, how are the incentives aligned? Do they make money when I make money, or do they make money irrespective? Fourth, when I want to exit, what is the cost? So these four questions are what you have to remember when you evaluate any financial product. Next slide. Let me talk about us now. So again, my name is Ashwin Reddy. I run investment firm Samatva Investments. We are a PMS based out of Hyderabad. I have an MBA from ISB. I've worked in Bombay. I've been in equity markets for the last 20 years. So in a nutshell, I'll tell you what we do at Samatva. Can you just go to the next slide? So it's very simple. Okay, let me give an example. There is one hospital which is here, for example, in an area. The economics, the profitability of the hospital is X. Imagine 4 or 5 hospitals come right next to it. The economics will change, they'll come down. We've applied the same simple logic to investing. When most people want returns in the next 6 months, 1 year, we are saying we want returns in the next 5 years. So in this today's day and age, when people don't have patience, we've taken a stance that we don't want returns today. We want returns in 5 years from now. We pushed out our timelines. That has reduced the competition, enabled us to invest far better. And when we invest, we go and meet the managements, we talk to the ex-employees, we understand the company's culture. It's not about investing in a stock or a share price. It's about investing in a business. That's something which we started with on day one. It's now been 8.5, 9 years now at Samatva. God has been kind. We've done well so far. Next slide. This is like something about our returns, what we started. We started in 2017 November as an investment advisor. We moved to a PMS. So in the last almost 9 years to this November, we've grown our wealth 8.2 times in the last 9 years. In the interest of time, then I think I'm out of time. I'll leave it there. If you have any questions, I'm happy to take. And also, I'll just start I'll end with a little background about why this talk and all. Because when I came back from Bombay, when I started investing and meeting people, right, I realized professionals are the ones who have the least amount of time to invest on themselves. Work so hard, but then the key decisions which are made financially are made in a suboptimal manner. So our endeavor through this and through other platforms is to just showcase to people the mistakes they should avoid. Don't go after high growth. Just use your time to make your wealth. I'll be happy to take any questions if you want. And we have like a small We have like a small stand and we have some literature outside here. I'm happy to share anything. I'm happy to meet. I'll be around here if you want anything. Any questions, I'll be happy to take. So I think a question is there.
Sir, how do you suggest about SIP, sir? SIP for mutual funds.
Right.
There are a lot of things are coming up with the SIP. When I invest and on paper it shows 30% growth, 40% growth. When I want to withdraw, suddenly it goes negative. How to overcome, sir, and what is the best way to invest the SIP?
Sure. See, so SIP is a good product. Okay. And before that, okay, this is my view. So do think about it and go and back and research about it. So when you say a SIP, right, SIP is a fantastic product that the mutual fund industry has come out with, wherein it is encouraging people to save regularly, right? The mistake people do is in choosing the kind of mutual fund they should choose. For example, I've seen portfolios where people say, I have 2 small cap funds, 3 large cap funds, 3 mid cap funds. Now, effectively, each fund has 70, 80 stocks under it. So you're buying like 400 stocks. In the end, you'll make the same return as the market and nothing more at a portfolio level. So the mistake is to avoid that. When choose one mutual fund or choose one fund where you understand the philosophy and you understand the edge. The point is to know what is that fund's edge. That is the most important thing. And you must give it time. I think taking advantage of time is single most important thing which I can suggest for you. Choosing the right fund when you invest is when you should spend the most amount of time, because see, people spend more time after they invest. Okay, how do I withdraw? Why is the fee so high? Before withdrawing, see what is the exit load, when does it kick in, what has been the past track record, actual track record of the fund manager. So all these things are important before you invest, and then giving it time. So whatever money you need in the next 1-2 years, equity markets is not the best place to put it in. Equity markets is for your long-term growth, for your kids' education, or for your retirement, or these are the goals that equity markets can solve very, very effectively, because they are volatile and you are making the returns in exchange for volatility. So you have to remember that. If you need money in the next 1 year, I would not suggest equity markets at all. For us, for example, at Samatva, we only take money as clients who have a 5-year view. And because we are a SEBI-regulated entity, we have a certain minimum requirements in terms of 50 lakh, what we have to take and all that separate. But it's all about understanding why you're investing, where you're investing, what's your end goal. That is the most important.
On the stage.
Yeah,
Yes, sir. So when you said today a flat in Hyderabad costs 2 crores and you can make that 50 crores over a period of time, like 20 years. Then what if the market grows and a flat 20 years down the line costs 50 crores? What will the value of my 50 crores be then? Wouldn't we, like, what if inflation takes over the value of my investment?
Sure. See, the thing is this, okay, you must understand over long periods of time, the asset classes which appreciate, right? There have been typically been land and equities. They're both assets. So flats, once they're completed, typically they don't tend to appreciate as much, right? I mean, it is all about the land or the equities which appreciate. And why do they do it? Okay, land appreciates because cities urbanize. Employment comes in, people want to buy more properties, and people come in. They come from villages to towns to cities, right? That is the reason why land around cities appreciates. Number one. And why do equities grow? Equities are a call on a country's economy. If we have, for example, if you want to participate in the defense team, or say, for example, in the semiconductor team, we might not have much in Hyderabad. The way to play it is through a different asset class. So it's about having a balance linked to your own personality. What is your personality? What are your end goals? Because each has its own thing, right? So land, you can see it physically. That gives you the comfort. But what about the liquidity? And alternatively, the equity markets can be more volatile. Unless you have the mindset saying that I'm okay with the volatility, you'll not be able to take advantage of it. So you'll have to give it time. So it's all about having a portfolio, how much mix in that, what is your end goal, and what is your time frame. That matters the most.
Thank you, Mr. Ashwin Reddy. You have thrown a good light on financial planning for the young Arthos.
Great.
And definitely, we have got any queries, definitely we'll ask you later.
Sure.
Thank you for coming all the way from the place and giving a enlightening on this issue. Thank you.
Thank you, Ashwin. You came all the way from Hyderabad with a short notice, sir.
Great. Thank you so much.
Sure, sir.
Thank you. I appreciate the platform.
May I call upon Mr. Chandramohan, sir? He'll speak on a setting up of a new hospital.
There's a
Is
slight
there?
delay. Sir said he has requested Sri Lakshmi Narasimha.
Sir, may I call upon say Lakshmi Narasimha sir? Will speak on the medical legal issues. It's going to be in medical legal issues. If anybody grants any queries, please you can ask sir directly.
For all entrepreneurs, established hospitals, and others,
Welcome,
this is
sir.
going to be the real talk for all of us. Lots of us these days with hospitals and doctors coming into consumer forum and so many protection acts for us. I think sir will deliver being an advocate so much of information for us. Thank you very much, sir.
Sir, before I start, respected Chairman, office bearers and associations, distinguished senior orthopedic surgeons, permanent faculty, delegates, gentlemen.
Sir, mic.
Thank you very much.
Just the mic.
Thank you very much, sir. There is one. The doctor's job ends once a patient dies, and the lawyer's job begins after the patient dies. So this is a very common parlance in our thing. Not to make you discourage taking up this profession.
Only dying, sir. Otherwise, also now doctors are scared.
I agree with you, sir. So what is required is this Consumer Protection Act just come of late. I have been seeing a lot of stress amongst the doctors in spite of they taking reasonable care, whatever care that is possible that could be taken. Still, number of cases have been filed in different parts of the country. Now the compensation starts, let's say, from 50 lakhs to 20 crores. So the moment you see a lawyer's notice that a case has been filed against you in a state forum, that starts about minimum 10 crores. So this entire financial thing which my learned friend was just now giving a lecture will go for that. That also you should plan for that when you are starting a hospital. Make sure that you take an insurance policy also. That's very compulsory. What I want to say was, let's take an example of two surgeries which I have dealt with earlier, with the cases which I have dealt with earlier, long time back. There is one surgeon who have performed a knee operation. There's a lot of pain the patient had, and once that pain subsides, it takes some time. Another surgeon performed the same operation, but by mistake, he gave a small needle inside that particular bone. Now tell me, will the Lord treat them equally? Can any one of you please tell us? Raise your hands and tell me both are to be treated, because both the patients suffered the pain and both of them took a long time to recover. Now, how does the Lord treat each of them equally? Any suggestions from the audience? No.
Both would be different, sir.
Both exactly correct, sir. Both are different. In so far as the first case is concerned, the law will exempt the surgeon because he's taken possible care. But when it comes to the second part of it, then the surgeon is milked with the heavy compensation. So that's why I want to tell you, sir, these two are different. Now let's go to slide 2, sir. Now you see, this is the first case that came up in England that is called as a Bolam test. That happened way back in 1954. That's an English case where there are three things has to be established. The patient must establish three links. One is duty of care arising from the doctor, then patient relationship, and second, a breach of the required professional standard. The third one is causation. The breach must cause or materially contribute to the injury. Any other breach is not required. If any one link is absent, negligence is not established. A bad result is not by itself a proof of a bad doctor. This was the first case, what we call it's a Bolam test. Slide 3. Yeah. Now, what happened in the Bolam test was the English courts, we call it House of Lords, or it's called as a Privy Council. If any case goes from India to the England, it is called a Privy Council decides a case. If the case originates from England, it is called House of Lords. Like what we have got a Supreme Court here, they got those two types of courts. The first case came up in 1957. That's called as a Bolam test. That Bolam is the patient. He sued the Freeham Hospital Management Committee. In what it said was, the doctor act with ordinary skill and care of a reasonably competent practitioner professing the specialty? 1. 2. The law does not demand the highest possible expertise. Insists that every surgeon choose the same technique or guarantee for a cure. First, a recognized practice, a responsible course does not become negligent. Likewise, second is a reasonable judgment, a genuine and a reasonable clinical judgment is not converted into negligence. Third one is no hindsight. The decision must be judged by the knowledge, facilities, patient conditions, protocols reasonably available at the time. This was the first case that was decided in England. This was followed by a second test, what is called a Bolito test. We in India also we are almost following the same type of system of judgments. Now in this case, what happened was it's from Bolito versus City Hackney Health Authority. Now that a lot of people are starting private hospitals, kindly be careful that you maintain the entire documents if possible. If CCTV is possible, kindly preserve it. It is for your own purposes. Otherwise, you will end up in a lot of difficulties. Now, in so far as Bolito test is concerned, kindly go to slide 4, Babu. Excuse me. Kindly go to slide 4. For a Bolito test.
Next slide,
4.
please.
Next slide. All right, next slide. All right. Now, in this case, what happened was a medical opinion supporting the doctor's conduct is responsible, reasonable, and capable of withstanding logical analysis. These are the two things that is required. The court may therefore examine three things shown in the slides. One is whether the opinion rests on a reliable facts and contemporaneous records. Just now I've been seeing number of spinal surgeons giving the slides and all. Insofar as the slides are concerned, they should be preserved. Either they should be preserved by way of physical or by way of a digital. Because I have seen a number of, it was a very nice thing to see the spinal surgeons giving lots of MRIs, then what is we call as X-rays and all, showing the little differences and how it should be done. There was an element of discretion was there with the change. That is what I could understand. Whether we should go for an earlier one, whether we should go for a later one, or a later mean in the sense surgical one. That particular decision when you have taken, a surgeon has taken. Fortunately or unfortunately, if it ends up in a difficult fiasco, supposing if you had only waited for 8 months, that could have ended by a medicine is one such thing which I've seen. The second surgeon says, no, we'll take a small surgical aspect part of it. Let us do the surgical part of it so that it will be cured within a couple of months. Fortunately, unfortunately, both end up after 10 months. Now, in so far as the first surgeon is concerned, he escaped because he said, no, I followed only medical. There was nothing wrong with that. When it came to the second surgeon who took a decision where a discretion was involved, whether to go for a surgery or not to go for a surgery, that's exactly where the records should be proved. The record should be preserved and it should be shown to the court that this is the record, the discretion is mine. The surgeon is not blamed in that aspect. Provided the records are there, it will go before a committee of experts. The committee of experts will say ultimately what the surgeon did was correct. The decision is wrong or not is not a criteria. This is one aspect. This is what is called as a bolito.
Sir,
yes.
In this regard, can I ask you one question, sir? Here, sir.
Sir, I'll do one
from
thing.
the
On the dash.
On the dash.
Sir.
Sir, one surgeon, I think the patient went to a doctor, one surgeon.
Yes.
So he has done some surgery.
maybe it failed in the sense, maybe not resulted in a good outcome. Then he went to some other surgeon who said that it is, we are going to conduct one more surgery for this one.
Yes.
Then he is also done. Then it also went wrong.
Yes.
So it take, suppose this is a very common here. So the first one escapes, or if suppose the patient comes to the second person, how we say that, how we protected. So this happened only because of the failure in the first one. So you go and ask him. But legally, what it
That's why
stands?
I'm coming to that. Let us say that he went to a first surgeon. So he has got his own records to prove that he has taken a reasonable. What is expected is a reasonable care, not the best care. Kindly try to understand this. Nobody is best. Reasonably, this is what you have thought about it. Reasonably, the records prove that what you thought is correct and you have taken the surgical part of it. You are not blamed.
Very nice. Thank you, sir.
I am sure you people have understood. What the court requires is that you should give the best no. Reasonable care is what is required. Sometimes it may go wrong, sometimes it may be all right. For that, court is not concerned. So for example, take for example neurosurgery. Just now we have been seeing. It will end up in a paralysis to some people, or some people may have some other loss. Eyesight will be losing. So when they go to the court, the surgeon has to establish that these are the records I have got it. This is what there's a slight bulge in this particular, whatever the technical term I do not know. So I have to operate upon that. That is reasonable what I could have done it. The court will not find fault with the surgeon.
Along with our surgery records, we should produce even like a registry of our literature.
I'm coming to that, sir. In fact, just now I've been. These are the two things which you people will be aware of, but that's also there in the slides, sir. We call it a SOAP and SOAP plus. Is any orthopedic surgeon are aware of this? Have you ever heard of this acronym SOAP? S-O-A-P?
No, sir.
I'll come to that, sir.
Yeah.
I have got it down. These two papers I have prepared. I'll leave it with you. Whoever is.
We would love it, sir.
It will be very useful for a person who does surgery from a private hospital.
Sir.
Insofar as government hospitals are concerned, that has been exempted. So government doctors need not have to worry about something went wrong, so I'm going to be sued. That portion is not there.
Correct.
But the difficulty comes only with a private surgeon.
I was telling the moderator the same, sir. This talk would be more appropriate at a hospital.
Absolutely, I'm very grateful to you, sir. It's really my pleasure to be with you. I'll come to the SOAP a little bit later, sir.
Sir.
Then we'll go after the Bolito test. The one case came up before the Supreme Court in 2019. It is called as Maharaja, slide 4. Next slide. It is called as Maharaja Agrasen Hospital versus Master Rishabh Sharma and others. This was decided in 2019. There the Supreme Court has said that in terms of Boehm's test has been approved, but expert opinion must remain reasonable, responsible and defensible. This is what is required. Nothing more, nothing less. The practical lesson is to record. This is what important. Record findings, options considered. I have been seeing that slides. The important risks and why the selected treatment was reasonable to the patient. These are the 4 things the court will examine whether the doctor has gone through these things. Then we come to the other one, what is called as an go to slide 5. Next. Before Babu, kinda 6 kalu 5 పెట్టండి. Just before, yes. Consent. Now we go what is called as an informed consent. This is the informed consent means consent is a process of informing the patient. There are 3 things in fact. The record should show that the diagnosis, proposed procedure, material risks reasonable alternatives and patient's individual concerns are informed to the patient when he comes over there. You take a small piece of writing and write it in that. This is what has been given, this is what has been told, this is what are the material risks involved in this. Then
Does it need any audiovisual consent also, no, sir?
yes,
sir.
yes, you can. Now that the development of technical things are more, definitely yes, you can have an audio visual thing, you can have a CCTV thing, all those things you can preserve it. Now all are digitized, you can preserve it as many years as you want to. There is a limitation is there in so far as consumer courts are concerned. They should file any case within 1 year of whatever is happening. But nowadays that has been slowly diluted. Even after 2 years later also, when the complications come up, the patients will go and file, this is the result what happened 5 years ago. So there is a reason, but if we can preserve the digital, now there are a number of digital platforms are there who can take your thing and they preserve it for 20 years or 30 years. You need not have to preserve in your own hospital. Number of units have come up by preserving these things. Now you got, so, but please preserve it, please. For it may look very simple that that patient may not know English, patient may not know Telugu. So please ask, do you understand that? If he says no, నాకు తెలియదు, please tell me in Telugu. Please tell him in Telugu and see to it that it is completely preserved. The court, see what happened 2 years ago. Today nobody will know what happened except your record should prove, and the patient is there. Patient is not able to walk is the practical reality. What you have done, we don't have anything else to say. Therefore, what you have done is important. Please preserve it, whatever it is.
Sorry, in this particular regard,
yes,
non-MLC versus MLC. MLC case records, as per our TSMC and others are concerned, we need to preserve those records for a period of 5 years.
I agree, sir.
Whereas MLC records, as you said,
medical legal services.
Medical legal services needs to be preserved for 7 years.
Quite true, sir.
So after that, if I dispose of my old case sheets.
This is what I'm saying, sir. This is what I'm trying to bring to your lordship's, to your notice. The aftermath of a particular surgery will not be immediate. Take for example, just now since I've seen the neurosurgeons telling, any operation which is done today, the effect may come after 6 years. We do not know. But what is known is that patient is there. He is now he is not able to walk. What happened? Why is he not able to walk? Because you did the operation 6 years back. You should not have done that operation because other people will come back and say, then you produce a record. At that point of time, this is what was happened. This is the reasonable care I have taken to see the records. Within the 6 year, that patient might have met with another accident. That could also be the result of that, but they will not tell that.
No, what we are asking, as you said, rightly said.
7 years you have said so. Medical
after 7 years, so as you said, now digitalization, preserving of records is there, that's okay. But a physical copy of a case sheet, trying to preserve in the hospital for a lifelong system.
No, sir, not necessarily. Now,
the TSMC has given that you need to produce it within 5 years. After 5 years, I can as well, as a doctor, say, it was a non-medical case, I don't even have the records.
See, in view of the Information Technology Act which has come into existence, even electronic records are also admissible in evidence. You don't have to preserve a physical record. I was about to tell that.
Correct.
For 5 years or 10 years, you preserve them. Once it is digitized, then that digital is recognized under the Information Technology Act, which has come very recently, about 5 years or 6 years ago. That you are.
But now both the government acts are, what do you say, they're not crossing each other. They're opposing each other. This law says that I should preserve it only for 5 years. Now, the patient has filed a case 6 years later.
Correct.
I don't have the records, I have disposed it off as a hospital owner.
Therefore, you are taking a risk. This is what I'm trying to bring.
But that's the law that is there.
I understand, sir. There is a limitation of 5 years, I've agreed. But the limitation is a continuous limitation. For example, cause is continuous. Today, what happened, what operation you have done today, if the cause comes back after 7 years, it can come back, we do not know. This is what I'm telling you. Insofar as the court is concerned, the patient is in front of him who is unable to walk. His contention is that I have went to that hospital, he has done this particular operation. When you go back to the hospital and say, I don't have the records, then the court will take an inference against you. So try to produce, now that the digital, entire thing is digitized, you don't have to worry at all.
Correct.
You need not have to, there are number of associations have come, number of companies have come who preserve the records on your behalf. And they preserve it for 20 years or 25 years, makes no difference. So these are the new technologies that have come up. Now the SOAP which I am telling, compensation, that slide 6, kindly go to slide 6. Now, what is this is two important legal principles, sir, insofar as compensation is concerned. This was decided way back in 2024 by the Supreme Court. First principle is a Latin term that is called restitutio in integrum. That's the first principle. That is, restore the injured person. I have answered your question. Restore the injured person so far as money can to the position without the wrong. This is restitutio in integrum. This is a Latin term. The other one is called ex cultere, also answered your question. That is, the wrongdoer takes the victim as found. So as on the date when he is found, whatever is there will be the criteria insofar as the patient is concerned. Genuine vulnerability may enlarge the consequences. These are the two things which have answered your questions. Then the third one, kindly go to the next one. This is what I am calling as a SOAP. Slide 7.
Slide.
Next slide. This mostly this is used by the orthopedic surgeons. This is called SOAP. I am sure you must have done it, but perhaps the acronym might be different. S stands for subjective. O stands for objective. A for assessment. P for plan. This is what we have been discussing throughout in the morning session, which I could see. Although they are not able to put it in the legal form like this. Most of the orthopedic surgeons do this. Subjective. What is subjective? Subjective is what the patient reports. He comes and gives you a complaint. Sir, I got a headache. I got a spinal ache. I am not able to walk. Symptoms, history, concerns and priorities. This you write it in the case. We call it a case history, if I'm not mistaken.
Yes,
Case
sir.
history.
Yes.
Then we go what is called an objective. O is what you examine and verify. Examination, imaging, neurovascular findings and investigations. This is an objective method. Then we go to the third one is assessment. A is the diagnosis which a doctor does. Important differentials and clinical reasoning. The last one is P is for plan. What is to be now the treatment? I've just now in the spine, they're telling what treatment should I give. Plan is a treatment, medication, surgery where indicated, aftercare, rehabilitation, review and referral. Shortly put, this is called as SOAP in this acronym. After this, I have added one more thing as a last SOAP plus. In that will be useful in so far as the case laws are concerned. In case, always, those days are gone when patients used to come take a medicine and be grateful to the doctor. Nowadays, gratefulness is only half part of it. Something happens that gratefulness will become vengeance. Try to imagine this. Please
Fantastic, sir.
don't misunderstand me.
No,
Right,
that's
sir.
a
Right,
fact
sir.
that's happening, sir.
Because the moment I am cured, I am very grateful. Tomorrow something happens, my gratefulness becomes vengeance. This man did like this. This is why I am not able to walk. That becomes a vengeance. And that will carry on and on till the end. Good things will never remembered. Bad things are always remembered through the lifetime.
And propagated.
Absolutely correct. So the plus what I have added was these two things I'll give with you. So there's two. This SOAP procedure has got about 12 financial clinics in this one. Then why the plus what I have added was why this choice? Reason for treatment and reasonable alternative. Just now we have been discussing. Every time we will be discussing that what operation should we put it nails or should we stitch it or what should we do? That is the reason of treatment. Then the consent and safety, materials, risks, warnings, follow-ups and referral. These are the one addition which I have added to SOAP. so that it will be as a guidance to the doctors who are practicing on the private side. This I leave it with you, sir.
Sure, sure.
But whatever you want it, you can take it. Kindly go to slide 9, sir. This also I have shown it there, slide 9. Now we go to clears. No. Go to slide 8. 8. Now what is a clear? This is what is another acronym you should be able to. One is consent. First thing is you take the consent when it comes, specific patient centered. The other one is legible records, contemporaneous findings, reasoning and action. Whatever you record on that. E is for evidence. This is very important. Protocol or a record or reason to deviate. You just now were asking whether we can take it audio visual. This is what I says, or a record or reason to deviate. The third one is aftercare, warning signs, rehabilitation, review dates. Once a patient goes, you give him at some time, come after 2 months. It does not come after 2 months. You make a record, it did not come. That not coming within 2 months might have aggravated his problem. That he will not tell. Then the last one, the R is for referral. Escalate without avoidable delay, record communications. Then S is speak. Explain complications and next steps. Never alter the records. Don't try to alter the records. Strike it out, do something else. That gives a wrong impression that you are trying to alter the records. So this is what we have done this.
Could you tell a little more about this? What this referral is, sir?
Escalate without avoidable delays. A referral means, for example, you have come to a particular conclusion. Second opinion, which we call it, I don't know whether I'm sure in this.
We take second opinion.
Second opinion. That is what is called a referral one. So keep this in mind. See, this is what I have thought about it. Because amongst you also there are experts. You assign it to another expert and see what is the expert, his opinion is there. These are the records, these are the foundations which you have got it when a case comes before the court. So this is what I have done. I have made one judgment, but to be on the safe side, keeping patient's thing in view, I refer to a second opinion. There is nothing wrong in referring to a second opinion. Please write, no, don't be misunderstood because I am not able to do it, I'm asking the other person. No, I am able to do it, but I just wanted as a matter of a second opinion, is there any better opinion is there? That is always
safe.
Sometimes necessary also, because we will not know all the things. Correct. These are the records, you show it to the court. This is what I have referred to. Just now been seeing few slides that this could be done, this could not have been done. This clear, keep this in mind. Once the patient comes, keep this in mind. This is how I have framed those, I have given it to you. Practical slides. And the slides also kindly go to page 9 and 10 of the SOAP, slide 9. This is orthopedic clinical medical legal sheet, which I have just now passed on. It has got different varieties. This is a 2-page one. One is presenting complaint and injury history, assessment, reasoning and concern, comorbidities, medicines and allergies, examination and distal neurovascular findings, 4, 5, 6. Go to the next one, Babu. This is a 2-page one. Then procedure, aftercare and follow-up, the second page. Then final, I put it as a clears. This is what normally the orthopedic surgeon does, but nomenclature may vary. For this, I have added plus. Kindly go to the next slide. This orthopedic SOAP plus, this is what 2 pluses I have added to that SOAP.
Yes.
Sir, this is what is about the presentation part of it. So
Sir,
my humble request to all doctors, please do not be afraid to do a surgery. If it is necessary, it is necessary. Do not be afraid. Do not be nervous. If I do, something will happen. Please, our lives depend upon you. It's not the other way around. Not that your life depend upon us. It does happen sometimes, mistakes do happen, but please preserve the records. Maybe in 1 or 2 cases, surgeons might be supposing, please don't misunderstand me. If a surgeon is not in a mood to do an operation today for various reasons, maybe some problem, something is there, try to defer it for the next day. Don't do that while you are in stress, because something may go wrong, because it may take about 5 minutes or 10 minutes. 1 second is sufficient to make a small error. That will cost you a lot. So be stressful. Don't be stressful. Leave the stress. But do not be afraid of doing a surgery. If it is required, it's required. Only things, preserve these records. This will save all the surgeons or anybody who does it. Somebody goes to a court, I can't stop you from going to a court. It is your wish. If you go to the court, well, I have got my defense to prove. I don't have any malafidis against a person. I don't want that person should be...
Should die or something.
No, nothing.
That's right.
That's a good, very good point, sir. These days, because of Aragasya and all schemes have come, and because of the, like a competition and everything.
Absolutely.
Now the patients are, they are completely pressing upon the
Totally.
that.
Totally.
So suppose if you do this surgery today, I'll be here. Otherwise, I'll go down. Because of anything, most of the surgeons are under stress.
Absolutely, sir. As much as the patient is, patient's job, as I've told you, the moment surgery is over, patient is gone. But tomorrow, patients will come back with a vengeance, because some patients believe what his servant maid gives him. Are itla kadandi, if you had only gone to my surgeon, you would have done it. So these are all the things they create a vengeance. Out of the vengeance come the cases mostly. So please don't be afraid of that. Do your job, but please maintain a record. Physical record, if possible, but definitely a digital. Now all are digitalized. So it all requires hardly a disk, maybe 1 MB disk, 2 MB, depending upon whatever is your capacity. Please maintain it. With this, sir, I am very grateful.
That's a very good point, and we are most of the times young surgeons and we are afraid and deferring the case, because as you said, it giving a very good like a courage for us.
Absolutely, sir.
So we have to go for the surgery, but tell to the patient that given a good consent,
yes, sir.
Maintain a good records for you, and we are very these days the difference between the medical legal case and this case. So patient is coming to our casualty because of an orthopedics.
Yes, sir.
So he'll having sustained some injury. He says that I fell down there.
Yes.
So after some time, after 1 or 2 days after the surgery, they are coming and directly going to the police station,
yes,
and they are giving a complaint there, sir. Then from the station, the fellow is coming here, station house officer, they are coming for this. No, this is a beaten up case, this is a road traffic accident. Why didn't you make this a MLC case? Then we are forced to give it to that one. If he says the same thing in the casualty, then my discretion comes. Then very small case, should I take it or not, that one. Then how to go? What
Sir,
is the bailout?
I'll tell you one thing.
Yes, sir.
You are a doctor first. The moment a patient comes to you, you don't know whether this is a medical case. Now what happened? This fellow did take a stab wound for that matter. Somebody comes with a stab wound. You say, no, this is a stab wound. You first go to the police station, give the complaint in the police station, then come to us. Don't be afraid of that. You just take that, do the record. When the man comes, there was a stab wound is there. I have treated him. And then if you require, you just, this is the record. Even the police comes to you, also tell them, this is what I have done. This is my job to do it. Don't be afraid. They may come, no, you should have told us. Ours is a medical legal case. Medical legal case is only with regard to a case, not with regard to a patient. Patient dies. You can't wait until the police will come, record something, and then only I'll start my treatment. Please don't do like that. And don't be afraid of that also.
It's clear to all this.
There is one more situation here, sir. The hospitals, what a patient comes in an emergency.
Sir.
More so it happens with OBGY. Obstetrics and gynecology.
Obstetrics and gynecology, yes.
Patient is in labor or acute this thing.
Yes.
The doctor doesn't find time to record and a mishap happens.
Sir.
So by the time this thing happens, a station officer, 1 minute, comes to the hospital and asks the doctors for records. And what is happening is we are supposed to produce a record. Now something has happened, mishap has happened with the patient. I have tried to save, but patient finally collapsed.
Yeah, no difficulties. I got your point.
And what's happening is once this incident occurs, the doctor should write the notes or treat the patient.
I was about to tell that, sir. In that soap, the moment a patient comes to you, you have given the date and the time. Let's say 9:15 p.m. the patient has come. Immediately you have seen what is what. Your first job is to attend to the patient.
Right.
Supposing any mishap happens, come back here and write the notes. This is what has happened. Simultaneously, it's not possible. You can't write, you can't do the patient and start writing. It's not possible.
That's what is happening.
No,
Now,
sir.
once a
No.
patient dies,
No.
there is a big mob in the hospital.
Yes, sir. Yes, sir.
So
Yes, sir.
for me, it is the time either to react to that person or to
Sir.
write my notes.
First, attend to the patient.
Patient is gone now.
That particular sheet will protect you. Once the patient dies, let's on the table the patient dies sometimes while performing an operation for due to some other complication the patient dies. He comes to you, the lady comes to you with a stomach pain, but her heart collapses.
Correct.
Immediately you take the timings and after it is over you write it down. It is not there cannot be a simultaneous thing. Some time will be taken. Yes, you have to recollect, close your eyes, find out what was the patient and then start writing. Because the court will not blame you for writing. There is no malafide intent. Malafide means you don't have anything against the patient.
Correct.
What has happened, this is what I have written. Even if, assuming for a minute, the other person asks, why did you not write it immediately? Make your head high and say, I'll attend to the patient first. After the patient happened only, I started writing. Maybe 5 minutes, 10 minutes would be the delay. That does not mean I have scribbled the records. No, this is what happened. Then you are not negligent.
Thank you, sir.
Thank you, sir.
Sir, any questions from the audience, sir?
Now, any questions from the students, persons who are going to start hospitals?
It's too early for them, sir. They have to get trained after this post-graduation, this training here. They have to be treated and trained elsewhere.
Very well.
Run the hospital and treat patients.
Anything?
All this while they are safe in government sector or a private medical college and stuff.
Yes, yes. Any questions, ma?
Sir, thank you for this. Actually, we wanted to keep this in a Thana conference, that hospital associations and nursing hospitals. That conference should be different. That's we are going to.
What I'm saying
There
is,
we want to invite you for a complete session, sir.
it's my pleasure. I am at your service.
Thank you, sir.
Sir, you are a doctor. Whether you are a government doctor or a private doctor doesn't make any difference.
Post your slides, sir, so that we will mark your name and number.
Yes, sir.
Because you are the most required for orthopedic profession.
Sir,
People like you.
God forbid it doesn't happen like that.
No, sir, it is not practical. It is going to happen. Every doctor who works more has more problems.
I agree with you.
One more question from the senior surgeon, Dr. P.N. Prasad.
Sir,
tell me, sir.
Actually, you might have heard about the recent POXO case in Khammam.
Yes.
The baby came to me first. And she told me that her
Baby, what age, sir?
age around 10 years.
You have noted it down?
No, she came to me and we have taken the x-rays. This is multiple fractures. And so I could not handle that. And I immediately referred. And they went out. And they landed in some other hospital and then they treated from there. But now they are asking me for
Compensation.
no, not compensation. Patient haven't come to me, but the lawyers and police are asking me for the evidence or something like.
What evidence? You have said that this is particular case requires a different type of treatment.
Yeah.
In this hospital, it is not possible. With you, it is not possible. Therefore, I have referred it to XYZ hospital.
That's all.
There ends the matter.
There ends the matter.
Absolutely right. You have not done nothing.
Nothing.
Absolutely. There is nothing wrong in that. Whatever you have seen her from physical examination, you have recorded and given it off them. That the girl is about 10 years. She came to me at 2:15 or 4:15. I have examined like this. This is my prognosis or diagnosis.
I have not written anything.
Very well, sir.
Except taken x-rays and seen multiple fractures and the baby is in a bad condition. Referred to higher center.
This is why I said there is no record with you.
There is no record.
That is why I gave that soap record to you just now.
Except for the
Please keep the
X-rays.
record. This is what I'm saying, sir. Kindly keep a record, even if it's for 1 minute. The moment a patient comes to you,
But when I referred, I didn't have the other particulars or anything.
no
They-
X-rays and all you have got it, no.
They said that it is not a. I didn't know at that time even it is a POXO case. Parents told me that she fell down from a building.
Yes.
Polytrauma.
Yes.
That's all.
Sir,
And
this is what I'm
afterwards
saying.
it proved to be POXO
See,
case.
your job as a doctor is to see whether there are any broken bones.
Yeah.
How it happened is not your job,
Yes.
right?
Yeah.
Supposing if it is a murder, then the angle of a knife will show whether it is protruding from upside or whether it's sideways. Or, that is what you are going to record. You will not record whether it is a suicide. You will not record whether it is a homicide. It is not your job. The patient came to you, let's say 9:15. Take a small piece of paper. It doesn't cost you much. Or ask one of your assistant to do that. 9:15, the patient came. My age, according to me, she must be 10 years. Otherwise, she said it is 10 years. These are the X-rays I have taken. These are the X-rays and this is the sheet. Matter ends there. Please, even if it is 1 minute also.
Okay.
Kindly,
Thank you.
this is very, very important. At least from now onwards, at least you keep this in mind.
So if you interested, this is a very interesting topic, sir. I think it is never ending, and we request you to come and occupy the chair for a small felicitation
Felicitation from
for
our
all the
organizing
members.
committee. Thank you, sir. Thank you.
Thank you very much, sir.
I'm grateful, sir. It's my pleasure, sir, and very grateful, sir.
Music, stop. Stop the music.
And nice sessions we had so far. All good things we start would come to an end. Maybe too late post lunch on day 3. Yet we have giants here, and we are going to have the general body session of Tosa now. And I request Tosa Secretary Jaganmohan sir to take over.
Thank you, sir. Sir, so we'll start the general body meeting of TOSA. So please, those who are not a member of Telangana Orthopedic Association can leave the hall. Rest all the
Next, we have Dr. Saida Saba. She has completed hand, wrist, and microsurgery fellowship under myself, Dr. Gopinath Bandari, Apollo Hospital, Jubilee Hills. Dr. Mohit Reddy has completed the fellowship hip and knee arthroplasty under Dr. Akhil Dadi at Srikara Hospital. Thank you. Dr. Kunna Bharat Raja, he has completed spine surgery fellowship under Dr. Suresh Chikatla at KIMS Hospital. Next, we have Dr. Fatima Heba. She did her pediatric ortho fellowship under Dr. Vidyasagar Chandrakere at KIMS Sunshine Hospital. Fatima Heba. Next, we have Dr. Hassan Rafiq. He has done his shoulder fellowship under Dr. Kaushik Reddy at Apollo Jubilee Hills. Next, we have Dr. Syed Salar Ahmad, who has done his orthopedic trauma specialty fellowship under Dr. Srinivas Kasha at KIMS Hospital, Secunderabad. Congratulations to all the fellowship awardees, and next round of fellowships will be awarded, announced soon.
So this year, the TOSA Consensus Gold Medal goes to Dr. Rajiv Reddy from Memorial Hospital, Hyderabad. And the TOSA medal poster, Apollo, na? Okay, Apollo, okay. Sorry, is Rajiv Reddy from Apollo Hospital, Hyderabad. And TOSA medal poster awarded to the Dr. Sana Begum from KMC. They will be, and TOSA quiz winners, Dr. Abu Obedur Rahman and Dr. Uzma Khan from Usmania Medical College. And first runner-up, Dr. Khatir, Dr. Bhavish from Tejashwini Hospital. Second runner-up, Dr. Gnaneshwari and Dr. Prasanna from KMC. So these will be awarded in the next upcoming conference. Thank you.
Sir, may I request Dr. Ramkumar Reddy, sir, Organizing Secretary, to please give a brief about this TOSACON and Oasiscon 2026, sir.
Now we can safely say this is Tosa Khan. Oasiscon అయిపోయింది. Oasiscon. Sir, మీరు Oasiscon member. Okay, this is the valedictory function of the Tosa Khan and Oasiscon, Tosa Oasiscon 2026. Thank you very much for all the delegates who are coming all the way from the different states and coming to this and making this organization very colorful and active. Many speakers came from different states and also from different areas, and they given an excellent scientific content for the delegates. And many of delegates personally appreciated me. The content was good, and also the arrangements were also they are comfortable. But this has to be heard from you people. If any delegates if able to or if able to express their feelings about this conference, I am very much happy to hear, and we'll make that to improve ourselves in the future. Other than from the Department of Athletics and OSA, we can anybody. మైకేనే సార్కి అంటే వరంగల్ కాకుండా వేరే ఎవరైనా చెప్పొచ్చు. So this conference has been conducted by the Department of Orthopedics, Kakatiya Medical College and Warangal Orthopedic Surgeons Association. They combinedly hosted the program. Thank you. Timmareddy sir.
Yeah. Congratulations to the Tosa Khan team and Oasiscon team. I think he proved again this should be the feather in the crown of Warangal again. And I congratulate Vijay Chandra sir and Ramkumar sir. As usual, they are done well. Good job. And the entire team and the scientific chairman Mahesh and Rakesh sir on stage always. And the team Warangal Orthopedic Association and Sudhir is there. And I think this is nothing surprise actually. Anyhow, Warangal will done better. That is the assumption what we have. So, but this time venue is good because of venue and all our arrangements. It looks like 5-star appearance has come, and now everybody is comfortable. And food is excellent, of course. And this scientific content also good, and everybody is happy with what I feel. And I had feedback also. So congratulations to the Tosa team again, Ramkumar and President-elect Alwal Reddy sir earlier, and Secretary and other members. And for arrangements of the accommodation and the all, Shravan, I thank you for all smooth going of the conference.
Murthy sir.
GVS Murthy sir.
Okay.
I think whoever is there, we can give a standing ovation to them. That's all. That's all. I think.
Thank you sir. Prasad sir.
PNVS Professor.
PNVC.
It's a very
very successful meet, and I congratulate all the team members, everyone, and please visit midterm conference also in a good number. I predict more number of people to attend. Come on. Thank you.
So, young orthopedic surgeon Syed sir, your feedback.
I forgotten one most important thing, and I congratulate my department also. Earlier, I am with you. Congratulations to Department of Orthopedics. I think they work very hard, our postgraduates.
I will note them in the vote of thanks. నాకు ఛాన్స్ ఇవ్వండి.
Okay, fine.
Okay. Wonderful conferences. Actually, two conferences coming together and doing is very difficult nowadays. And you have conducted both the conference at a time very well. And we must give all the credit to Warangal Orthopedic Association.
Thank you sir. Thank you very much.
And Department of Orthopedics, and also Tosa also.
Yes sir.
Thank you, sir. Syed. So, medal. Yeah, you want to say?
Thank you, sir. Wonderfully conducted conference. Just I wanted to stress on this point, like uh, why we young people want to join TOSA. Like many of them don't know the benefits of it. Like as Gopi sir said, fellowship is a very big opportunity to make the young orthopedic consultants join TOSA. So people should be made to know what is the benefits that they are getting out of the association. So that point should be stressed so that more and more new orthopedic surgeons join this association so that their voices can be heard and we can grow as an orthopedic fraternity. Thank you, sir.
Thank you. Thank
Good,
you.
good input.
So you
Thank you.
also should encourage your colleagues and your friends to join TOSA.
Any good association needs more primary members. So, like that, TOSA and also IOA also, IOA membership from Telangana.
Yes, sir.
I think we have to uh, think about that in easy meetings and also I think we have to involve every HOD, head of the department of all private and government medical college, including professors, so that they will encourage the second year and likely final year PGs so that to become associate members. Once they become associate members, it is easy to convert into full members. Later on, they will become IOA members. Thank you.
Great, sir. So thank you all, sir. Medal change.
Exchange of medal.
Yeah, exchange of medal. Medal. Yes, sir. Yes. Yes, sir. Sir, the president, the current president of TOSA, organizing secretary of TOSACon 2026, is giving the medallion to the president-elect to Dr. Alwal Reddy, sir.
Before Dr. Ram Kumar Reddy gives over his president's medallion to Dr. Alwal Reddy, I request the audience to applaud the work done by our president, Dr. Ram Kumar, for all the last year. He was active and involved, took the responsibility of organizing secretary also. Such a mammoth conference of both Oasiscon and the TOSACon together. He satisfied the Oasis office bearers, TOSA office bearers, and clubbing together is not that simple, but still he could able to make a success. Thank you very much once again. Now it's time. Please exchange the medallion.
Thank you, sir. Alwal Reddy, sir, as president, new president, address by new president.
Good evening to all. Thank you, everybody, all the orthopedic community of Telangana for bestowing me this great responsibility on me to do the president post for 1 year. I hope it will be 9 months, and I'll try to justify myself, and I will live up to your expectations, and I'll try to do a good membership drive. I will increase the membership. That's the most important, as Dr. Srinivas Reddy sir has told, because the organization should thrive only on the memberships. That I'll definitely concentrate. And my thinking will be from basics to uh, advanced. Like basics to today, we are having all uh, latest technology, advanced technology. Basically, I will be concentrating. I will be always consider basics and next to the learning without forgetting the basics and up to the advanced. That will be my concept. So we'll try to live up to your expectations. Thanks for giving me this opportunity. Yeah, we'll try to. Yeah, we are already you have reduced 6 months. At least 6 times I will go. Definitely, you will be helping me all the time. Sir, thank you, one and all.
Vote of thanks, bhai.
Vote-
Yeah. Jagan. Vote of thanks, bhai.
So basically, from basics to robotics, that will be my thinking.
Very good.
Thank you, sir. Now we have a last vote of thanks by our dynamic organizing secretary, immediate past president, Dr. Ramkumar Reddy, sir.
Thank you, sir. It is my privilege to express my gratitude and vote of thanks to everybody. First of all, I express my heartfelt gratitude to all the guests on the dais and also all the delegates who come from various states and all the associations of Oasis, WhatsApp, KOA Karnataka, KOA Kerala, POA Pondicherry, and my Tosa and my own WOSA and Department of Mathematics. I express my heartfelt gratitude for the organizing committee team and Dr. Bijendra sir, Kali Prasad, and Koteshwara sir, J. Venkateshwara sir, my friend, V. Ashok, Dr. T. V. Rao sir, Nagendra Babu sir, Radha Krishna, Dr. Tirupati Reddy, X. Lakshmirana, Virajesh, and Dr. Sudhir, Dr. Shravan, Sudan, and more, notably the scientific chairman, Dr. Maheshwar. Very hard work, and he has tried almost 2 months continuously for setting up the program. Very excellent academic program. Dr. N. Srinivas Reddy, Dr. Prasad Reddy, Dr. V. Rajesh, and Dr. Venkata Ritish, Dr. Dayasagar Reddy, Uttam Vaidya, Karthik Reddy, and Rajender, Dr. Abhiram, and Sukesh Reddy, Ranadir, Sudhir Kancharla, Mahesh, and I express my gratitude and thanks to Dr. P. Sudhir Kumar, who taken the charge of the trades and stalls and the food. At the same time, the banquet, Dr. Sudhir Kumar, Koner Rao, Naveen, Raju Rayapuram, Sai Charan Reddy, Hisham Ali, and Vital Krishna. I express my gratitude to Dr. Sirish S., who taken the responsibility of the registration, Dr. Ram Mohan, Dr. Vishwanath Nayak, Chandrasekhar, Sudhir, and Dr. Yakub, Gautam Chauhan, Nitin Chandra Reddy. I express my gratitude for my friend Dr. J. Venkateshwarlu of the reception committee and Dr. G. Krishnamurthy, Dr. Kranti Kumar, Dr. Kishore Kumar, Dr. Pattabhiramaya, and Pradeep Kumar. And the food committee, Dr. Mahendra Reddy, Dr. Venkadaswamy, Prakash, Viren, Ambati Ajay, and G. Anurag, Mukka Naveen, Sudhir. The transport accommodation made by my friend Banna Kiran Kumar and Sripal, Rakesh Ajmira, Dr. Minimula Srikant, and B. Srinivas. Spouse and sightseeing by Gannu Vijay and P. Archana, Krishnakant, Lakshman, Naveen Kumar, and Bichandana. Cultural taken over by the Dr. V. Suresh, Dr. Ravi Kiran, Dr. Surendra Reddy, Srinivasamurthy, Venkat Lakawat, Chandu Nayak, and Avinash. One more personality who strived very much is the Souvenir Committee member, the Kishore Kumar, Srivan, Keshav Rao, Srinivas Samarth Reddy, Rajit, and Mementos, Ram Mohan, Santosh Srikant, Shantan, Jay Prakash, Srinivas Chandra. So these are all committee members. I help thanks, and I express my gratitude for all the judges who taken the pain to select the medal papers today, and all the chairmen who came to the chair and they run the sessions perfectly on time, and also the members and trade and sponsors, but whom which nobody is there. So next person. By name, they will be remembered, and the Kuda administration of the Kaloji people, the sanitation people, the staff, electricians, technical staff, caterers, the security staff, and volunteers, my own postgraduates. They have done an excellent job, and they have done up to the end, day and night. Almost they work for almost for months, I think. So everybody has all the postgraduates. Come on here, come here, all of you, please come. All the organizing committee members, I please come to the stage for a group photo, please. All of you, all Varangal and Department of Mathematics, please come to the stage for a group photo. And UG students also, many of there. And one more important person, so I express my thanks to the audio visuals and Yogi and team, Ramu here, some of them Yogi, and one more important person is our Mr. Verma, Sunil Verma. Then they have done an excellent job. You might be observed, this event has been done without any event manager. So this is good. All the people made this with our local people only. So we can conduct this much of conference without any help of the event manager, so that we can reduce some price because of the finances have been little less. We have people, involved people, but they worked very well and also on par with any other conferences. They have done very excellent technical job. I congratulate all audiovisual people, Mr. Yogi and Mr. Sunil Verma for helping me out this conference. Thank you very much. Thank you everybody. If anybody I missed, it is not intentional, and kindly forgive me for any omitting. Thank you very much. Thank you all. Vishnu Priya. Vishnu Priya last year
Best Poster Award.
Best Poster Award. She came, I think.
Vishnu Priya.
Please come onto the stage to receive a medal. She is there.
Yeah,
Please come. We'll give the new president.
Hi. Proper one later. Thank you. Congratulations. Congrats.
ఫోటోగ్రఫర్ ఈజ్ రిక్వెస్టింగ్ వాడికి కవర్ అవ్వట్లేదంట, కొందరు ఇటు వచ్చి ముందు కూర్చోండి అని అప్పటి నుంచి చెప్పడానికి ట్రై చేస్తున్నాడు. Try to make yourself visible in the photo nicely. So come front. Pona. అందరు హిప్పీ పూరే చెప్పండి. రామ్ కుమార్ రెడ్డి సార్ హిప్పీ పూరే చెప్పండి అందరు కలిసి ఒకేసారి. బోత్ లో ఎనర్జీ, సార్ ఇస్ డ్రైన్డ్ అవుట్ ఆఫ్ ఎనర్జీ.